हेलो हेलो। हाँ, हेलो चेक टेस्ट। हाँ।
Yeah, okay. Audio is okay.
हेलो दिनेश सर।
Yes, बोलो।
आ रहा है? नहीं, वही चेक करना था टीवी का ऑडियो, तो वहां से कोई
Okay,
बोलते
done.
थे तो।
Thank you, thank you. अभी आवाज आ रहा है?
आ रहा है, ओके।
Thank you, बस।
Hello.
Yeah,
Hello.
hello.
Dinesh, is this Mr. Dinesh?
Yes, ma'am. Hi, good morning.
Yeah, good morning. I am Dr. Verti here. So let us know when to start because the patient has been induced.
Okay, ma'am. Just Dr. Ganesh sir going to tell, ma'am.
Hello. Yeah,
Hello.
good morning. Ganesh here from Sun Pharma.
Yes.
Madam, we will start at 9 o'clock with the introduction. So it will take around 10-15 minutes for a brief introduction initially.
10-15 minutes. Okay.
And our SB head. And then we can start the surgery.
Okay. ठीक है.
Yes, madam.
Huh? A very good morning to all of you. I'm Dr. Purva Artham. I feel privileged to extend you a very warm welcome on behalf of Royal Pearl Skull-Base Institute in association with AOI Hyderabad, supported by Sun Pharma Maxim Division, who has clubbed all of us together for this mega hybrid live surgical workshop. For the next 2 days, we have with us the perfect amalgamation of surgical procedures and discussions, which will help all of us gathered here to explore and expand the horizons of knowledge in the field of ENT. I would like to extend a gracious welcome to our esteemed guests and delegates who have joined us from different parts of the country to our historically rich city of Hyderabad, a city known for its pearls and palaces, is now reinventing itself as an entrepreneurial capital and medical hub of India. May I request Mr. Amit Shukla, SBU Head Maxim Division, Sun Pharma, for his opening remarks on this workshop.
Thank you, Dr. Purva. A very pleasant good morning to all the respected faculties, delegates, and the PG students who are attending this unique live workshop being conducted under the banner of Elite ENT Club of India by some of the renowned and skilled ENT surgeons. I am Amit Shukla, SBU Head of Maxim Division of Sun Pharma. Thank you, sir. Thank you for being with us today. We extend a very warm welcome to everyone on behalf of my team. I sincerely thank and acknowledge each one of you who have decided to take out their precious time for attending this scientific event. I am sure that this workshop would have different identity altogether, and the kind of surgeons who are performing the typical surgeries today and tomorrow would definitely be going to add immense value in addition to knowledge, understanding, which will definitely going to help in your day-to-day practice. We are very, very fortunate that we could get a panel which includes key experts and renowned ENT surgeons across India, in which each of them is going to perform and demonstrate a unique surgery with the latest techniques. I would like to give my special thanks to Padam Shri Dr. Milind Kirtane sir, Dr. Janki Raman sir, Dr. Sudarshan Reddy sir, who is the President AOI Hyderabad branch, for conceptualizing these scientific initiatives. I would also like to thank from the bottom of my heart to Dr. Deepak Haldipur sir, Dr. Madam Nupur Nirulkar Madam, Dr. Pratmesh Pai sir, Dr. Madhuri Mehta ma'am, and Dr. Sangeeta Verdi for being a vital part of this live workshop and accepting our request for as a faculty member. I'm sure that these 2 days live workshop is going to set a new unprecedented standard and benchmark of its kind. Sun Pharma has always been pioneer of various such scientific initiatives and try to add value in healthcare sector. We at Maxim Division has done these initiatives for the first time, and this is going to be continued in every year. We are going to assure you that we will try our best to improvise each and everything basis on the feedback of each one of you. So without taking much of your time, I would like to start the proceedings, and for this, I would like to hand over the session to Dr. Purva again. So over to Dr. Purva. Thank you very much to each one of you.
Thank you, sir. Now I would like to hand over the mic to Dr. Archana Karalke, Senior Manager, Medical Affairs and Clinical Research, for her introduction of Dr. Janaki Ram, sir.
Good morning, all the respected doctors in this workshop who are virtually attending this event and actually physically here to enjoy this scientific feast today with all the experts in the industry. Today, it's my privilege to welcome one of the versatile, dynamic, passionate, world-class renowned surgeon who is a ranker himself throughout, but he feels proud that he is fortunate enough to get trainings and teachings from Kirtane sir. He is inviting operating faculty in various national and international master classes and workshop, but still he is attached to his roots. And that is really appreciating fact. He has multiple activities daily he's doing medical education, free camps, free online trainings, YouTube channel like ENT Encyclopedia, free online platform trainings also he's doing, along with his surgeries and the artistic side of him, we will explore in the evening also. He's expert in various surgeries and procedures, we all know, but I will like to mention one fact that he's an international pioneer in endoscopic management of extensive sinonasal and endonasal and extensive sinonasal and skull-based tumors. He has numerous honors and awards in his kitty. Just to mention the recent one, which is really a special award, Best Teachers in Rhinology Award in 17th Otolaryngology International Conference in Dubai, held in March 2022, and really want to congratulate Sir for this award. Very humble, full of energy, and we will be experiencing that full of energy today to welcome none other than Dr. Narayanan Jankiram. We all call him Dr. Janki with lot of love. Sir, request you to take over this dais, and I welcome you and your team for this ENT club workshop, and we will be experiencing the energy and enthusiasm today from you. Thank you, all of you. Please, sir. It's my honor, sir, to welcome a humble person like you. Please.
Thank you for your very nice words, Dr. Archana. A very good morning to all of you, brothers and sisters of ENT. I'm really delighted to meet all of you after a devastating COVID, which actually separated us, but in fact, virtually united us in a big way. We missed each other, the hugs we shared today. But today, we are here as a very big team. When Sun Pharma, Mr. Amit and Mr. Mohan approached me, they asked me, what can we do? I said, we should do something which is memorable, which is the apex, which should be remembered throughout this year, because they are planning to do it every year, so this year. So then they asked me, how do we do it? I said, the only best way is to bring the top-notch surgeons together in one roof. And so they have done it. It's a very, very, very big, elaborate arrangements. We are having 250 people here in 2 different halls live, and they have arranged 100 centers across India. So we are being seen by nearly 5,000 doctors across India, which is, let us give a big hand to Sun Pharma. And this is purely academic, and we know that Sun has always been academic. I'm so happy to, and they were asking me, what is the name we should give? And they have decided on this very, very nice name, Elite ENT Club. So please understand that Elite ENT Club doesn't equate to the people who are operating. It equates to the people who are sitting here. So let us understand that this is what Elite ENT Club means. It doesn't mean that, the people operating are elite. You are the elite, and we are just trying to demonstrate. That's all. And something about Royal Pearl Hospital. I am now shifted to Hyderabad, but you can see the warmth which Hyderabad is extending. Like, my brother, Professor GVS Rao sir is here. He's sitting first. See the warmth. What more you want? Dr. Shyam sir is here. Dr. Sudarshan Reddy Garu is here. Dr. Nageshwar Rao Garu is here. I mean, there is no words. I'm actually having goosebumps, sir. Am I standing in Hyderabad or not? Thank you so much. And this is the kind of brotherly affection which I have developed over the past 15 years. Now, telling about Professor Kirtane, sir. Can you project the, yeah. So actually, they said, you have to read the CV of Professor Kirtane, sir. Teachers. So he's a living legend. He's a legend. So I can call ENT as pre-Kirtane era and post-Kirtane era. If at all there is something like AC and BD, then I would definitely split it into a pre-Kirtane era and post-Kirtane era. And of course, the government also has recognized it by giving him a Padma Shri and also a BC Roy award. He is a consultant ENT surgeon, Breach Candy Hospital, PD Hinduja Hospital. But I want to tell a few warm things which I have shared. The first time I saw Professor Kirtane sir was in Singapore. I went in 1999. That was the time I went to Singapore to Professor Sethi. Sethi is my teacher, my real teacher in rhinology. When I went there, there were 4 people. Dr. Deena Dayal was there. Professor Kirtane was there. Then Professor Anand was there. And when I saw Professor Kirtane's lecture, he was talking about transpterygoid approach. 1998, he was talking about transpterygoid approach. Unheard for. I was like having goosebumps. My God, an Indian person, I've come here. An Indian person is talking about all the high-end approaches for CSF rhinorrhea. I said, I have to get trained by this greatest gentleman. This is the first encounter I had. The way, stylish way he was delivering his lecture, I was, oh my God, he was a beautiful orator. So if at all I am talking something today, I've gained a lot of tips from Professor Kirtane. I flew directly from Singapore to Bombay. I just asked him, sir, can I come? He said, immediately come. And one day he gave me a chance to raise a fascia lata. For his morning, he used to do clival leak, afternoon pituitary tumor, evening clival chordoma. This is the kind of list he was doing in 1998. Today we are talking about clival chordoma and everything. But he was doing it in Kambala Hospital. Oh, workaholic. And he can rightly be defined as the father of endoscopic sinus surgery. I read his book before I read Stamberger's book. Imagine. So he gave his book to the world, and now he is the father of cochlear implant surgery. The maximum number of cochlear implants done by, and let us give a big hand to Professor Kirtane sir. And I have no words. I mean, if I talk about his proper biodata, the way he has been operating, chairperson, or orations, awards, then it'll go on one full day. I just want to summarize by saying only one word. He is my teacher, and I have the greatest respect for all my teachers, and I have the greatest respect for Professor Kirtane sir. Really, sir, I am filled with tears. The moment Sun Pharma approached me, I said, I cannot think of anybody else who can define this elite club other than you. So thank you, sir. Over to you. And I'm sure that we're going to have a surgical feast from you from Bombay And here we are. I hope the hall is already full. And we are going to have a wonderful feast. I'm sorry, the child has been intubated, I presume. And over to you, Professor Kirtane, sir.
Thank you, Janki. Can you hear me? Am I audible?
Very much.
Okay. Thank you very much, and good morning to all of you. Good morning, the Sun Pharma team. Janki, thank you for putting this together with your team. The first case that we are going to be demonstrating today in this program is a cochlear implant.
And just a minute, I'm going to interrupt you sorry. So we're going to invite the chairpersons for this session. And yeah, can you please excuse me for a minute, sir?
Yeah, Dr. Pradeep Chaure is there, I suppose.
Good morning, Kirtane sir.
Good morning.
I would like to invite panelists for this session. Dr. Pradeep Chaure. Sir is President of Doctors Club of Bhopal, Executive Member of AOI. He has been offering free surgeries for army personnel for the last 36 years. Dr. Indira Devi, ma'am, Professor and HOD at Bhaskar Medical College and Hospital, Consultant ENT Surgeon at Apollo Hospital, Himayatnagar, Hyderabad. Dr. PJ Mondal, sir, Senior Consultant ENT Surgeon at various hospitals in Calcutta. Dr. Venkateshwar Rao, sir, formerly HOD and Professor of ENT, Gandhi Medical College and Hospital. He was past Treasurer, Secretary, and President of AOI Hyderabad branch. I welcome you all.
Shall I go ahead now?
Yes, sir.
Would the chairpersons like to say something before we start?
Hello. Good morning, sir. Dr. Pradeep Chaure here.
Good morning, Pradeep.
Sir, everything has been said by Dr. Janki, and as he said, you are also my first teacher in ENT. We used to read when we were in MBBS, we used to read and hear about you as a legendary figure. But when we came in contact with you in the KEM workshop, I attended 3 workshops just to meet you. And after that, let me tell you one thing about sir. I was in a great soup during a mastoid surgery. The facial nerve was there and the lateral semicircular canal was exposed. The patient was vomiting on the table. From there, I gave a call to sir and he was in surgery. But he listened to me, then he told me how to come out of it. So sir is such type of a person. I tell you, hats off to him, and my really, as sir, Dr. Janki said, tears flow out of my, and I make it a point to wish him on every Guru Purnima and on the 5th of September. Charan Partna, Sparsh sir, again, once again, I touch your feet from here, sir. Thank you so much, sir.
Thank you, Pradeep. Thank you for the kind words. Today, we are going to be demonstrating a cochlear implant surgery in a 4-year-old child. And when Dr. Janki Ram, or I can call him Janki, when he asked me to do that, I said, look, Janki, my first presentation that I made was in 1972 in an international conference. It's exactly 50 years now that I've been doing this, and it's time that we learn to take a back seat. So I have requested my colleague, Dr. Sangeeta Varti, who is a consultant at the Hinduja Hospital and was the ex-associate professor of ENT at St. GS Medical College and KM Hospital in Mumbai, who's got a special interest in cochlear implant surgery. She's done hundreds of cochlear implant surgeries now. And she's also been sort of conducting teaching workshops on cochlear implant surgery for the past many years. She is also associated with the National ADIP scheme, which many of you are aware of, because she's there as a clinical expert on that committee of the ADIP scheme. And this is by virtue of the fact that she's a visiting consultant to the Ali Awar Jung Institute, which coordinates the scheme. So she has kindly consented to demonstrate this surgery. I will be with her in the theater. But before we proceed, just let me give you a background of this case. It's a 4-year-old child, congenital deafness. The child child was in the NICU for a few days after birth, but the parents didn't realize till the child was 3 years old that the child has a problem. That's a sad story, something that tells us that we must have a universal newborn screening program in place to detect these cases early. This is the audiogram, shows you the aided audiograms in the high frequencies is absolutely below what is expected. So the indication for a cochlear implant is clear. We've decided to operate on the right ear. And I'll just quickly go through the anatomy of the temporal bone, the mastoid on the right side. As we always do, we always insist that run through not just the cochlea, but run through the entire anatomy so you do not miss out on anything. So you are seeing the actual CT scans of the right temporal bone, and it's our practice to start reading from above, from the tegmen level, and go down towards the tip of the mastoid. So as you can see, a well pneumatized mastoid, which is good for us, and there is no disease. And now here you come across a little white patch, which is the top of the tegmen, the arcuate eminence. So the superior semicircular canal is coming here. As you go to the next cut, you see good pneumatization in the petrous apex, and you can very clearly see the superior semicircular canal. In the next cut, now you're going through the dome of the canal, so you see it as one line. When you go a little deeper, you'll see the superior canal in the axial plane with the ampullary end in front and the posterior end here, which goes to form the crus commune at the back. As a matter of fact, if you see the next cut now, you will see the ampullary end of the superior canal, the crus commune, the posterior semicircular canal coming into view, which this is the ampullary end of the posterior semicircular canal, and the two join together to form the crus commune. And you're also seeing a linear shadow here, which is the subarcuate artery, which passes through the arch of the superior semicircular canal. As you go to the next cut, you see the posterior semicircular canal very clearly, crus commune, ampullary end of the superior canal. And go one cut lower, you're starting to see the superior posterior canal, crus commune, and a little shadow appearing here. That's the top of the internal auditory meatus. You're approaching the internal auditory meatus from the top, where in the next cut now, again, you see the internal auditory meatus clearly. You just opened the roof of the internal auditory meatus, ampullary end of superior canal, crus commune, posterior semicircular canal, ampullary end. As you go a little lower, you see the internal auditory meatus quite clearly now. You're also now seeing the lateral semicircular canal, and you see a slight indentation here. That's the endolymphatic duct. Usually you will see it at the level of the lateral semicircular canal. You should always try and see if your lateral semicircular canal is well formed, because if it is not well formed or if it's abnormal, the chances of the facial nerve course being abnormal are much higher. Similarly, look to see whether the endolymphatic duct is enlarged. It should not be enlarged more than about 1.5 millimeters, because if you have an enlarged vestibular aqueduct, you're likely to get some CSF leak when you open the round window. As you go further now, you see the internal auditory meatus. This is the superior vestibular nerve. This is the facial nerve leaving the canal and going over the labyrinth. It's called labyrinthine portion. And between the two, you see this ridge of bone that is called the Bill's bar, that divides the superior compartment of the internal auditory meatus in an anterior facial nerve and posterior superior vestibular nerve compartment over here. That's the vestibule that you see, the lateral semicircular canal. Go one cut below, and now you see, let's look at the facial nerve first. This, in the previous cut, this shadow that you see is the top of the cochlea. You don't see the lumen as yet. So in the internal auditory meatus area, what's in front is the cochlea. What is behind is the vestibular labyrinth. So if you see the next cut, you've gone a little lower, internal auditory meatus. You're seeing the top of the cochlea lumen over here. You're seeing the vestibule and the semicircular canals here. And you follow the facial nerve. We had seen it coming out of the canal. Now it goes to the geniculate ganglion here. You can see this nerve going in front. That's the greatest superficial petrosal. And the facial nerve curves back in an acute angle. This dilatation here is the geniculate ganglion. And that's the horizontal part of the facial nerve. And you can see a nice bony canal covering the horizontal part of the facial nerve. And it's for the first time now that you're also able to see the head of the malleus and the body of the incus with the short process going to the fossa incudis here. Also, see what you're seeing here. It's a little shadow of the jugular bulb. So we know that it's a fairly high jugular bulb, which is coming right up to the level of the vestibule here. We go to the next cut now, and we look at the internal auditory meatus. We can still see the lower portion of the internal auditory meatus here. And you can see the cochlea. You can see the aperture of the cochlea where the cochlear nerve is entering the cochlea. And you can see this butterfly-like shadow here, which is the modiolus. This is called the cochlear aperture of the cochlear canal. And it should be about 1.2 millimeters to 2 millimeters. If it's smaller than 1.2, then you would call it a narrow cochlear aperture, which would indicate to you possibly a thin cochlear nerve. Here you see the vestibule, the posterior semicircular canal, the jugular bulb, and the ossicles. Now you go to the next cut, and you can see the cochlea in all the three turns. You can see the basal turn, the middle and the apical turns, which will be defined a little better in the next cut. You can see a shadow here. That's the cochlear aqueduct, which is a communication between the subarachnoid space and the scala tympani, just near the round window. It's covered, it's totally sort of filled with a reticulum, so you don't have a direct communication. But this is how meningitis infection goes and affects the basal turn of the cochlea, leading to fibrosis and ossification. You can see the ossicles here. You can see the malleus. You can see the incus, maybe the incudostapedial joint over here. In this particular one, you don't see the... okay, if you go back here, 1 minute, can you come to this? Here you can actually see in the vestibule, that's the footplate of the stapes, and you can see the crura of the stapes here. You can see the pyramid. Now, in this cut, we had seen the facial nerve coming back. At this point, it will turn. This will be the second genu. The first genu was here. And then it becomes vertical in the course. So when you see it in the next cut, the horizontal portion becomes vertical. So the facial nerve here. And this triangular piece of bone is the pyramid. That is the stapes, and the stapedius tendon would be here. So now as you go down, you will find the facial nerve here. The pyramid, the shadow in the pyramid here is the stapedius muscle. And this is the vestibule. As you go one cut below, what you're now seeing is that the air shadow of the middle ear gives this little nubbin of shadow projecting into this little notch here. So that's the round window niche. The way to recognize it is this little shadow or air bubble going into the niche. This is the bone overhanging the round window niche. We'll have to remove to get a better exposure of the round window membrane. And if you see the next cut, you will see a nice high jugular bulb. You can just see the handle of the malleus. That's the umbo there. The basal turn of the cochlea, the middle turn of the cochlea, the apical turn of the cochlea, the internal carotid artery here. See how close it is related to the cochlea. That's the internal carotid. And now you're going to the lower part of the cochlea, internal carotid artery, that's the eustachian tube coming over there, jugular bulb. So we have a good pneumatized mastoid, no disease. We have normal semicircular canal, so we do not expect too much of variation in the facial nerve canal. A good looking cochlea where we have all the three turns. So I think this should be a good case to do the cochlear implant. So I'm now going to hand over them. Oh, sorry. In the MRI, what you look for in the T2 weighted images is if you see this area here, you can see the cochlea on both sides, and you can see that the cochlea has got a good amount of fluid content indicated by the white in the cochlea. And you can see the actual cochlear nerve entering the cochlea as it goes through. You can see the modulus of the cochlea here. So that's where the cochlear nerve is entering. And if you see the parasagittal oblique sections, then you see the internal auditory meatus shadow, and you can see the facial nerve, the superior and inferior vestibular nerve, and cochlear nerve here. And what is to be seen is that the cochlear nerve is about 1.5 times the size of the facial nerve, which is the normal size of the cochlear nerve. The cochlear nerve should be bigger than the facial nerve. If it's smaller than the facial nerve, then again the report will be thin or a deficient cochlear nerve. So these are the things that you would see in the MRI. Besides seeing the fluid content of the cochlea and the presence of the nerve, you would also want to see the brain and make sure that there are no other problems there like leukodystrophy, which can come in the way of a good result or outcome in a cochlear implant case. So I think now we are ready to start, and I'm going to hand over to Dr. Sangeeta Varti. She's ready, and she will show you mark out the incision for you, how she plans to put the implant, putting the template on the patient's head, and then she will start with the incision. So over to Dr. Sangeeta Varti. Thank you.
Okay.
Good morning, ma'am.
Hello. Good morning. Can you hear me?
Ma'am, I would like to introduce the moderator for this session, Dr. B. Nageshwar Rao, sir, additional professor of ENT Government Medical College, Nellore. He holds a special interest in anterior skull base. Over to the sir.
Thank you, madam. Thank you. I'm Dr. Nageshwar Rao, additional professor of ENT, ACSR Medical College, Nellore, and settled in Visakhapatnam as private practitioner. Thank you.
Good morning, all of you.
Good morning, madam.
At the outset, I would like to thank Dr. Kirtane sir, Dr. Janki Raman, and the Sun Pharma for giving me this opportunity. And a special thanks to Dr. Kirtane for training me and mentoring me for the cochlear implant surgery and showing me the goal which I would like to go ahead with. We start the surgery. We are going to do a posterior tympanotomy approach. The incision for the surgery is like all of the otology surgery. Okay. So we'll start the case. You can see this is the right ear. This is anterior, posterior, superior, and inferior. And I'm palpating the mastoid tip. Okay. This is a template where the sound processor is going to be. We nowadays we don't use a blue mark to know the site for the well. But if you can see this, there is a small projection here. So around 1.5 centimeter behind that is going to be your well here. Okay. The incision is going to start at the around 3 millimeter away from the post-oral groove, right up to the mastoid tip. We can give this incision a little curve posteriorly. So when this incision comes and we do a cortical mastoidectomy, your well is going to be here, and your implant is going to be here exactly at 45 degree to the vertical line. So this is how your implant is going to be sitting under the skull. Okay. And the infiltration has been already done. It is our local 2% halocaine with adrenaline and a little bit of sensor cane in it. A slight curve posteriorly. We take small soft tissues of fat for plugging the round window after the implant is inserted. around 4 to 5 pieces. Try to take them just below the hairline. Okay. You can use a cautery or you can use a knife here. Now we are going to elevate the flaps. Thirty. So now we are going to make a posterior superiorly flap after undermining the edges. I'm undermining the anterior edge now, anterior flap.
Little fine adjustment, madam, please. There is little blurring of the.
Okay, I can feel the posterior canal here. Okay, this is your temporalis fascia. At this level, you start now elevating the, undermining the posterior part of your incision. You are getting a nice plane here. Okay, we need to do this because we need to take a posterior superiorly based flap. Okay, so the posterior superior based flap, now we have a, this edge is all undermined. You can see anteriorly and posteriorly. Give me a cat spawn. Okay, now we will start taking the posterior superiorly placed flap. So your flap is going to lie this way. This is the anterior edge of the flap.
Please centralize the field, madam. And little fine adjustment, madam. There is a blurring.
Can you see now?
No, this still there's a blurring, madam. Please, little fine adjustment. External camera.
Also fine adjustment. Can you see now?
A little
It's
fine.
better.
No. Oh, now it's better, madam. Now it's
Okay.
better, madam.
Okay, so now this is your where we are going to take the anterior part of the flap, and this is going to be your inferior edge. So this is how your flap is going to be posterior superiorly based. Okay,
Yes.
I'll elevate the flap. Go right up to the periosteum. You can use a knife or you can use a cautery with whatever you are comfortable with.
Madam, is the
Okay.
flap incision and skin incision not corresponding? Like?
No, they are not corresponding.
Again, the picture is blurring, madam. Now it is fine.
Okay.
Okay, madam.
Okay, so this is your posterior canal here.
Yes, madam.
Okay. I'm making a small tunnel here now only for the ground electrode. Okay.
Yes, ma'am.
Now we will start taking the inferiorly based. Okay.
Yes, ma'am.
Now you have to be very careful here because you're going to get a emissary vein. Okay. If you encounter the emissary vein, if you cannot stop the bleeding with a cautery, you should have a bone wax in the operation theater. You cannot allow a blood loss in a young child. That's it. That's it.
Yes.
Okay.
Yes, ma'am. Oh,
Suction on. Okay, now this,
yes.
just a small.
Hello. Does this emissary vein always comes in the way, or is it okay?
Most of the time. Most of the time.
Okay.
Okay. Now you take a periosteum elevator and we make a pocket, but now you have to see that you don't make up a large pocket, just enough to accommodate your implant. So we'll have a template now, which will be not this. No, not this. Not this, not this. No. Cochlear. Give me something, huh? Just give me a minute. Yeah. Okay. Yeah. I have another template. Till it comes, I'll just show you how it is snugly fitting here. Can you see?
Not clear, madam.
1 minute. Give me your
Sorry.
That's for. Yeah.
The size
Can you
of the
see?
flap is- Yes, madam. The size is blurring, madam. Again, the picture is moving frequently unnecessary also.
Okay.
No,
Alright.
blurred. Yeah, it's
Yeah. So I got a proper template, the right one. Cochlear template here.
yes, madam.
Madam, at this level, Dr. Kirtane uses a special type of instrument to detract the.
Not this. When we are drilling the well, I will show you the proper instrument.
Okay. Because
This
that
is just showing you the exactly the pocket which you make. Huh?
Dr. Kirtane's
Okay.
favorite instrument for that.
Yeah. I'll show you when I'm using it.
Instead of retracting, why can't you go for suturing the flaps, madam?
We can suture the flaps, or
Yeah.
we can use a mastoid retractor. Okay. Now we'll have a. Okay. So now we have the whole area which I'm going to drill. This is your posterior canal wall. This is your mastoid tip, and I'm going to do a cortical mastoid now. Okay. Give me your pal. Okay. Bada. Give me one more retractor.
Most of the patients are children, madam. They have simultaneously secretory arts media with profound SN loss. What are the
Yeah.
precautions? If the patient, most of the patients are children,
Okay.
if they have secretory arts media,
Big one.
simultaneously secretory arts media,
Okay.
then what will you do?
Initially, we are going to do a gromate insertion.
Yes, ma'am.
If it is not going to with the medical line of treatment, Okay?
Yes, sir.
And then plan your cochlear implant surgery later. Okay, I'm starting.
Any infection is very much detrimental for
Okay.
cochlear implants.
Hmm. So this is your master tip here. Be careful in children. You have a very forward lying sinus, low lying dura. So if you can first see that in your CT scan, it will be very helpful. Now here when you're drilling, you have to see the edge of your, it is not going to be like how you do for your mastectomy. Your edges are all going to be undermined. You are not going to have a bevel structure here. Okay. Can I shift to a microscope so you will be able to see better?
Madam,
Vivek?
can we avoid wobbling
Vivek?
of the picture and blurring of the picture?
Vivek, mala chasma hai. Tell Vivek to give me my specs. You said something?
Can we avoid wobbling of the picture and blurring of the picture, madam? It's constant.
Yeah, I think now when we come back from the microscope, maybe you will be able to see better.
Yeah.
No, listen.
Yeah, can you hear me?
Yeah.
Yes, sir.
Fix it here.
The blurring of the picture is occurring because, it's an automatic focus camera. So when the hand comes in the way, the camera changes focus. That's why I suggested to her now that instead of the external camera, let us take the microscope picture so it will be better. Because every time her hand came in the way, the camera would change focus. So that's why you were getting blurring. Okay?
Sir.
So we'll
Sir,
try and
can
do
we
it with
ask a question, sir, for you?
Yeah, please go ahead.
I'm Dr. Nageswara, sir, moderating the session.
Yeah.
So the role of CT scan in the cochlear implant surgery.
Well, as I ran through the whole thing, it showed you the pneumatization, lack of disease. It showed you whether the cochlea turns were present. It showed you the course of the facial nerve. It showed you that the labyrinth was well formed. It showed you that the endolymphatic sac could have been enlarged or not enlarged. So all these things in advance. When you look at the coronal cuts in the CT scan, you can look for a low dura. You can look for a lower placement of the facial nerve. You can see if there is a dehiscent superior semicircular canal.
Sir.
So the CT scan is a fantastic guide for you to know what to expect in the anatomy, any variations, any pathology in the mastoid, in the cochlea or the labyrinth, in the course of the facial nerve, a high jugular bulb. You're warned of all these.
Sir.
The MRI is seen mainly to see the nerves, the brain, and the fluid content of the cochlea.
Can we assess the round window depths radiologically before surgery?
Round window?
Depth.
Well, you can know the depth of the niche, but it's really something which you will tackle once you expose the round window. So you need to remove the operculum of the round window to get a good view of the round window membrane. Yes. Now, in this case, for example, we are using the old REST implant. Now, that is not ideally suited for a round window insertion. It's a little stiff, and the diameter of the array is continuously the same. So if you try to go round window with this, you might encounter a little resistance to the implant after you put in a certain number of electrodes. So if we are doing an REST, and there is no hearing preservation in this case, I would certainly say that it's much better to do a extended round window cochleostomy for smoother insertion of the implant. But before you do that, you would take out the operculum to expose the round window membrane clearly. This is a step which I insist on so that, there have been mistakes in the past where people have taken a hypotympanic cell to be a round window. If you can visualize the membrane, then you can't make that mistake.
Sir, as the children are, when the child is affected by the meningitis, he may prone to develop profound, sometimes bilateral profound loss.
Yes.
Did you do any prophylactic dummy implantation in post-meningitic child?
Well, the first thing to do in any post-meningitic child is to test the hearing.
Yes, sir.
If there is no hearing loss, you could afford to wait. But if there is any starting point of hearing loss, I would immediately do a CT scan and an MRI, because if the hearing loss is present, the ossification post-meningitis can start as early as few weeks. And if the ossification progresses rapidly, you might land into a situation of obliteration of the cochlea with bone. So these are cases where almost like a semi-emergency, you would have to go in. Post-meningitis, child develops hearing loss, do a CT. And if you see the starting point of ossification, I would say better to operate as early as possible, provided the audiogram suggests that it is beyond the range of a hearing aid. And you would monitor the audiogram because it might be progressive hearing loss.
So we are proceeding for the viewing of the incus now, sir.
Beg your pardon?
So now we are proceeding for the viewing of incus at this point.
Yeah,
that
we are
I'm going to
just
leave to Dr. Vati to describe what she's doing
Okay,
in
I'm
the
just
surgery.
seeing the incus now.
No. Now it is
Can
seen,
be seen.
madam.
Yeah, we can just see it incoming.
A small niche can be
Yes,
seen.
madam.
Okay.
Yes, madam.
There's a short process of incus here.
Yes, sir.
Yeah. So this is your dural plate here. This is your sinus plate here. You can see a little bit of sinus here. And this is your mastoid tip. So I have the whole area now for me to start drilling the posterior tympanotomy approach.
He will tell you what are the limits of the posterior tympanotomy.
Question to Dr. Khetre, sir. Are you proponent of Varia technique or opponent of Varia technique?
Not at all.
Sir?
Not at all.
Yes.
I did the Varia technique. I was perhaps the first one in India to do the Varia technique with Professor Tripon.
Yes, sir.
Dr. Hans was with me here at that time. We did it at Hinduja. I did it in a few cases. Then I realized that, especially with the newer electrodes coming in, the contour advance and then the mid-scalar and the 632, you can't use those through the Varia technique. And these are for structure preservation, if not for hearing preservation. And the very concept that you expose the wound to an external canal incision is something that which, I would be dead against, because you're opening a possible pathway to infection. And secondly, I think one basic principle we learned in surgery is that the tip of your cutting instrument, whether it's in the sinus surgery, whether it's in the larynx, or whether it's in the ear, the tip of your cutting instrument should always be under view.
Okay, now another important thing is here is you have to thin the posterior canal wall, but see that you don't breach the canal.
Madam, is there any calculation where to open up the posterior canal?
Yeah, so this is your short process of incus here, and this is going to be your digastric ridge. Okay, so this area which you have here, I'm going to thin it out, and this is your lateral canal here. Now, there is a lot of bone mastoid cells over it.
As all of you know, the margins of the posterior tympanotomy will be, it's a triangular space that you create with the base of the triangle towards the fossa intudis, the apex at the caudofacial angle. The posterior margin is formed by the facial nerve, which will be delineated, and the anterior edge is formed by the chorda tympani. So chorda tympani in front, facial nerve behind, the fossa incudis at the base of the triangle. So first thing to do is to
Give me
define the
your code.
incus, which he has done.
Yeah.
He will need to remove quite a
Yeah.
bit of bone because
So now this is a incus. I need to remove the whole bone over this. Okay. And now from this incus, if I have a 50% here, I have to create a base anteriorly also.
what
So
she
I
means
keep on-
by the 50% is that the base of the triangle that she's creating is in such a way that 50% of that line, the base, will be in front of the fossa incudis and 50% will be behind, so that you don't go too close to the facial nerve and you don't go too close to the external auditory canal. And I just saw the CT scan again. The amount of bone in that area is quite a bit. So she will have to drill quite a bit to come to the facial nerve, which she's doing it. See how she's running the drill up and down the course of the facial, not across, but in the direction of the facial nerve up and down.
Madam, before opening up the posterior tympanotomy, before doing it, that just let us once again tell us the 50% concept.
Yeah, I'll just show you. Let me drill some and I'll show you with a marking. Okay, give me a curved pick or something. Okay. Now this is your first short process of incus. Yeah.
Yes.
So 50% here and 50% here. Still I have to drill this bone here. Okay. So this is going to be the base of your triangle and your facial is going to be here. I have to drill a lot of bone over it and your chorda. Okay.
Can you show the incus buttress, madam, there?
Here.
Incus buttress.
Yeah. Give me a curved pick. Can you see here?
Yes.
Okay.
That's incus.
Yeah.
I'm just going to
Now when you're drilling the posterior tympani, yeah.
I'm just going to the external camera for 1 minute for you because of this 50% question.
Yes.
See, this is the mastoid, which is real. This is the external canal, right?
Yes, sir.
This is the facial nerve.
Yes, sir.
This is the chorda tympani. This is the incus here, and this is the base of the triangle, correct?
Yes, sir.
So what you mean by 50% is if you take this fossa incudis, the base of the triangle should be such that it's 50% in front, 50% behind.
Yes.
If you take the base like this, then you'll hit the facial nerve. If you
Yes.
take the base like this in front, you'll enter the external canal. So keep it roughly 50% front, 50% back, so
Yes.
that you're neither too close to the facial or to the external canal. And if you see the fossa incudis, and if you draw a line along the body of the incus through the short process, and you extend it to the same length as the body here, this is where you will encounter the facial most of the time. You followed? Just draw an imaginary line through the incus, same length as the body of the incus, and that is where you will encounter the facial or somewhere nearby. So you understood this 50% rule?
Yes, sir.
Yeah?
Very clear.
Okay. Go back to the microscope.
Sir, is the chordofacial angle is constant, sir? Any variation? Many variations.
So that varies. Sometimes the chordofacial angle is much lower, much higher. The corridor doesn't take off. Normally we say 6 millimeters above the stylomastoid foramen, but that can be variable.
Yes, sir.
Water.
Back to Dr. Sangeeta for the surgery.
Okay. So I have started creating that 50%.
Good morning, sir.
So that now your posterior tympanotomy should not look like a tunnel, but like a funnel. Okay, it should be open, wide open. Can you turn the table opposite to me, please? Away from me. Bus, enough. Okay. Okay, so now I've got a base. Now I'll start looking for the facial.
Please
Drill
note that
along.
she's using a very big burr, not a tiny little burr which can, damage the facial. Always a broad burr so that it's much safer near the facial. Diamond burr.
Size of the diamond bar, sir.
The burr size is always 2 times bigger than the area where we are dissecting. Is it true, sir?
Sir, importance of digastric ridge once, please elaborate, sir.
No, he had asked some other question before that.
Yes.
Something about 2 times the size. What was that question? I didn't get it.
Sir, size of the diamond bar.
Bore size.
Should be
Area which is drilling.
I think the surgeon has to decide what he is comfortable with. As regards the digastric ridge, yes, if you have a difficulty in locating the facial nerve, especially if you have a slightly abnormal course, then you would go more for the digastric ridge. Here, I use the incus as a landmark, which is what she's doing. And if she gets the facial nerve there, then she may not have to go and define the digastric ridge.
Okay, sir.
People talk about the facial nerve and the learning curve, and that's why they shift to varia. But the same people who do varia, when I ask them that how much do you lower the posterior canal wall when you're doing a canal wall down mastectomy, and they say up to the facial nerve. So they know where the facial nerve is. I asked them whether you had a traumatic facial, you would do a facial nerve decompression or not. They said, yes, we do facial nerve decompression. So they know where to find the facial. So if in cholesteatoma surgery, if in traumatic surgery, you know where the facial nerve is, why be afraid of it in cochlear implants?
I'm just started seeing the pinkish hue of the facial nerve.
Yeah, there is little change of color, madam, from white to pink.
I'll just show you. Yeah. Okay. Can you give me a curved pic to show them the faces? I'll just show them here. You can see it is curving here. This is a facial. This is a facial which is just curving here.
Yes.
I have to still drill over this area.
Yes.
Okay, I'll take a small bore now. I can see the facial. Working. I take a small bore and now. Yeah. I'll take a smaller bore now so that I can better delineate the facial for you. Can you give me an 18 number section?
Sir, when the cochlear ossification due to meningitis, post-sequelae meningitis, the patient is having profound hearing loss. What will you do for implantation?
I didn't get your question.
Sir, I'll answer that question.
Yeah.
So for cochlear ossification
Yes, sir.
often begins near the round window. So in the stage 1, it will be only near the round window. The stage 2 part of the scala tympani in the basal turn will get involved. It's very rarely that you get a complete ossification involving the cochlea completely.
Sir.
That can happen. It's a whiteout. So you have to study the CT scans, study the MRI. Then you have to do a drill out. For example, if there is ossification near the round window and a little bit of the basal turn,
Yes.
if you drill carefully and gently, you might be able to reach the lumen. I told you that the ossification begins in the scala tympani. So sometimes in these cases, you might purposely want to enter the scala vestibuli where the ossification may not be as dense. And if you can get the lumen, then you are able to do an insertion. So you have to drill very patiently. You have to have a 3D idea, a 3-dimensional idea of the lumen of the cochlea in your head as you drill along. And very often you're able to drill a little bit and get into the lumen of the cochlea, either in the scala tympani or in the scala vestibuli. People have talked about doing 2 cochleostomies and putting a split array, but that is more or less given up because the split array that goes into the second turn often stimulates the facial nerve. There is another technique of a cochlear drill out around the modulus and putting in as many electrodes as can go in. I have done cases where I put about 6 or 7 electrodes inside only, and the patient has still got some amount of response. And if you can't do any drill out, you can't get any implant inside, then the only option that you have would be to go for a brainstem implant.
What is the indication of middle turn cochleostomy, sir? Mid-turn cochleostomy.
As we said, the ossification begins in the basal turn.
Yes, sir.
So if you can get into the middle turn, then you put some electrodes into the basal turn, you use a split array, and you do a middle turn cochleostomy. So if you had the old cochlear array, it had 11 electrodes on one arm, 11 electrodes on the other arm. So you could put 6 or 7 into the basal turn and put about 5 or 6 into the middle turn. So you could have about 10 electrodes to 11 electrodes in the cochlea. But I think Cochlear has now stopped manufacture of that implant, the split array.
I'm just at the, you can see, give me a code pic.
Let us now concentrate on the surgery because she is now about to do the posterior tympanotomy.
Okay, you can see the facial coming here. I'm just looking out for the chorda, but I'm not yet able to see the chorda. Yeah. This is the facial coming from here. Can you see the pink color?
Yes,
Change of, you can see the difference between this bone and this bone. Okay?
Yes, ma'am.
Yeah. Trying to see the chorda, but it's okay. Be close toward the facial if you cannot see the chorda. We don't want to open the annulus and open the posterior canal wall.
Please notice how she's made a wide funnel and not just a tiny tunnel to enter the posterior tympanotomy. Okay, that's important.
I'm drilling over the facial. Still trying to see the chorda. I think I can see a small streak of chorda. Okay. So we have opened the posterior tympanotomy. Yeah.
That is stapes.
Yes.
Yes, ma'am.
And you can give me a adrenaline gel form, please. Okay, so that is your stapedius tendon and include a stapedial joint. Okay, we will go a little posteriorly now to see the Yeah. Yeah, I'm drilling now media to the facial and you can see the
Yes, madam.
stapedius tunnel here, muscle.
Incrostopidial joint.
Yeah, this is the adrenaline gel foam just to show you. Okay.
Yes, ma'am.
You can see the stapedius tendon here. And the tunnel for the muscle, okay?
Yes,
Please
ma'am.
focus here.
Fine focus.
Okay?
Yeah, yeah.
Yeah. I'm just started seeing the round window there.
Yes.
I'll have to drill this bone here.
You can just see the top of the round window peeping at you.
Yes, sir. Please straighten it and centralize the picture, madam. Yes, we are losing
Now
the anatomical
Yeah,
orient.
can you turn the table towards me?
clear.
Little.
You can see the round window now, but you'll have to expose it a little better.
Yes.
Yeah.
Yeah, I still need to a little thinning of the canal.
Yes, madam.
Yeah, I'll go. I'll just thin the canal little. Block.
Sir, can we fracture the postmeatal wall and push anteriorly to access the round window?
That has to be done only in a situation where you have an overhanging facial and you just cannot see the round window.
Yes, sir.
There are 5 or 6 options there. We'll discuss that after the case is over. There are 5 or 6 different options you have.
Yes, sir.
So I'm just coming at the cordofacial angle.
Round window is very clearly.
Yeah.
Madam, it's obliquely placed. The picture is obliquely placed. It's not horizontal. Little change the picture, madam.
1 minute. Block, please. This is blocked. Adrenaline gel foam, please.
Still it's.
Can you see now?
Yes, madam.
It's quite clear, ma'am.
Clarity is good, but it's not this one in the horizontal plane, madam.
Tendon, madam.
Can you see?
Ma'am, are you
Can
drilling?
you able to see the
Can
picture?
the orientation be changed, ma'am, slightly? So that
Pardon?
Ma'am, are you drilling the stapedius muscle there?
Yeah. This is the stapedius muscle. I just drilled the stapedius. Sometimes.
That the stapedius muscle or the pyramid may come in your way and you may have to drill that out.
This is the.
Medial to the facial nerve.
This one.
Yeah.
Yes, ma'am.
Yeah.
Okay.
That can't be helped because otherwise it's overlapping the round window area. But that's why she's got that good orientation now.
Yeah, yes, ma'am.
Okay. Now I will just skip a adrenaline gel foam here, and we'll go to start making a well now. Okay.
Yes, ma'am.
So we'll shift back to the top light and external camera. Okay, now I will show you the retractor what somebody was asking. Give me. Okay, can you see this?
Fine adjustment, madam, please.
So-
Fine adjustment.
This is a special instrument, Dr.
Yes.
Kirtane, retractor.
Yeah. Okay, yes, you can see the serration.
Yeah.
These
Yeah,
are
yeah.
very important so that you get a good grip on the bone. Huh?
Yes,
And
ma'am.
there is a nice concavity here. Okay, this will go underneath your flap here.
So till now it has not been named.
The instrument has been named. I call it as K-Surge instrument.
Dr. Kirtane's retractor.
Yeah, or K, just a short form.
So from today, it will be known as Dr. Kirtane's retractor.
Okay.
Sir, everyone will call only Kirtane sir's retractor only, sir. Not from today, sir.
Okay, so now I want to show you, this is your dural plate, this is your sinus plate, and this is your sinodural angle.
Yes,
Okay, we want to have your implant at this trajectory, right?
Yes.
So we will just take a template now. Okay.
Now, we-
We'll place it underneath the flap. Okay, now this should be a
Yes,
little far away because your sound processor should not come on the implant, right? So take it little behind. I take it around an inch behind. Okay,
Yes, ma'am.
so give me your pen, marker pen. Okay, so you have a, give me a retractor, cat's paw. Just hold the implant with up the top. Okay, and then you mark this, and this is your going to be your for the channel. It's a retractor, K retractor.
Madam, can you orient the picture, madam? In the horizontal position, now it's in the vertical position, as if you are doing the surgery in the patient standing position.
Point
See-
is for the camera
You have
to be
to-
oriented properly, the cameraman has gone on to the opposite
Yeah.
side.
Because we
So
otherwise
you
you'll
want to look at it as if you're operating from the front of the patient, okay?
see
Because
because
if he
it's,
stands behind her, then he cannot focus onto this area.
Yes, sir.
But and sometimes we do this. I mean, I actually get up from the table, go to the opposite side of the patient.
Yes, sir.
Although she's sitting here and operating, the view that you are getting is as if the surgeon is sitting in front of the patient, not behind the patient.
so this is going to be your well. Okay,
Yes, madam.
and you have a template for the well over here, so you can mark it. Okay,
Yes, madam.
and now we'll start drilling the well. I hope you can see.
Yes, madam.
नहीं हो रहा है इससे ड्रिल ड्रिल नहीं हो रहा है I think they can see, no? No? थोड़ा can you tilt the table little away from me? No, away from me. Still little. Okay.
You need to drill this to a depth of about 2 millimeters.
Yes, sir.
And if you don't have that much thickness of bone, then you'll drill all around, keeping an island of bone in the middle so that you can expose the dura around the ring. So you can actually depress that central bone. The idea is that the receiver stimulator, which is circular, should fit snugly into this so that you don't have to do tie down holes and suture it with a non-absorbable suture, because it fits very snugly and cannot move. So what she'll try to do is a 2 millimeter depression. If required, she may have to expose the dura, keeping a island of bone in the center if possible.
You have a golden one, Levan? Okay. So this island of bone I'll keep on thinning.
Excellent. Sir, the indications of cochlear implant are drastically changed. Before they used to do bilateral profound hearing loss in a child. But there is no age is indicated, but any patient having deafness.
Sorry, I couldn't hear that because the noise of the burr was very close to my ear. Can you just repeat your question?
Sir, the indications of cochlear implants are nowadays changed. What is nowadays the patient is having deafness, not benefit of hearing aid is the indication for cochlear implant. Is it correct or not?
The indications for cochlear implant have changed, yes, from profound hearing loss to severe to profound hearing loss. Also, in adults, you look for speech discrimination score.
Yes.
So even if you have something that is helped by hearing aid to a certain extent, but it does not improve your speech discrimination score to beyond about 40 to 50%, speech discrimination score, then you could consider a cochlear implant. So indications have changed, yes. Indications have changed even in adults with unilateral hearing loss. People are talking about cochlear implants.
Your series of implants, sir. What is the lowest age patient? What is the highest age patient? Age of the patient?
I have operated on a 7-month-old child post meningitis.
Yes, sir.
But 8 months and 9 months we've done quite routinely now, even bilateral simultaneous implants.
Yes, sir.
Sir?
Sir, you will go for hearing aid trail in every patient.
Sorry, once again?
Hearing aid trail, sir, in every, you will use hearing aid trail in every patient, sir, or is it mandatory, sir?
Can you be a little louder, please?
Hearing aid trail, sir.
Hearing aid trail. Yeah. I think as a routine, we put them on hearing aid trial. I want it documented in my reports that the hearing aid was tried, was not helpful. And that's why I'm doing the indication for cochlear implantation. Secondly, the child also gets used to sitting with the therapist and doing the training in a particular way, so that after the operation, if it's the same therapist, there is no problem for the child to sort of sit with the therapist whom the child gets to know. And number 3, if the child has any behavioral problem, sometimes some children take the hearing aid and throw it away. You know, if they do that with a cochlear implant processor, you might lose a lot of money. So if there are behavioral issues, those can also be sorted out in advance.
Okay, sir. Sir, for how many months routine?
Now that depends entirely on the audiologist, who will tell us whether they have been able to reach a conclusion that a cochlear implant is necessary. It may be weeks to months.
Okay, sir.
Okay, so we have finished the well. Now I'm going to start making a channel. You can see it with the template.
Yes,
it's nicely fitting here. Huh?
I'm requesting her to demonstrate this with the microscope so that you are able to see it better. She can also show you the well which she has made. And with the template, she will show you how snugly the template is fitting in there.
Yes, sir. Now it's clear, sir.
It's okay. Give me a, yeah, this little thinner. Yeah. Yeah, I showed it, but I'll show it again. I just edges, I will.
There are many
Again, the edges of this well should be,
Yes.
just hold this, Leah, hold this. Okay. Now the edges of your well also should not be beveled. Okay.
Yes, madam.
Yeah, continue.
Thousands of delegates are watching the live surgeries, madam.
Pardon?
Thousands of delegates are watching the live surgery.
Yes.
Yes.
Ma'am, this is Dr. Archana from this side. Actually, there is one question from virtual platform. If you allow, can I ask?
Yeah, go ahead.
Yeah. Dr. Sabri from Salem has requested Madam to brief about the size and types of burrs used.
For size of the burr, for thinning the floor of the well, I'm using the largest burr, which is a diamond burr, because you don't want to damage the dura here. Okay. Very carefully keep on thinning the floor of the well.
So, ma'am, thank you.
You know, the size of the burr is not, we don't go by millimeter size that you use a 4 or a 3 millimeter burr. You use what you think is comfortable for the size of the mastoid that you've got. The largest burr possible should be used so that when you're near the vital structures, you don't poke into them. Whether you're near the dura, whether you're near the facial nerve, use the largest comfortable size burr that you want. If you use a very tiny burr, the chances are that you might poke into the vital structure. Also see how she's continuously moving the burr around and not trying to push down at one particular side, so that you're very gently thinning out the bone.
Thank you, sir. Quite useful.
I can see now the pinkish hue of the dura coming. So you can stop here because you have got a good depth also.
Yes,
I'm
ma'am.
using a template here. You can see it is nicely sitting here. Can you see?
Yes, madam.
Huh? Okay.
Yes, yes, madam.
Yeah. Now I will start drilling the channel. For this, initially I take a cutting burr. And then again, when the dura comes on the floor, you shift to a diamond. Now here I will demonstrate to you how to make a hook. Again, this hook is also called as Kirtaneswar hook. No?
You see that bone is diploic. You can see the bone marrow. So you'll need to use a diamond burr thereafter to get a hemostasis.
Okay, now we'll start making a hook now, or a bridge you can say.
Any questions from the audience to pass the faculty? Please write on the paper and hand over it to me. I will pass the question to the faculty people. You are all welcome.
Okay, now we'll start making a, yeah, just hold, yeah. When you're making this hook, you have to be very careful about the sinus plate. Sometimes the sinus plate is just below the hook.
See, the extra wire, the lead wire of the implant sometimes has a tendency to bounce out. So the hook that she's making is with an idea that you slip that wire under the hook so that it cannot spring out of the mastoid.
Okay, so I made it. You can see the okay. Okay, now I'll just take a diamond bar and smoothen out all the edges. And then again we will try and use a template and see.
See, you see she's making all this preparation, including she'll put the implant first before opening the round window or doing a cochleostomy, so that the amount of time that the cochlea is left open will be minimized. So you don't do a cochleostomy first and then come and do all this. Get all this ready, put the implant in position, and then do the cochleostomy so that the exposure of the cochlea is limited to minimum time.
Give me the template, please.
Sir, for the benefit of the postgraduates watching all over India, can you explain various anomalies of the anal ear, routine anomalies which encountered during clinical practice, especially cochlear implant surgery?
Before sir answers, sir, can we show the plastic implant is very well placed here?
Just see how the plastic implant is sitting there
Silicone
right in the
implants.
notch. See, I just try to move it and show that it can't be moved at all. See that? So there's no need to fix it now with sutures. It cannot move out of that because the periostal flap will push it down into that groove when you suture it, right?
This is the flap.
Okay.
Huh?
So now while she's getting the implant ready, I'll just answer your question. Almost 20% or little more than 20%, that means 1 in 5 of your patients will have some kind of an abnormality of the cochlea.
Yes.
Commonest one is called the incomplete partition 2, which is often associated with the Mondini deformity. You can have incomplete partition 1 where you have 1 1/4 turns. You can have incomplete partition 3, which is X-linked deformity, which is very rare. You can have hypoplastic cochlea type 1, 2, 3, and 4. Type 3 and 4 can be operated. You can have a common cavity. And then, of course, you have pathologies like otosclerosis obliterating the cochlea or ossification obliterating the cochlea. Besides this, you can come across anomalies of the facial nerve, which might come in your way while you're operating. So you have to be prepared to find them out already in the CT scan by studying the CT scan yourself. One important tip here, do not always depend only on the report of the radiologist. Learn to read your own CT scans. And have them hanging in the operation theater. So if at any time, especially if there's an abnormality, you can refer to them as you go along. The same thing that you do with endoscopic sinus surgery, you should do with cochlear implant surgery. Learn to read your own scans.
So there are a few more questions from virtual platforms. Can I take them?
Yeah. When she's ready, she will just take over and we'll stop answering.
Sure.
And then so while she's getting the things ready, we can ask the questions. Yeah.
Sure, sir. Please let me know.
Yeah, go ahead.
The question is, which make you prefer, like carbide or SS?
थोड़ा और करना.
But the carbide burrs cut well, they last longer, but they are more expensive.
Sure, sir. Sir, and there is one more question. Actually, they have mentioned only about the anatomy of temporal bone. So I think they want a brief clinically here from you.
About?
The anatomy of temporal bone here.
I went through the anatomy in the CT scan, if you remember. So maybe some of them were not present at the beginning.
Give me 20, 18
because I
number
went through the
section.
whole
18
anatomy
number.
on the CT scan. So
Thank you,
what
sir.
exactly in the anatomy do they want to know, if they can be more specific?
Sure, sir. We will wait for the brief question on that. The next question is from Dr. Navroz from GMCH. Doctor wants to know difference in CI surgery done for infants versus adults.
The basic steps of surgery are the same. In infants, you have to remember that even starting with the post-oral incision, you have to be careful because in very young infants, the facial nerve can be very superficial. So using an incision there or using a cautery there, you have to be extremely careful. Otherwise, cortical mastoidectomy, posterior tympanotomy, making the well, all that remains the same. Also remember that the amount of blood loss permissible in an infant is much less than in an adult. So as Dr. Valti said, being ready with your bone waxed in case there is emissary vein bleeding or something, make sure that the amount of blood loss is absolutely minimal. But otherwise, the basic steps are the same.
Thank you, sir. So the next question is from Dr. Payal. In a child with starting of a labyrinthitis ossificans, post meningitis with moderate to severe SNHI and getting benefited with hearing aid, what is the ideal time to go for cochlear implant?
If the child is benefited with a hearing aid, why would you want to do a cochlear implant? Sorry, I'm sorry, the phone rang in the middle. So what was the first half of the question? Can you just repeat that?
A child with starting of labyrinthitis ossificans, post meningitis with moderate to severe SNHI and getting benefited with hearing aid, what is the ideal time to go for cochlear implant?
Yeah, so sorry. So if you have got benefit with a hearing aid, you will wait and keep on repeating your testing. And if you find that the hearing loss, which was moderate, becomes severe, and it's proceeding towards severe to profound, then I think you know that this child is going to lose hearing in some time. So doing serial audiometric check and serial testing with the hearing aid becomes important. And if you find a steady trend of things getting worse, then I think even before the child reaches profound loss, you would want to operate because you might not be able to get a complete insertion if you wait too long. So repeated audiometry and hearing aid testing would be necessary to take a decision.
Thank you, sir. And one more question again. What is the age of child you would advise for a beginner cochlear implant surgeons to start with? So now,
Give me another between these two.
Attending workshops, assisting in surgeries, doing lots of temporal bone dissection is absolutely necessary. Once you're comfortable, if you have a child, I would say above the age of 1 year would be okay, whether it's 1 year, 2 years, 3 years. I would say don't operate on infants till you have got a little more experience. But if you have a child older than
Give me an
2 years,
hydrocod
I don't
injection.
think there is any problem at all. Below 1 year, I would say wait till you have a
20.
little more experience.
20. Okay, now we'll start exposing the round window is already exposed. I'll just see. It's a very small.
Can you see the round window membrane? Can you
Yes,
zoom in?
sir. Madam, can you show the scrotum of the round window there? With pointer.
Yeah. Okay. Third pick.
I think the round window is so nicely seen that
Yeah.
you may be tempted to go for a. That's the overhang, which is not too much.
Not too much.
So hardly anything at all. And it's a nice big round window facing you. This is favorable. So the round window is facing towards the surgeon. That's good. Sometimes you have it almost in a edgewise so that you barely see the membrane without removing the overhang. But
So
in
when I
this case,
open the round window now.
why don't you put the implant first?
Okay.
Sangeeta,
okay.
put the implant in position first before you put it on.
Give me your hydrocod.
This is what I said, that instead of opening the round window now, first put the implant in position, then open the round window so that the exposure time of the lumen of the cochlea is minimized.
The change of gloves at this stage.
Any other questions while she's picking up the implant? She's changing her gloves, and if there's any more question.
Well.
We tend to fill up that middle ear with hydrocortisone or decadron, so that when you open the cochlea, it is exposed to that hydrocort solution. The concept is that if it diffuses into the lumen of the cochlea, the amount of fibrosis that will be evoked by the implant will be minimized.
Sir, an implant patient is simultaneously having CS showing with dry ear. CS showing with dry central perforation is and posted for implant. What will you do?
If you have a dry central perforation, you don't post for implant. You would first do a tympanoplasty.
Yes, sir.
Get a good healing of the eardrum, and second stage you can do an implant. If it's a cholesteatoma and you've done a canal wall down, you could then go for a blind sac closure, obliterate the eustachian tube, close the external canal, fill the cavity with fat, wait for 3 months,
Yes,
and then open up and do a cochlear implant with a
Take a
blind
bigger
sac
one.
closure.
And there is an extensive
Now, one
cholestoma.
minute, she's putting the implant in now. Watch that.
Extensive cholestoma.
Yeah, just 1 minute. Let her put the implant in there. See how snugly it goes and fits over there.
Yes, sir.
Can you just check with the
Little anteriorly there is little
centralized.
block, sir.
Beg your pardon?
Anteriorly around the implant.
Anteriorly?
There is overhang of the implant is on the bone, sir.
Where now? No, now the implant is fitting right into the cavity. She will show you. See that?
Can you see? It's in the well. It's not moving at all.
It's not moving at all. It's flat, submerged into that well. You can see that edge of the implant is, yeah, beautifully fitting there. Very clearly seen. Centralized, please.
Yeah, hold this. I'll central.
No, it's okay. It's okay. There, can you see now?
Yes, sir.
Okay, see how absolutely snugly it is fitting over there. Beautiful. So now she can put those area a little bit aside. Now open the round window and attempt a round window insertion. If there is difficulty, she can always then make an extended round window and do it.
Okay, suction.
Sir, don't you drill the superior lip of round window in all the cases, or
block?
It depends upon the amount of overhang of the operculum. You drill it out to get a good exposure of the round window membrane. Now, in this case, I think she has a good exposure already.
Adrenaline gel foam.
You didn't have.
I maybe after opening. Okay. Yeah. Give me the gel foam, please. Saline gel foam now.
Madam, can you go for little higher magnification?
Yeah, I just controlling a little, making a little blood-free field for you. Just hold on.
Yes, ma'am.
Gel foam, please.
It would be ideal to make sure that no blood goes into the cochlea, because that will promote more fibrosis. At times,
give me adrenaline gel foam, little.
suddenly the blood appears there.
I want
when you open the
adrenaline.
cochlea. That's bad. So if you're doing hearing preservation surgery, you really can't afford to have that happen. If your hearing is already so bad, then not much difference.
So very important tip for the students also who are on a virtual platform across institutes.
What's the tip?
So whatever you shared about fibrosis and blood, because
Yeah, because
you-
blood would definitely evoke an inflammatory reaction from the cochlear lining, and therefore you would get more fibrosis. That's why we said try to put a little hydrocortisone, and they say you open the round window through a pool
Okay.
of hydrocortisone or decadron.
Give me adenine sulfur.
Tip कडे पण एक घालून ठेव.
हा. This is adenine.
So we have multiple questions again on virtual platform. So whenever you feel I can ask the questions, please.
No, go ahead till she starts opening, and if she is opening it, she'll just start talking. The moment she starts talking, I stop talking. Go ahead.
Sure, sir. So Dr. Suhas from Mysore want to know role of HRCT temporal bone in otosclerosis.
There is now a trend to do HRCT temporal bones as a routine in autosclerosis to see whether you can identify an autosclerotic focus near the foot plate. You also want to rule out something like a congenital fixation of the ossicles or even a superior semicircular canal dehiscence syndrome. I had one case where patient had a facial neuroma, and I had gone in without doing a CT scan, was faced with that situation. So I think this started in the West because of medical legal situation. So it has become a more or less routine that you should do a CT scan. But if your clinical suspicion is very strong,
Give me one.
I think we have been for years together doing autosclerotic surgery without a CT scan. If there is a slightest suspicion of something else being there, it should be done. Are we doing it as a routine now? Yes, we are doing it as a routine.
Thank you, sir. Dr. Sohail want to know how to identify the ear infection, whether it is bacterial or fungal.
Okay, I'll open the round window now.
Yes, madam.
I mean, I have a hydrocot with on a needle, 2 cc
Can
syringe.
you point out to us that if you were to do an extended cochleostomy, at what area would you be doing it?
Okay, I'll just give me a code pick.
Sir, at this moment, can you show the landmark for singular nerve, sir?
For the
singular nerve landmark here. Can
the
you
singular
show
nerve will be posterior to the margin of the round window. So,
sir,
yeah, it will have to be more posterior.
Okay, so your cochleostomy will be an extended round window. This is your anterior portion of your round window. This is the posterior, superior, and inferior. So at the antero-inferior region, you are going to extend to an extended round window.
Just show it with the suction where you would, yeah, there.
Here. Suction is blocked 20.
When you pick your hand was
Yeah.
So the singular nerve neurectomy has been advocated for.
Okay, where my suction is going to be.
BPPV.
Yeah.
Sir.
Where my suction is going to be where there's going to be an extended round window.
Okay, just inferior to the round window, slightly anterior. That means if you're looking at it as a clock and towards the pyramid is 12 o'clock, then it would be 4 o'clock, correct?
Yes.
There, that would be the your hand again comes in the way. Bend the injection needle.
Yeah.
Bend the needle.
Yeah, bend.
She's opening the round window with the.
You can see.
Yes, yeah,
Yeah,
increase,
yes, sir.
increase, enlarge.
When we can see the window also, black shade.
Yeah, you can see I've just taken
has
a.
been opened up now.
Yes, sir.
And you can see the CSF coming.
Yes, sir.
Little fluid coming out.
Yeah.
Yes, ma'am.
Code pick.
So we saw a definite endolymphatic duct over there, which didn't seem to be too enlarged, but we had a small CSF oozing out. This is not a CSF gusher. This is what you call a CSF oozer. Nothing to be worried about. Okay.
Yes.
So this is without a Mondini, in spite of all three turns in the cochlea being present. So you have an entity of an enlarged vestibular aqueduct, which is without a Mondini.
Would like to do a little
And there is a
extended round
common-
window.
And there is a
Not
common
very
cavity,
common,
sir.
not very common.
Extended round window.
I think she will attempt a insertion with a round window. If it doesn't work, then she will extend it. Okay.
Okay. I think I should little open.
For a CSF,
I beg your pardon.
sir, is
There
this
is a common cavity.
CSF gusher?
This is a oozer. This is not a gusher. A gusher, it rushes at you.
Sir, is this perilim for CSF, sir?
Same.
This is ultimately CSF because coming through the scalar tympani maybe from the round window area, because perilymph quantity is not so much that it will keep on oozing out like this. The quantity of perilymph is very little.
So roughly in how many patients we see the gusher?
Yeah, a little. Take a bite. Try.
I would say, as I said, in about 1 in 5 to 6 cases, sometimes you get a little fluid coming out.
Hydrocone.
Even in stapes surgery, we call it perilymph gusher, but it is never perilymph. The quantity of perilymph is not so much that it will keep on coming out.
And how to deal with it, sir?
We have to just plug it, no problem. She will show you. She's going to attempt a round window insertion. If it doesn't work, then she will do a cochleostomy. Okay. But she's taking the implant. You can see it's a full banded implant. And see how she manipulates it with her hand alone right into that opening. Beautiful. It's just like threading a needle. And now she'll take a forceps. Now the direction of pushing is not towards the modiolus. That happens in varia. Here the direction of pushing is towards the outer wall of the scala tympani, and it's going in. You never put in all the rings. The last 10 rings are stiffening rings. So you will tend to leave about 5 to 6 rings at least outside the cochlea. Okay. If you put all the 10 stiffening rings in, then that your basal turn would be only stiffening rings and not active electrodes.
Okay.
Where is the retrograde insertion is indicated, sir?
Excellent insertion, ma'am.
Retrograde insertion.
What do you mean by retrograde insertion? I didn't get it.
Electrode array retrograde insertion, sir, when it is difficult through this antigrade.
Let's all give a very big hand to Madam for that fantastic insertion.
Thank you very much.
So what we'll do now is just check with a C-arm that the insertion is okay, and check with the electrical testing that the responses are okay.
I'm just pushing in 1 or 2 electrodes inside.
Huh?
Just pushing 1 or 2.
Yeah, but she's got about 5 or 6 electrodes outside, which is what we want, so that the basal turn has all active electrodes and not just stiffening rings. And she will just show you how to seal that. So Janki, we need about 5 minutes more, and then we are with you. Okay.
So does this
Please take your time, sir. Please take your time.
Does this electrode has an indicator?
No, the ring is outside. You can count the number of rings.
Yeah, I'll count the
You have
rings.
a white or a blue dot over there. She can actually count the number of rings that are there outside. There are
2,
about 6,
3,
7
4, 5, 6.
Yeah, 6 rings are outside, 4 stiffening rings are inside. So we've got a good insertion. And we will know that our insertion is complete when we do the NRT. So
this is how you plug it.
Okay.
With connective tissue, she will plug it, that connective tissue which she had taken out earlier. Okay.
So one more question.
Yeah.
Does the electrode should be on the outer side of the canal? Or
I beg your pardon?
So should it be on the outer side of the canal? The electrode,
which
electrode.
Of which canal?
I mean, inside the window, when you place it.
Yeah, it goes and lodges itself on the outer wall of the scala tympani. These are all outer wall electrodes. This is a straight electrode, not a contour. Contour or a 632 or a mid scalar of AB would go towards the modiolus. These will all lie on the outer wall. See how with the connective tissue she has effectively blocked that CSF leak. Can you see that? So now she will show you the use of that little hook which she had made Go to the lowest magnification.
Block.
Okay.
Okay.
Go to the lowest magnification. And show how the
Okay,
electrode
so now this is your electrode and this is the hook. Very gently go underneath the hook. Okay. And place the hook. Place the array inside the mastoid which you have drilled.
beautiful.
Okay. Now we have a ground
So
electrode.
now the array now stays inside the cavity. Okay. And the array will just remove the retractor.
No,
And
no, I
the
want
array will be put in a tunnel. We'll just put a little
no,
gauze
I want
piece
a
on this.
forceps. I want a
We'll do a
forceps.
C-arm picture.
And I put forceps. Please.
And we will do the neural response.
Okay. Now this is the ground electrode.
That has to go and lie under the temporalis muscle.
Sir, can we know the position of the electrode array by doing cone beam CT or intraoperative CT?
Yeah, right
Take
now
a
we are
reference.
just doing a plain image intensifier picture.
Sir,
Give me a master. Give me a periostem elevator.
So are there any helpful tips to identify round window in difficult cases? Dr. Gautam from Guwahati wants to know this.
Once you see the inkidostapedial joint, about 2 to 3 millimeters below that, you know, inferior to that is going to be the round window. At times it's difficult if the facial nerve is coming in the way. You saw that Dr. Sangeeta, what she did was it thinned out the posterior canal wall, made a nice big funnel, a large posterior tympanotomy. But there would be difficult situations where the round window hides behind the facial nerve. So there are various things that you can do. You can do a little extended posterior tympanotomy. You can decompress the chorda, push it in front. Sometimes, very, very unfortunately, the chorda may need to be sacrificed to get a better view. Or you could even go superiorly, remove the incus, and from the incus buttress, from a superior area, try to see the round window. Then, as somebody suggested, you could fracture the posterior canal wall attached to the skin of the external canal and push it forward, do your surgery, and then push it back as if you're reconstructing the posterior canal wall. And lastly, if you can delineate the facial nerve confidently, then you can go medial to the facial nerve and enter the middle ear retrofacial. So these are some. And lastly, of course, if you can't do any of this, then do a complete removal of the posterior canal wall of the external canal skin and the tympanic membrane. So canal wall down, mastectomy with a subtotal petrosectomy, and then a obliteration of the eustachian tube and putting fat, abdominal fat, and closing the external canal so that you overcome the problem of a round window which is difficult to visualize. But usually if you do a little extended drilling there and tilt the patient around, then you would be able to see it.
Now the flap is nicely covering the.
yes.
Now see the flap, see how it's covering
Yes.
completely. Not only
Step-
that, but like an apron, that flap also pushes against the package so that the receiver stimulator which you have put into that well with this is getting pushed into that little receptacle which she has created. So now there is absolutely no chance. And the other beauty of this flap is, see, it's without any kind of tension. The whole implant is getting completely covered. The suture line is not under pressure.
So there's one question from Dr. Vanilla.
Yeah.
What are the precautions to be taken to avoid displacement of the electrodes?
Avoid displacement of the electrode. You saw how she fitted in that thing under the hook, right? So that prevents the bouncing out action of the electrode array. That is what can lead to the electrode getting extruded. And secondly, when you seal the window, When you seal the window, make a tight seal so that that also prevents the electrode from bouncing out. Formerly, we used to make a little notch at the fossa incudis area and push it in through that. But with this little hook that we make on the cortex, I don't think that is really necessary. I think we'll just stop the closure here for a moment, put a gauze piece so that they can do the NRT, and then we can move on to the next case. See the periosteum there being sutured. So this is important to get a periosteal cover on the mastoid so the postoral scar does not sink into the mastoid, okay? That is the disaster waiting to happen. If the postoral scar sinks into the mastoid cavity, then it will go and touch the electrodes and extrusion is possible. So this is a nice tight periosteal closure. She put a little wet gauze on it. Move the microscope out of the way. We'll just shoot a picture.
And see, you can see the covering.
See how the implant is completely covered by the flap. Can you see that?
Yes, sir.
And see, nothing of the implant is exposed, completely covered. Okay. I think she deserves a big hand for this, guys.
That draws for an applause from the.
Welcome.
So thank you for
A very, very big round of applause, please.
so much, sir. Thank you, ma'am.
Thank you very much.
Yes.
Thank you,
So
sir.
now
Thank you,
we
ma'am.
just cover it with a little bit of plastic.
Surgery and the wonderful
you, madam.
teacher standing there.
Madam, you demonstrated CA like tonsil.
Yeah.
So if
No,
there is-
no, no.
So if there is one take
No.
home point, that should be that you have to understand and study the radiology first.
Excellent demonstration.
No, but it has to be the mentor is behind me. So maybe that is why I could do it.
Mentor is behind everybody, madam.
Both mentor and mentee.
I also
Excellent.
learned CA from sir only.
So there are a few more questions.
Yeah,
Can I
please
take
shoot.
them?
Go ahead.
How many millimeters
Doctor-
lateral to stapedius muscle
I beg your pardon?
facial now?
Sorry.
How many millimeters lateral to stapedius muscle can we?
That's variable. That's very variable. There's no standard. It's always posterior to it, but that distance can be variable.
Posterolateral
1 minute. Let them see the impedance.
or
Yeah, and also pyramid
Yeah, impedance. Yeah, back.
is filled with the muscle tendon, and then it goes in the inferior direction.
yes, sir.
You
So
can
can
see.
you see just before you go? Can you see the impedances done? All the impedances are completely okay. Can you see that?
Beautiful, beautiful.
And they're all below 10. And now we will do the NRT. We'll just show it to you for a couple of electrodes and then let them shoot the C arm. And then the closure we will do while you go on to the next case. So she's running the neural response telemetry now. So the stimulus is given and the response is being picked up.
Take it down.
Look at this one. You've already got the wave coming there. Can you see that? Can you zoom in? Zoom out a little bit because the response also has to be
Black,
shown on
the
the
yellow,
chart. So
yellow.
you can see the
Yellow.
response here coming at about 150, 158, 160. This is the apical area. The basal area, usually you get it at a little higher current level. But there it is coming there as well. Beautiful. You got a response. And what is important is that the response should be linear. So this should not be too much up or down. You should get a nice linear response to tell you that things are okay. There comes the response and it's coming down. Can you see this? Nice linear response. So we will stop this. We can just do the C-arm shooting and that's the end of the demonstration. Thank you very much, all of you. And
Thank you very much, sir. You get blessed from the auditorium.
I'll be seeing you guys in the evening today.
Sure, sir. Thank you.
Sir, it's a very big honor, sir. Very big honor. Really, really, no words to thank you, sir. And we're eagerly waiting to meet you here in Hyderabad, sir.
Thank you very much. So Janki, now you know why I said Dr. Sangeeta will do the surgery.
Sir,
Right?
I mean, when you
It
say
was absolutely flawless, absolutely flawless, sir. Beautiful demonstration.
fantastic, sir. Fantastic. Really, really impressed. So sweet, sir. So nice, so nice.
Oh,
Thank you, sir. Thank you. Will she also come, sir, along with you today?
no, I think she's got a lot of other things to catch up on.
Oh,
We'll meet
Okay, okay.
we'll meet some other time, definitely.
Oh, it's a pleasure, madam. Please, please, madam.
Okay.
Thank you so
So
much,
now we are
madam.
all going out of the theater because we are shooting or we are being protected by these guys wearing.
Thank you.
armor.
Yeah, 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 yeah.
Went well.
And
Thank you
Went
so
well.
much.
I thought it's when I said REST मेरे को टेंशन आया
okay.
हाँ बहुत दिन से REST किया नहीं हाँ टेंशन होने वाला हाँ
What a beautiful insertion.
REST
You
बहुत
look at the
इतना कमी
camera.
नहीं
I just wanted you to see the position of the.
अरे वाह अच्छा वाह वाह बढ़िया आया no curving no kinking no curve
See this angle which is given. This is what we call the cochlear view.
no kinking
Automatically
nothing
accurate to the patient.
I wanted to push but then sir said don't push now only 6 are outside
So your mic,
Sir, your mic is not audible, sir.
Can you hear me now?
yes,
Yeah,
sir.
yeah, better, better.
Yeah. Can you zoom in a little more? See this. Zoom maximum. अजून कर ना zoom.
हे पुढे गेम
तू पण पुढे ये ना जरा भाऊ.
Sir, I have a question for you, sir.
या माझ्या बोटावर फोकस कर. या जानकी.
Sir, you have made sure you have gone through the round window and the insertion is so sweet.
Yeah. Can you see the electrode? Can you see the implant now?
Yeah, very nicely seen, sir. I just want to know whether this C-arm is mandatory for every case or is it, I mean, why do you do this? I mean,
See, we are a teaching institute and we also do a lot of workshops where I want to impress on people that the only certain way to know that you are in the round window is in the cochlea is to do the X-ray. If you've got responses, you've been sure of your insertion and you're an experienced surgeon, you may not do this. But to all beginners, I would say do it because there have been instances where the implant has gone into the basal turn of the cochlea and has got curled up, tip curl over, or sometimes it has gone into the vestibule. And if you send the patient away that way, it's a disaster. So if you've got everything smooth, if you're experienced, you may not do it. But as a teaching institute, and you know that I do training workshops and I've mentored a lot of surgeons. I tell them, if you do it, you're 100% sure. Also, especially in an abnormal cochlea with CSF leak, it has happened in the past that the implant was pushed out over a period of time. Here you have proof that you have put the implant in correctly. Later on, because of a fall
medical
or injury,
legal issue also.
Yes, the implant comes out. The patient says you never put it properly. You've got the X-ray to back you up.
Okay, sir. Okay, sir.
Thank you very much. Till today
Thank you, sir.
evening. Bye.
Thank you, sir.
Thank you very much, sir.
Dear audience, there are multiple questions, but because of the consent of time and our next surgeon is waiting, so we will try to take them next if time allows. Yes.
So I think we'll be going on to the next surgery.
We are giving bucket to this person. Later. Now we'll go for the next case. Introduce the next case.
Thank you, panel members, for chairing this session. We would request all the panel members to be available in the evening for the felicitation. Next, we have parodectomy surgery demonstrated by Dr. Prathamesh Pai, sir. Dr. Archana will be introducing, sir.
It will be again an honor to introduce this versatile surgeon again. Dr. Prathamesh Pai, we all are aware about his details, but I feel that it is a small formality, at least to have a brief about him. He's professor, Department of Head and Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. Officer in charge for Homi Bhabha Cancer Hospital and Research Center, Punjab. President for Foundation for Head Neck Oncology, India. He's a teacher for MCH. This I'm mentioning particularly for the students who are online. He's a teacher for MCH for Head and Neck Surgical Oncology, which is a 3-year training program and recognized by MCI. He's a versatile surgeon, we all are aware. but his special interests are in laryngeal and skull-base surgery with focus on laser and minimal access. Again, a faceted expert, reviewer, investigator, teacher, IRB member for Tata, co-editor for a monograph on surgery for larynx and hypopharynx. He was awarded Hargovind Medical Fellowship for minimally invasive endoscopic surgery of skull base and pituitary at Pittsburgh University, USA. This is just one I'm mentioning, which is in 2007, but n number of other honors and awards in his kitty. So I welcome Dr. Prathamesh Pai, and it is my honor to welcome him for this forum.
I would like to add a few lines if you don't mind.
Sure, sir, please.
Actually, I am sitting in the scan center of tomorrow's case. It's a hemangioma in the frontal lobe. So I just want to discuss with my radiologist. So I'm sorry. Anyway, I'm on Zoom meeting. I want to introduce Dr. Prathamesh Pai. When I asked him, sir, what case would you like to demonstrate? Of course, he's the dawn in all the head and neck cancers. I wanted him to particularly demonstrate parotid. And when I asked him, he said, we will do an overall management, like, we'll bring in the facial nerve monitor. It's going to be a team which is going to talk about this whole surgery so that the whole overall 360-degree perspective of this surgery will be brought out. I really have a personal rapport with Dr. Prathamesh ji, one of the fantastic surgeons, but more importantly, a great human being, very affable and a perfect gentleman. Over to you, sir. Without much ado, we will start the parotid surgery.
I love a mic.
Thank you, sir, for this wonderful introduction. Along with Dr. Pai, Dr. Anuja Deshmukh, Dr. Richa Vaish, and Dr. Parthiban are also there in the operating team, which are giving us this clinical pulse today.
Good morning, everybody, and thank you, Janki. Can you hear me?
Yes, sir, very much.
Yeah. So what we have done is we have got together our colleagues at Tata Hospital in order to give you a good perspective about the management of parotid tumors. And we have got a good case for demonstration, a pleomorphic adenoma, wherein we will be able to demonstrate all the techniques that we practice in order to remove the tumor completely and save the nerve. So what we will do today is our entire team will focus on what is the characteristics of this tumor, how we use intraoperative nerve monitoring in order to preserve the nerves, and then go on to discuss the steps of the surgery. So our team today with us is Dr. Anuja Deshmukh, who is our professor in head and neck surgery, Dr. Richa Vaish, who is our associate professor, our surgical team colleagues, Dr. Vidula, who is our senior resident, and Dr. Anup, who is our senior resident, our anesthetist Sakshi and Rajni, who will be operating with us, and our physiologist, electrophysiologist, Meenakshi.
Oh,
so
hello, madam.
This is our team,
hello,
and I hand over this to Sukada. Our anesthetist Sukada will tell you about what are the nuances for the anesthesia during intraoperative nerve monitoring. So what we have done is we have recorded certain steps prior to this, and we will first tell you about the anesthesia followed by the intraoperative nerve monitoring techniques.
Sir, can we introduce the panelist before we start with the surgery?
Yes, please.
Yes, sir. Thank you. I would like to invite Dr. Sridhar Reddy, sir, formerly worked in KMC Manipal and Usmania Medical College and Hospital, presently working as professor and HOD at Apollo Medical College, Hyderabad. Dr. Vanilla ma'am, professor in Shadan Medical College, consultant ENT surgeon in Omega Hospitals, Hyderabad. Dr. Sameer Deshmukh, sir, director of ACE and Deshmukh ENT Hospitals, senior consultant at Doodh Hospital, Aurangabad. Dr. Sampath Kumar, sir, professor and HOD of ENT Usmania Medical College and Hospital, Koti, Hyderabad. He's also a guest speaker in various conferences. And Dr. Prasad Kelkar, sir, HOD of ENT Department, Ashwad Rural Medical College, Sholapur, and consultant ENT surgeon at Kelkar ENT Hospital, Sholapur. And our moderator for this session is Dr. Nageshwar Rao, sir.
Thank you.
Thank you very much, the panelists and the moderators. I know quite a few of them, Prasad and Samir. I've known them closely.
Hi,
And
Prathamesh. Nice seeing you after a long time.
good to see you. Yeah. So I'm just waiting for our anesthetic. Okay. So we'll just start with the case presentation. Vidula.
Prathamesh, can you hear us?
Yeah, we can hear you.
Yeah, we'll be disturbing you, interrupting you in between, okay? With a lot of
Absolutely.
questions. Yeah.
So what we are doing, Prasad, is we are going to start with the case presentation. Then we'll give you a brief overview of the intraoperative nerve monitoring. And then we'll have a talk on the various nuances of the management of parotid tumors. And then we will showcase the surgical steps so that we have all the discussion happening in stages. So over to Vidula. Yeah, Dr. Sukada has come. Maybe she can talk to us about the anesthesia in context to the intraoperative nerve monitoring. This is very important because as we go ahead and we practice intraoperative nerve monitoring in our surgeries, we will ensure that we get good outcomes. Intraoperative nerve monitoring is being used in a bigger way in redo surgeries, in malignant tumors, and more often than not, it helps us identify the nerves towards the reconstructions. So as we move on to improving the quality of life of our patients, it's no longer sufficient just to remove the tumor. So identifying the nerve steps, even nerve endings, even though you may do reconstructions later, it might be useful in order to do the anastomosis at this point. There have been a lot of techniques which have been discussed regarding the use of the nerve to the margin, to the masseter, wherein it can be connected to the facial nerve instead of the hypoglossal, so that you can have better conduction and a nerve supply which is in sync with the facial movements. Prasad, do you have any questions till they are ready with the presentations?
Hi, Prathamesh, Samir here.
Yeah, Samir.
Yeah, before you start, can we have a brief idea about the patient?
Yeah, so that's what we are doing. We are just putting, they were all ready, but I think they have just shut down the computer. They're restarting that. So they're going to tell you about the case and the case capsule. Just bear with us for a few minutes.
Yeah, Prathamesh, hi, Prasad here. Meanwhile,
Prasad.
I just wanted to ask you, I mean, how you put the nerve monitor pre-operatively, what all the techniques you use, where you insert the electrodes. We just want to know that.
Yeah. So all that we are going to have,
Okay, you are covering everything.
we will also show you what we have done in this patient, but also give you a brief background with a few talks.
Okay.
So there is one more question. In case the
Yeah.
is curled inside the cochlea, what is the next step? Dr. Muthukumar from Chennai wants to know this.
Sorry, can you repeat that question? Yeah. Are you ready with the presentation?
Today we are going to demonstrate a case of a superficial paradigm with intraoperative nerve monitoring.
वो नहीं दिख रहा है. Can you hear us?
Yes, sir.
Yeah.
Yes,
Yeah.
sir.
Okay.
Surgical field is comprised of Dr. Prathamesh Pai. He is the head and professor, pediatric surgical oncology. Dr.
Can you speak little loudly? We are not hearing you properly.
Yes, sir.
Yeah, this is better.
Our surgical team is comprised of Dr. Prathamesh Pai. He is a head and professor, head and neck surgical oncology. Dr. Anuja Deshmukh, she is professor. Dr. Richa Vesh, she is associate professor. I am Dr. Vidula Mestri, senior resident. And Dr. Anup Srinivas, he is a senior resident. Anesthetist is Dr. Sukhada Savarkar. Electrophysiologist, Dr. Parthiban, he is a clinical neurophysiologist of surgical oncology department. Scrub nurses are Miss Rajani and Miss Sakshi. This patient is a 51-year-old lady, resident of Mumbai. She is a housewife and presented with a chief complaint of swelling in front of left ear of 1 year duration. Swelling was insidious in onset. It was of almond size to start with, and it gradually increased in size to a present size. There is no history of associated pain, no facial deviation, no history of increase or decrease in the size of the swelling associated with limbs. There is no any history of previous surgery on head, neck, scalp, eye or eyelid region. She is a case of hypothyroidism and she is on thyroxine supplementation. No history of addiction and no significant family history. On examination, there is a ill-defined lesion in the left tail parotid region, which is antero-inferior to the lobule, with lobule in normal position. Lesion is approximately 1 × 2 cm. There is no visible scar or sinus present. Swelling becomes prominent on clenching of teeth. Inspectory findings confirmed by palpation. Swelling is firm in consistency. Swelling is firm in consistency. It is mobile in both vertical as well as horizontal direction. It is non-tender. Overlying skin is free. There are no palpable cervical lymph nodes. Facial nerve function is House-Bragman grade 1. Ultrasonography was done. We showed well-defined lesion. Ultrasonography was done. We showed well-defined lesion, which was solid, hypoechoic, measuring 1 × 0.7 cm, without any internal vascularity, without calcifications, no any suspicious cervical lymphadenopathy, and it was Milan 4A grade. Contrast enhanced MRI was done. These are the videos of T1 images with contrast in an axial and coronal plane. This is the axial image which is showing a well-defined homogeneously enhancing lesion in a left-sided parotid. Similar is the coronal image which is showing lesion which is localized to a tail parotid region and it is not extending into the deep lobe of parotid. This is a coronal image which is showing homogeneously enhancing lesion well defined in the tail parotid region which is not extending into the deep lobe of parotid. This is the still image of both T1 contrast in an axial and coronal section.
Can you define it on a screen? Because we are not high.
I think there is some lag, Samir. I think, yeah, now you are able to see?
Yeah. This is better.
Okay. So you can see that that nodule, which is appearing enhanced, it is in the pre-parotid. You can see the image on your left shows beautiful the vessel, that is the retromandibular vein.
Yes.
And the nodule is just above that.
Yeah.
And that is very critical for us to understand the relation of the nodule or the tumor to the retromandibular vein. So the image on your left, on your right hand side shows a nodule just above the retromandibular vein. And that is so classic. And this will help you plan out whether you would encounter the facial nerve in close proximity to the nodule. So here you can see it is far away. Yeah, go ahead, Vidula.
Yes, sir. Ultrasonography guided FNSE showed myoepithelial rich salivary gland neoplasm which favors pleomorphic adenoma. So the diagnosis is pleomorphic adenoma. So the diagnosis is pleomorphic adenoma of left parotid gland. Our treatment plan is surgery, which is superficial parotidectomy, and we'll do it under intraoperative nerve monitoring.
So you want to have some discussion at this point, Samir, or the interop we will discuss?
Prathamesh, Prasad,
Yeah.
I want to ask you a few things. I mean, regarding the investigations, would you always like to do MRI or you can operate with USG only?
So there is a different take on this from various people. One is that in a pleomorphic adenoma, you would want to differentiate a solitary from a multicentric disease. So for that reason, some people might do MRI. Ultrasound will tell you about the nodules, but it will not give you a clinical perspective of the relation to the vessels, to the masseter, as well as if it is in the deep lobe in relation to the carotid and the IJV. So if you have a lesion which is clearly mobile, it's in the preparotid region. There is no elevation of the ear lobule. There is no skin involvement. There are no signs of malignancy like pain, no palsy. Then you do not need to do an MRI. So it is sufficient to understand what is the nodule, whether there are multiple nodules or a solitary nodule, and you can explain to the patient that our surgery doesn't change. We will do a superficial parotidectomy. Now, moving on, if you are believing in the philosophy of an extracapsular dissection, when you do an extracapsular dissection, you want to be sure that the surrounding tissue is normal. In that context, you would be better off having an MRI. So it all depends on whether it's a benign or malignant, whether it is freely mobile or adherent, and whether there are any signs and symptoms, signs of a malignant tumor. So for those considerations, then you would decide whether you would want, in addition to an ultrasound, an MRI.
Okay, what is your take on, I mean, the swelling in the parotid? I mean, I had one case where we opened it as a pleomorphic adenoma, but ultimately it was a facial nerve neuroma. So is it possible to differentiate between two on MRI?
Absolutely. So this is actually the exact indication. You would have known that this is not arising from the parotid tissue. You would have known that this is coming from the nerve. You would also know whether it's located extratemporal within the stylomastoid foramen or it is coming into the vertical part of the facial. So with the MRI, you would be better armed in order to counsel the patient and perform the surgery.
Okay. Now regarding FNAC, would you always like to go for it?
So we do practice FNAC, and we have got a lot of evidence in literature which suggests that. And I think Richa will talk on that in detail. I think we can move on to the anesthesia for facial nerve monitoring, Samir, and then we'll move on.
Prathamesh, before that, how much you rely on sonography? And can you just elaborate us on positive curtain sign? I mean, something like that?
I am not aware of this curtain sign. I'm hearing this very often now on a lot of these forums that we are having, conducting the case presentations. If anybody else would like to talk on the curtain sign. Prasad, Samir, do you know anything about it?
I mean, I have heard about it as far as the aerated pulmonary tissue, there's some hollow around it. But in the parotid, I have recently come across this. I thought you are the right person to answer this.
Unfortunately not. So we are still sticking to our time-tested signs and symptoms.
Okay, we can go ahead with the anesthesia.
Yeah. Sukada.
Good morning, everyone. Am I audible?
Yeah.
Yes, ma'am.
Yeah, good morning, everyone. Thank you, Prathamesh, sir. So as sir pointed out correctly, now neuromonitoring is becoming more and more common during the head neck surgeries as well. And this is one surgery where a good communication between the surgical team, anesthesia team, and the electrophysiologist is quite important. So just to give a little brief about intraoperative monitoring. So basically, IONM is done to detect or prevent neurological damage during various surgeries, especially neurological surgeries and now head neck surgeries as well. So different modalities of IONM are available. So one basic modality is the EEG or electroencephalography. And the other modality is evoked potentials. So evoked potentials means we either give a electrical or sensory or motor stimulus, and the generated potential is measured, and the latency and amplitude of that potential determines whether there is nerve injury or the nerve is intact or any neurological tissue is intact or not. So various electrical evoked potentials are there. For example, somatosensory evoked potentials, motor evoked potentials, brainstem auditory evoked potentials, and visual evoked potentials. For example, in SACP, basically a peripheral nerve is stimulated, and the response generated is measured at different levels of the central nervous system, either in the spinal cord or at the cortex or at the subcortical level. In motor evoked, a motor stimulus is given, motor response is generated. In brainstem auditory, the auditory stimulus is given, or in visual, a visual stimulus is given. And the third form is electromyography. So in parotid surgeries, we are concerned basically with the electromyography. So in electromyography, basically a cranial nerve or any peripheral nerve is monitored to detect any neurological damage during surgery because of any various reasons, either because of the surgical traction, surgical damage, systemic problem, hypotension, or any other reasons. So what are the different implications of anesthesia for EMG monitoring? Yeah. So during parotid surgeries, facial nerve is monitoring. Also, laryngeal nerve is monitored during the thyroid surgeries, right? So what are the anesthesia implications? So first and foremost, muscle relaxants need to be avoided because it is an action potential which is generated after stimulating any particular nerve. So that means the neuromuscular junction transmission has to be intact. So muscle relaxations is avoided generally. Regarding intravenous or inhalational, generally EMGs are okay. They are intact even if we use intravenous or inhalational anesthesia. If we have to choose, then inhalational anesthesia suppresses EMGs more compared to intravenous. So generally a TIVA, that is total intravenous anesthesia modality, is used, but we can also use inhalational anesthesia provided we have gas monitoring and provided we can maintain the MAC below 1. MAC is basically minimum alveolar concentration. So we have to maintain the MAC below 1. So in short, if we have to summarize the anesthesia implications, we have to avoid muscle relaxation. We have to maintain MAC of inhalational agents less than 1. We can give intravenous agents, for example, propofol or thiopental, and opioids like fentanyl, morphine can be given. More importantly, one thing important to remember is during intubation, we can give short-acting muscle relaxants because the effect is going to wear off when the actual nerve monitoring will be started. Also, very important is the real-time communication between 3 teams because, for example, it might happen that patient starts coughing, bucking during the surgery, and the anesthetist may have to give a short bolus of propofol, and suddenly the amplitude of EMG might reduce. But if I have communicated this to the surgical and electrophysiological team, then we can wait for some time and the nerve monitoring can continue. I think there is some connection problem, but yeah, in short, basically for EMGs, that is the gist of it. Thank you.
Thank you, Sukada. Any questions, Samir, Prasad?
So in summary, you give muscle relaxant during the intubation, and after that you don't give and continue on TIVA. Is that right?
Yeah, so generally our approach is like that during intubation, we will give atracurium, which is a short-acting muscle relaxant, and the effect generally lasts for 20 to 25 minutes. Then then before giving the next dose, I would communicate it to the surgical team, and if they're still far behind the nerve monitoring, then I can again additionally give a muscle relaxant dose. So it depends on the stage at which the surgery is really.
Okay. Okay.
So Prasad, just to interject at this point, if you are doing a neck dissection and you are not going to be using nerve monitoring, you should ask them to give relaxant because your neck dissection becomes easier. Having a muscle twitching all the time when you are doing the surgery, it can be disturbing you, and you might make a buttonhole in the vein and all as you go close to the IJV. So plan out your surgery, discuss with the anesthetist at what stage you want the relaxant, and then plan your monitoring at that point.
Okay.
So now we will just move on to the intraoperative nerve monitoring basics, and we have Meenakshi who will tell us about the electrophysiology.
Sir, can you comment on microscopic parotidectomies when compared to the conventional parotidectomies by general surgeons?
Yeah, so there is a lot of discussion that's happening in the WhatsApp groups. I'm seeing that whether you should use the microscope or the loop or the endoscope. So what you need to understand is that your surgery is revolving around preservation of the facial nerve and its branches. So if you can identify the nerve with your naked eye and then dissect and preserve like all other surgeons were doing in the past, there is no problem. As you are going closer to the nerve and you want to then dissect the tumor from the nerve, at that point you will need magnification. So at that point, either use a loop, or if you have a microscope in your operating theater, use a microscope, and that will certainly give you a better control on the nerve preservation. So there is no hard and fast rule that you have to use microscope or the loop. It depends on the surgery as well. If you have a lesion like this, which is freely mobile, which is far away from the facial nerve, I'm sure all of us can do this surgery safely without any magnifying tool. But having said that, what I urge all the residents today is to practice using loops from the beginning. If you are not conversant with the usage of loops, then later on it becomes difficult to adapt to it. So I would recommend all to use magnification, because magnification and illumination has changed the way we are practicing our surgery today. So over to Meenakshi.
Good morning, all. Am I audible?
Yeah, you are audible.
Okay.
Yes, madam.
So here this is a brief presentation about intraoperative neurophysiological monitoring in parotid surgery. Myself, Meenakshi Sudeep, I'm neurophysiologist here. What is intraoperative neurophysiological monitoring, or IONM? It is the electrophysiological method to monitor the functional integrity of certain neural structures during the surgery, and to reduce the risk to the patient of iatrogenic damage to the nervous system, and or to provide functional guidance to the surgeon. Rationale of IONM: to prevent new neurological impairment, reassurance to the surgeons about the neurological status, and to modify the surgical strategy. Surgeon's main concern: is the nervous system still intact at that point of the surgery, or can tumor be removed without causing damage to normal tissue to ensure safe maximal resection? So our concern is to monitor the patients during the course of surgery, give a continuous feedback to the surgeons regarding the status of nervous system, identify false alarm, and prognosticate post-operative outcome. Who needs IONM? For the clinicians who are transforming from generalist to specialist, junior clinicians, surgeons who are facing complicated surgery to preserve the neural functions. So these are the anatomical landmark of facial nerves exterior branches. So here it is the parotid gland, submandibular gland, and sublingual gland. So these are the 5 terminal branches, out of which 4 we are monitoring. First one is temporal branch, next is zygomatic, buccal, and marginal mandibular branch. So these are the placement picture. So here you can see temporal branch is innervating the muscle frontalis. So we'll be placing electrode over the frontalis muscle, followed by zygomatic branch, where we are placing electrode over the orbicularis oculi muscle, and the buccal branch we are placing electrode on the orbicularis oris, and for marginal mandibular branch we are placing the electrodes over the mentalis muscle. Now these are the stimulation parameters. So stimulator, we are using a monopolar stimulator, which is of 0.1 millimeter pole, and the frequency rate of stimulation is 2 to 4 hertz, and the duration of pulse is 100 microseconds. So the current strength is 1 milliamp, which will go down to 0.1 milliamp. The various recording parameters are even threshold or sensitivity, which lies between 100 to 500 microvolt. It is for the better visualization of the amplitudes, and low frequency settings of 30 Hertz and high frequency settings of 500 Hertz, which is already default setting in the machine, and time based or 25 millisecond per division. So this is an image of facial nerve main trunk stimulated at 0.2 milliamp current. Now the event interpretation and caveats. Neurophysiologists must differentiate true EMG event from artifacts. The artifacts can be caused because of monopolar or bipolar cautery or other surgical instruments. Neurophysiologists must understand true EMG waveform characteristics, EMG amplitude, and current surgical strategy. Risk of facial nerve monitoring includes false positive and false negative events. False positive events include change or absence of EMG response amplitude, but normal facial function post-operatively. So this can be excluded. This may give surgeons false sense of insecurity and alter surgical decision. The change or absence does not mean that stimulated tissue is not facial nerve. This is related to machine connectivity issues, stimulator ground or reference electrode related current delivery issues. False negative response. Normal or no changes in EMG response, but facial paralysis post-operatively. This must be judged properly. This may give the surgeon false sense of security. The normal or no changes means that stimulated tissue may be facial nerve, but needed to be double checked. This can be related to electrosurgical unit, bipolar specifically, and make sure to delineate other electrical equipment related artifacts that can mimic as true EMG response. So this can be analyzed based on EMG morphology also. Thank you.
So this was a primer in the electrophysiology for the nerve monitoring, and I think all of us need to know this as we go forward. The false positive and false negative are the issues that we need to tackle, and especially loss of signal. When you encounter a loss of signal after you have dissected, then you are wondering whether you really have an intact nerve or is it actually loss of signal. So there are troubleshooting measures that we will use in order to understand whether this nerve is intact or not, and as we will discuss that during surgery. So I'll move on to Anuja. Anuja will talk to us about the intraoperative nerve monitoring and how we will troubleshoot during surgery.
Sir,
Anuja.
Hello, sir.
Yeah.
Where do these electrophysiologists come from, sir? Because in an ENT setup, I'm seeing for the first time an electrophysiologist. Can you enlighten us from where do they come and how do we get them?
Sorry, can you speak a little louder?
So where do these electrophysiologists come from, sir? In ENT OT, I'm seeing for the first time. So
Right.
can you enlighten us what their qualification is and what they do and how they do it?
Meenakshi. Yeah.
Hi. So I have did my bachelor's in neurotechnology. So it's a allied medical science course. So it focuses on all these diagnostics things in neurology and neurosurgery. So intraoperative neuromonitoring is also a specialized part in this course. And this course is available it's in India as degree course, 3-year or 4-year bachelor's course, and also master's is available.
So yeah, go ahead.
So after doing this bachelor's in neurotechnology or neurophysiology, we can work as neurophysiologist in various institutes as IONM specialist and also in normal clinical side like EEG technician or nerve conduction study technologist.
So at Tata Hospital, we are using the electrophysiology in a big way. It came via the neuromonitoring. The neuro-oncology setup required that the electrophysiological states, the awake state, the motor component needs to be monitored. And now they're doing awake state surgeries wherein they will use the testing intraoperatively as they are identifying the tumor around the cortical white tracts. And the electrophysiology is an essential component of these surgeries. So we are now blessed with having a good electrophysiological team in the department of surgery, which will be used, but it is now being used by almost all the sub faculties, specialities. thoracic surgery, head and neck surgery, urology, the facial plastic surgery, and neurosurgery. So you can see that once you have got these tools, it can be having a very widespread application. Anuja?
Good afternoon. This is Dr. Anuja from Tata Memorial Hospital. I will be talking about the surgeon's perspective regarding the intraoperative nerve monitoring and just giving the brief idea about the evidences also for the intraoperative nerve monitoring. So as in our hospital, like how it has entered in our hospital is through the neurosurgery side. So the role of this monitoring is very well known for the skull-base surgery and cerebropontine surgeries. The parotid surgery has been the challenging surgery due to its close proximity with the facial nerve and its branches. The incidence of facial nerve paresis is very high in revision cases and mainly in the malignancy cases. So the rates are about 20 to 65% for the temporary paresis and the permanent 0 to 7%. However, this monitoring started way back. There is an infrequent use of the facial nerve monitoring. And in US also, about 60% of the head and neck cancer surgeon will use the nerve monitoring. The reasons being it is a highly costly affair, unreliability. There is some kind of a false sense of security occasionally, and there is a doubtful utility over the good surgical skills and requirement for the extra personnel, like you may require a neurophysiologist or a trained person to use the IONM. And the type of the injury, what you can have it on table, it's kind of a retraction or a direct pressure, a surgical dissection or a laceration of the facial nerve, electrocautery injury or a heat injury, a clamp compression, a ligature entrapment, or a transaction injury, or a suction trauma or a ischemia of the nerve. The major concern following these injuries are the facial motor deficits, cosmetic and the functional morbidity, ocular complication, impaired quality of life, and costly medical litigations, which is seen in the Western countries mainly. So there is an increase in the IONM use, the reason being mainly to identify the nerve by the surgeons, so that it helps in early detection, warning to the surgeons, then it reduces the mechanical trauma and it helps in mapping. The next reason why people use it is the medical legal concerns. There's another reason people use it for the increased safety, for the real-time feedback, what you get, and it can be used as a standard of care. It also protects the nerve, especially in a distorted anatomy, in a bulky revision or a malignancy cases. It helps in prognostication, evaluation, and it reduces the operating time. So coming to the connection, what already Meenakshi has told us. So these are the electrodes. It has got two components, the two needles. The probe which we are using for our case today is the monopolar, but we can use a bipolar also. Bipolar is superior because it is localized current will be passed. We can use a continuous, which people are using outside, because it will give you a constant real-time feedback. And the connections are done with the machine, and we do the recording on the EMG using a visual and the auditory signals. So this is the way what we are going to do. The four muscles, as Meenakshi said, frontalis, orbicularis oculi, the orbicularis oris, and the ramus marginalis is going to be needle. So basically the mechanism of action is we put the two needles. The nerve, when we stimulate, the first needle which is close to it causes a depolarization, and the needle which is far causes a repolarization, and that creates the action potential, and which has been recorded by the EMG. So we can have a monopolar or a bipolar active stimulation, or you can have a continuous. In continuous, you will have a separate nerve where you can see the recording for the particular nerve what you want to see, and the clip-on goes on to that nerve after identification. Coming to the optimal checklist, what we do it in our hospital is the preoperative period. You record the facial nerve function. Then comes the anesthetic checklist, that is just before that you use a short acting neuromuscular agent. The third is the neurophysiologist checklist, that is you check that the circuit and the stimulatory probe and everything is in place. The surgeon checklist is you check the muscle twitching for assessing the probe, that is the stimulus circuit is checked. And at the end of the surgery and during the surgery, you use the recordings of the stimulus so that it can be used as a medical legal purposes and records. And post-operative period, you do the facial nerve assessment by the scales. So House-Brackman scales should be used to classify the facial palsy. So coming to the evidences, the level 1 evidence is the meta-analysis. It is just published in 2021, which shows 1,000 patients around where the immediate post-op weakness is basically in the IONM arm is significantly less than the without IONM arm. And there is an absolute reduction of about 15% in the immediate post-op weakness. And in a permanent post-op weakness, there is about 8% absolute reduction. So use of IONM is significantly reduces the facial palsy. But if you look at the individual randomized study, there is a single study with the less number of sample size and not shown any significant difference between the using IONM and not using the IONM. So actually speaking, we don't have an ideal randomized study with a good sample size calculation, and there are no stratification done on a histology base or a size base or extent of the surgery or a prior radiotherapy and the type of a surgery. Also, we don't have any good study where the scoring has been done, cost effectiveness or a quality of life has been recorded for this patient. So coming to the false IONM results and why it is not so popular is because of the incorrect monitoring, inexperience of the IONM, the anesthetics drug effect is not worn off, or a malignant involvement of the nerve has been misinterpreted, or there is an infection. So this is the case where the left side superficial parotictomy has been done, and this is a post-excision facial nerve monitoring. So this is just to show you how we do it intraoperatively with the monopolar stimulus.
From all branch, from upper branch, from all branch, from lower branch, again from lower branch only, lower branch.
So that's how we do it. All the branches can be monitored, and you see the EMG signal, the audio visual signals also. And this is the post-operatively, what we do is the facial grading scale. So you monitor and you see how is the response to your surgery. Thank you so much.
Thank you very much, Anuja. Any questions from the panel?
Yeah, Prathamesh, just one question. In which cases do you really find that this monitoring would have made a real difference as far as nerve preservation goes? I mean, any specific indications where you feel it is absolutely must?
Yeah, so like I said, when you do an imaging and you find that the nerve is very close to the retromandibular vein, it's in a deep lobe. In those cases, and the patient has some pain, you know that this is a malignant tumor, you would want to use this because you want to identify that entire pathway of the nerve and try and preserve it. If you're not able to identify, you want to know what is the distal stump and the proximal stump. So in those cases, IONM is very essential. When you're doing facial reanimation surgery, those cases, in order to identify the nerve stump at the buccal branches, it's very critical because today you will do cross nerve innervation, and to identify this tiny nerves at the lip and around the modulus becomes very critical. And at that point, intraoperative nerve monitoring is very, very, very useful.
Okay. And do you
So in redo surgery, in malignant tumors, and in patients who have got facial weakness, I would recommend using intraoperative nerve monitoring.
Okay. And do you feel it helps in prognostication also? Because sometimes we preserve marginal mandibular, particularly in submandibular surgery, and you feel that patient is having post-operative some weakness. So do you feel that once the nerve monitoring is done and you have a confirmation of preservation, that will help telling patient that this will come back?
So, like Anuja said, in the meta-analysis, it showed that there was significant benefit of using intraoperative nerve monitoring. But most randomized trials have shown that the temporary paresis rate reduces and not the permanent. So to answer that question, just because the nerve is intact and there is impulse going doesn't mean that it'll be functional at the end of the surgery. So you need to be careful. You need to fall back on preservation of nerves using anatomical knowledge. But what is essential is going ahead. As we go on to move using continuous nerve monitoring, that's the time when you will actually prevent the nerve damage. So nerve integrity monitor, that's the name of these equipment. It tests the nerve after your procedure. But what we need to do is test the nerve during the procedure. So that will prevent any nerve injury from happening, any devascularization, and you'll be notified of it as it's happening.
Okay.
So we'll just go on to briefly on the management of parotid neoplasms before moving on to surgery.
I just have a comment, Dr.
Good afternoon, everyone.
Prathamesh,
yeah.
One more question. In a redo case where already there is an iatrogenic facial paresis or paralysis, and you want to do a facial resuturing, in that case, particularly after the surgery, the stump retracts and later on it becomes fibrotic. In that cases, this monitoring is going to help.
You mean when you're doing a redo surgery and you have not identified and tagged the nerve at the first surgery?
Yeah.
Yes, that's what I was trying to allude to. Usually you would have a patient coming to you after surgery and now wants a facial reanimation. So you need to identify the distal, trunk, where the nerve ending, which has been divided. So at that point, it becomes useful to identify this with the nerve monitor. So you would approximately know that the nerve is around certain anatomical structures. So for instance, the parotid duct above and below, you will see the buccal branches. So at that point, when you start dissecting in a fibrotic tissue, if you use the nerve monitor, you get a good idea about where the nerve is located.
Okay.
Dr. Prathamesh, I have a small point. Can I make? Dr. Janakram here.
Yes, Janki.
Actually, I have a small comment here. I was in a country abroad, and there was a surgeon who was operating with a nerve monitor. And unfortunately, the nerve monitor went off, conked off. And immediately he got paralyzed. He couldn't continue the surgery at all. And it took around 1.5 hours for the monitor to be repaired. Till then, the patient was lying there. This is a good facility, but I think it cannot replace the knowledge of anatomy. This is just for the juniors. Don't get dependent on any instrument like the navigation. If the navigation is not there, get paralyzed. No, you should be very confident. But these are all adjuvants to enhance your surgery. Am I right? What is your comment?
Absolutely, Janki. That's what we have been telling from beginning. These technologies are there for us to use, but do not let them be, something that prevents you from going ahead with your surgeries. They should enhance your surgery and not take away from what you're routinely doing. So depend on the anatomical knowledge, identify your nerves, dissect as you have been taught, and that will preserve these structures. This is just an adjunct.
Absolutely. Thank you, Prathamesh.
Yeah, Richa.
So good afternoon, everyone. I am Dr. Richa Vesh, and I would be talking about the management of parotid neoplasm. So we just start with the facts and figures. So salivary gland cancers are relatively rare tumor with only around 50,000 new cases being reported every year across the globe. They constitute about 5% of head and neck malignancy. And 70% of the salivary gland tumors are constituted by the parotid gland neoplasm, of which around 80% are benign tumors. And the most common benign tumor in the salivary gland neoplasm is pleomorphic adenoma, and it constitutes about 40 to 60% of all parotid tumors. Now, this is a mind-boggling WHO classification that enlists numerous entities, and this is how we have the classification for the cerebral gland tumors: benign, malignant, soft tissue. Very, very difficult to remember. But what we can do is at least we can remember a few important facts. So here we see a table in which they have highlighted the benign, most common benign tumors in the glands and the malignant tumors. So the most common benign tumor in the parotid gland is pleomorphic adenoma, whereas the malignant ones are mucoepidermoid carcinoma followed by adenoid cystic carcinoma. Now, the management can be split in two parts: the diagnostic workup, and I'll be talking predominantly about the surgical management. So we had a little discussion about the diagnostic workup before, and I'll be elaborating on each point further. So it may be prudent to do the FNAC in case of the parotid neoplasm, because here we see this is a summary of various meta-analysis published. And we can see that if we do the FNAC, it helps us differentiate between the neoplastic and the non-neoplastic etiology with a very good diagnostic accuracy, with a sensitivity of 96% and specificity of 98%. It also helps us differentiate between the malignant and benign tumors, although it's slightly lesser sensitivity and the diagnostic accuracy, but still it will be able to differentiate between the two entities with a sensitivity of 80% and specificity of 90% and the accuracy of 96%. In the next column, we see the ultrasound-guided core biopsy. It is not routinely recommended, but especially in the cases where the FNAC has been non-diagnostic. So there, the sensitivity improves to 92% and specificity of 100% and diagnostic accuracy of 100%. And third is a summary of the meta-analysis talking about the diagnostic accuracy of the frozen section. Not routinely recommended for the primary diagnosis. As we can see, it is adding nothing to the above mentioned values, where the diagnostic accuracy of FNAC and core biopsy is pretty much nearly 100%. I'll be come to it. When can we use a frozen section in this scenario? Now, this is just for the interest of everyone. We saw the heterogeneous group of classification, and there is inter-observer variation. So reporting may be very, very difficult. There may not be a consistency. So for easy reporting and consistency and report and comparison of the results, this is a Milan system. Various classification systems are followed, but this is the most widely followed one. And it is somewhat similar to the Bethesda category that we followed in the thyroid cancer. Now, we see the diagnostic category on the extreme left corner. In the mid, we see the risk of malignancy with each diagnostic category. And on the right side, we see what could be a probable next line of action. So yes, FNAC is helping us a bit with the diagnosis, and also it's helping us to decide the risk of malignancy and to decide our immediate next plan of action. So it may be prudent to do the FNAC in these cases. Now, coming on to the role of a frozen section, as I already alluded to before, there is a very limited role for primary diagnosis, but it can be very, very handy when we are dealing with the tumors where we expect the facial nerve to be involved preoperatively or intraoperatively. We can assess the margin of the facial nerve and ensure that we are clear on the nerve margins. And it can also be very, very handy tool when we are dealing with the parotid tumors and it is otherwise clinico-radiologically node negative neck. So it can helps us detect the metastasis and help us plan the neck management better. Coming on to the role of imaging. So again, of course, three modalities at our disposal: ultrasound, CT scan, and MRI. We had the discussion before. There is a certain role of ultrasound, especially if we are dealing with the tail parotid tumors, and these can be very, very difficult to differentiate sometimes between the level 2 node. So ultrasound can be the initial screening modality. And also, if we are doing the FNAC, ultrasound can help us target the right area, and it ensures that we get the tissue diagnosis. So it can help us in the ultrasound-guided FNAC, and also in the ultrasound-guided core biopsy, where the FNAC is inconclusive or we need more tissue for immunohistochemistry. When it comes to assess the exact extent of the disease, I think MRI is the imaging modality of choice because it's a soft tissue tumor and we need to assess the relationship of the tumor with the deep lobe, the facial nerve, if there is any perineural spread of disease or node metastasis. This is also in close proximity to the external auditory canal and it can go close to the skull-based bones. So at that time, we may complement it with a CT scan to look at the bone status. Now, coming on to the surgical management of these tumors, I'll just split it under three headings: surgical management of the primary, surgical management of the facial nerve, and the management of the neck in this scenario. So again, we have a whole lot of mind-boggling terminology that we keep using for the primary tumors. So it can be just a partial parotidectomy where we excise the tumor with a surrounding cuff of uninvolved parenchyma. So in this, just a proportion of the parotid gland is excised. Superficial parotidectomy, where we remove the entire superficial lobe of the parotid gland. Total parotidectomy, where we remove the superficial and the deep lobe, preserving the nerve. The radical parotidectomy, where we excise the nerve along with the entire parotid tissue, and it can also be extended radical parotidectomy when we have to excise the involved surrounding structures. Now, just to get the consistency in reporting, the European Salivary Gland Society has proposed a classification. So basically, it divides the parotid into 5 segments. One is superficial superior, 2 is superficial inferior, 3 is deep inferior, 4 is deep superior, and 5 is a accessory tissue. Now, depending upon what are we excising, we can report it in the exact manner. So here we see this is the proposed classification. So if we are excising whole of the parotid tissue along with the facial nerve, it would be reported as parotid 1 to 4. That is total the superficial and the deep lobe removed along with the facial nerve. Similarly, this would just be the removal of the entire lobe, preserving the facial nerve. And as we see here, this is kind of an extended radical parotidectomy where the nerve, the skin, and mesenteric is also sacrificed. So henceforth, and you can just notice how the trend is and how did the report. Now, when we are dealing with the tumors, there is also a concept of a parotidectomy and extracapsular dissection. Now, there is a difference between the two. Extracapsular dissection, we don't make any attempt to identify the facial nerve, and we would be just taking out any tissue less than a level. So this is basically followed only and only for benign lesion. It does not have any role in the malignant lesion. The other is the parotidectomy. There, at least a nerve branch would be identified and at least one level of the tumor would be cleared. Now, how to decide what kind of a surgery to offer? So if we are dealing with the benign tumor confined to the superficial lobe, or it's a very, very small tumor, probably we can get away with a partial parotidectomy or superficial parotidectomy. And when we are dealing with a T3 and T4 tumor, or the low-grade tumor, but it is confined or involving the deep lobe, in those cases, a total conservative parotidectomy is preferred. This is not only to achieve the adequate margins, also the advanced tumor and the high-grade tumors may have intraparotid node. So to clear out those nodes completely, is advisable to do the total conservative parotidectomy, preserving the facial nerve. Now, it's a very important, the facial nerve involvement is a very important issue, and this is a systematic review article published in 2018 that analyzed 195 articles. And few important points were borne out by this article. Majority of the times, the facial nerve is not actually involved by the tumor, and the aim is complete removal of the tumor along with identification and preservation of the nerve. But if a portion of the nerve is involved, it's completely encased by the tumor, it is better to resect that part, and it would be a radical parotidectomy. And if the part of the nerve has been sacrificed, then one should consider doing a primary nerve reconstruction for better outcomes. So if we look at the recently published ESCO consensus guidelines, so wherever surgeon is able to preserve the nerve, it should be preserved, taking out the entire tumor, creating a plane between the tumor and the nerve. But in case the branch of the nerve is impaired or involved by the tumor, then it should be sacrificed. Neck management in parotid malignancy. If it's a benign tumor, no worries. If it's a malignant tumor, it can be a node positive neck or a node negative neck. If it's a node positive neck, which can be seen between 10 to 40% of the cases, and it may involve multiple nodal levels, right from 1 to 5. In those cases, a therapeutic neck dissection clearing out level 1 to 5 should be done. And if it is a clinically node negative neck, in those cases, the risk of occult metastasis is quite low. It can be ranging between 12 to 49%. In the order of decreasing frequency, level 2 is most commonly involved, which is seen in 71% of the cases, followed by level 3, which is seen in about 15% of the cases, and 1 and 5 are rarely involved. And the tumor factors associated with the lymph node metastasis are advanced T-stage, facial palsy, high-grade tumor, extracapsular spread, vascular invasion. So, presence of these factors and the presence of advanced malignancy should prompt us in doing the elective neck dissection, which would comprise of clearing at least level 2 and 3. And in cases like T1 and T2 and low-grade tumor, the risk of occult metastasis is extremely low. So in those cases, either we can completely observe the neck, or we may just consider doing a level 2 clearance and subject it to frozen section. If it is negative, we can just stop at that. So to summarize, the parotid neoplasma heterogeneous group of tumors with variable prognosis. Appropriate workup with imaging to assess the extent of disease is important in planning the management. FNAC and biopsy helps in establishing the diagnosis and helps us guide in the immediate next plan of action. Stage and grade should be considered in the treatment algorithm because they have a very strong prognostic implication. Surgery alone would suffice for the low-grade early tumor. In neck dissection in the presence of N+ disease, an elective neck dissection should be considered in presence of a high-grade tumor or locally advanced disease. These are the references for further reading. Thank you very much.
Thank you, Richa. I think that was very well summarized. And the bottom line is that you need to resect these tumors with a cuff of normal tissue. Salivary gland tumors are different. The minor salivary gland tumors can be resected completely with margins, and you need more margins because most of them are malignant. In case of the submandibular gland tumors, you can remove it completely with wide margins. But when it comes to parotid, you need to realize that the fascia of the parotid is merged with the surrounding fascia. So that's the reason you can never remove the entire parotid gland. Or even in a radical parotidectomy, you will leave behind some tissue here or there. It extends right from the zygoma up, anteriorly up to the buccinator-masseteric junction, inferior up to the digastric, and posterior onto the mastoid. So it's a very wide area where this salivary gland can spread. So you stick to your cuff of normal tissue. You need to remove all the multicentric disease, if at all. And the bare minimum that you would need to do today would be a superficial parotidectomy that is lateral to the facial nerve and remove the entire cuff with a cuff of normal tissue. If there is a deep lobe extension, you need to then remove all the retromandibular tissue going towards the parapharyngeal space. So keep things simple. If you find that lesion is having an extra glandular disease, it is a minimum of a T3 tumor. So when you have a T3, T4 tumor, you should do a neck dissection. So you need to do a level 2, 1B, and 3 clearance at the very least. So plan this along with the surgery that you're doing. If you have a T1, T2 lesion, then you can do a complete resection of the tumor. And what we practice is sending the level 2 node for a frozen section. So we know that in most of these cases, it will be negative, but should it come positive, you will complete the neck. Any questions before we head towards surgery?
It was very well covered, Prathamesh, the treatment plan.
Prasad?
But just one point I just
The
wanted
others,
to ask.
any questions?
Hello, Prathamesh, can you hear? Hello.
Okay. If there aren't any, then we will go on to showing the marking of the skin incision. I would request
Yes, sir,
the
you can go
audiovisual to
ahead.
show the
Perfect,
recorded
sir. Perfect,
surgery
perfect. You can go ahead.
till now.
Prathamesh sir,
Can you hear me?
Hello, theater.
Can you hear me, sir?
Hear me?
Are you seeing any image?
Hello.
I can see you.
Prasad? Sameer?
Prathamesh, we
Dr.
can hear
Prathamesh,
you,
we're not
but I
able to
think we
hear
are
you.
not audible.
I have a question.
I think
Can you hear?
we are not audible.
Dr.
to hear.
Prathamesh, can you hear me? I have a question to ask.
It's not going.
Yeah. We'll check till then, by the time we can start his surgery.
Audiovisual, can you please help? We are not able to hear the audience.
Hello.
Hello.
Sir, please start the case. Oh, it's not able to hear.
Can someone take my phone?
Prathamesh, you want to hear me?
Just see if if they can communicate on the phone. 1972. Take the call. Yes, Amir.
To reach you.
Yeah. Now we can hear you. Yeah. Okay. So,
Dr. Prathamesh ji,
okay, we'll go ahead. Okay. Can you
Can
show
you
the
hear me?
recorded video?
Are you hearing us now?
can you hear me, Dr. Prathamesh ji?
Samir, we are now showing the recorded video. Ban kiya? Laga this call. Keep it on.
Dr. Prathamesh ji?
What we had done, Samir, is recorded the the implants, the placement of the electrodes and the skin incision to save time because we had only 2 hours. So we are just trying to show that video. Yeah.
Hello.
Hello.
Can you hear is there audio on it?
Prathamesh sir, we can hear you. I don't know whether you can hear us.
So this is how the electrodes are being placed. Hello.
Yes.
Yeah, Ganesh, but the AV guys need to be told.
Are you able to hear the auditorium?
Keep it on.
So last one is mentalis muscle innervated by marginal mandibular. So I'm placing the electrode on infralateral surface of lower lips.
1972. Just press that. Cancel. Rupert, sir.
So these electrodes are connected to the amplifier box of machine, which is placed under the bed. We have also placed the ground and reference prior to the placement of electrode. Ground and reference can be placed anywhere nearby the recording electrode. So I have placed it on the trapezius muscles.
Yes, Amir, I just wanted to know whether you can hear.
You keep on talking, absolutely fine.
Yeah. You are seeing the electrode. Are you seeing the audio on that video?
Yeah, very well.
Okay. So that is how the electrodes are placed. And now Meenakshi will show you about the monitor.
Can start. So this is the neuromonitoring machine, NIM integrity monitor response 3.0 by Medtronic. So from this we are selecting parotid procedure. So it is already presetted. So this is the intraoperative neuromonitoring screen for this parotid case. So I will show the basic settings also. So here we are adjusting the current, so we can increase the current as per our wish. And here is the auditory feedback adjustment also. Followed by that we have a control panel where all other settings including the stimulation settings, monitoring and audio settings, which we can adjust as per our convenience. So these are the 4 muscles, and here we are getting a baseline values. So upon stimulation, we will be getting a response over on the screen. Thank you.
One question, how will we answer?
Yeah, hello.
Hello.
Yeah, yeah.
Can you hear us, Prathamesh sir?
Yes.
Thank you. Hello.
You should. Yeah, go on. Yeah, start recording. Starting recording. Infiltration there. Or forceps. Anek stitch there. Yeah, we are. So tell him we are showing the clip.
Yeah. Okay, fine. But after that, let him.
Okay, maybe we'll show live.
Next video that was that.
So Samir, we are not able to hear you, but we will, I don't know how we'll communicate, but I'm just going to show live because they are having some problems. So I just wanted to discuss the various incisions because that is very important. And we had recorded all the incisions very well. So the standard incision that we have is your modified Blair's incision. The modified Blair's incision has two components. You have the vertical component, which is going up to the ear lobule, and then you have the horizontal incision. So you will have two components.
Hello. Hello.
We lost you, man.
Some scarring and adhesion, and it look abnormal. Another incision that is being advocated is the retroauricular incision. So those who are doing the retroauricular robotic surgery and neck dissections, they have popularized this, wherein you mark the vertical limb in the hairline, and then you mark the horizontal limb, which then goes on to connect with the vertical limb. So at this point, you would get a complete access to the entire neck and posterior part. And anteriorly, once you take this incision, you will get good control on your parotid. Now, a cosmetic incision that is done is a post-auricular and a pre-auricular. So you identify the post-auricular groove and go on to the vertical limb, and then come on to the vertical limb. So this entire ear lobule will be elevated, giving us a good access to the facial nerve and giving a good exposure. So these are the three approaches which you can use. Then what we do is to elevate the skin flap. Now the skin flap elevation is always a concern, forceps. There are thoughts about leaving some fat on the parotid, some fat on the skin flap. You want to avoid a phrase syndrome, so you want to not have a very thin flap. So the best technique is to identify, take the horizontal incision, identify the platysma. Once you identify the platysma, you elevate this in the subplatysmal plane. Hold this. So you can see here the platysma here very well, and it connects with the SMAS, the superficial musculoaponeurotic fascia. So you can see how this fascia is connecting with the platysma here very well. If you follow this plane of the platysma, you will be above the parotid without any problem. You will leave very little fat over it, and most of your fat will be in your flap, and you will avoid communication of the nerves and reduce the incidence of phrase. You elevate this flap anteriorly, and now the query is how much to elevate. We have always been taught that identify the masseter anteriorly, and I would not recommend you to do that, because as the parotid ends and the nerve exits off the parotid, you will see the masseteric fascia. So if you go on to the masseteric fascia, all these nerve endings which are coming out of the gland will get damaged. So please do not elevate it. There is a slight elevation of the parotid. Just elevate it, just slight, so that you can then proceed with the dissection anteriorly if required. So this is in keeping with how you will elevate this flap, exposing from the intercartilaginous region all the way up to the digastric or the sternomastoid. So we have done that. The next step is to identify two structures. One is your sternomastoid, one more forceps. Your sternomastoid is a key towards elevating the parotid fascia. As we discussed, the parotid fascia extends from zygoma all the way up to the digastric, from masseter all the way to temple bone. If you identify the sternomastoid, you will be able to get into the parotid fascia without having getting into the glandular structures. So that's the first thing, the sternomastoid. And second is your tragus. So again, like I do the horizontal and the vertical, you first identify the inferior, identify the external jugular vein, the great auricular nerve, and the fibers of the sternomastoid coming onto the mastoid tip. Then you identify the tragus and elevate the tragus all the way down to the junction of the tragus along with the external auditory canal. So you can actually palpate the styloid base with till that point you need to elevate, so that you're actually seeing the tragal pointer. Having done that, now we need to identify the facial nerve. So the first step is to preserve the great auricular nerve and the external jugular vein. What we have realized is that people take the external jugular vein early on, and this congests your gland. Please do not do that. Your external jugular vein, as we were discussing in the anatomy and imaging, is very vital towards identifying the nerve, because it is in the Patty's fascia, the fascio-venous plane, and it is above the vein. Hello. Yeah, can you hear me?
Hello, Prathamesh.
Yes.
Yeah, we can hear you well. You continue.
Okay. So, any questions so far?
Hello.
Just wanted to ask regarding greater auricular nerve. It has two branches. I mean, how you do about, I mean, the anterior branch and the...
Yeah, I had actually recorded that very well. So you can see that as we discussed, there are two components. One is your sternomastoid and your tragus, right?
Yes. Yes.
Do not touch this tissue in between, because that's where your nerve will go on to supply your pinna. The common mistake everybody makes is take this and cuts across onto your tragus, and this nerve gets divided.
Okay.
So you create one pocket above and one pocket below. Then you trace mosquito. Then you trace the greater auricular nerve. That's the great auricular nerve.
Yes.
And you identify the branching. Now there is varied branching. You can see this was the anterior branch, which was going into the parotid, and this is a posterior branch. So as I came onto the parotid and identified this truncation, I divided the anterior branch, and I pushed the nerve posteriorly, and traced it all the way up as it was going into the lobule.
Perfect.
So you can see how the nerve is preserved all the way. Even this much of elevation should be avoided as far as possible, because it devascularizes the nerve. Now, almost 30% of our patients will still complain of numbness, but over time, most of them recover if you have preserved this.
Okay. Sir, can you show the surface landmark from the greater auricular nerve? From the surface landmark.
Pardon?
Surface landmark, skin landmark for the greater auricular nerve.
Yeah, so this is what we are seeing, the platysma ending. You can see where the platysma is ending here. It's very nicely seen, the demarcation.
Yes, sir.
So one and a half centimeters behind that or posterior to that would be your external jugular vein.
Yes.
The nerve lies lateral to the external jugular vein. So many times if you ask the patient to strain, you will be able to see the external jugular vein.
Yes, sir.
And that is usually the end point of your platysma, and your nerve lies lateral to that.
Okay.
So now that we have identified these two structures, we now proceed towards identifying the next structure. Skin hooks, please.
Prathamesh sir, Dr. Archana from this side.
Yeah.
If you allow, can we take some virtual platform questions?
Sorry? Yeah, please go ahead.
So there is one question from Dr. Navroz from Guwahati. He wants to know preoperative identification of facial nerve and retromandibular vein on MRI.
Anuja, will you take those questions?
So on a MRI, if you see the axial cut, I don't know, we don't have the image, but when you see the axial images, there you can pinpoint the retromandibular vein, and that actually signifies the level of the facial nerve. So that's how you will see the extent of the lesion. On a T1 weighted contrast images, you will check the extent of the lesion with respect to the superficial lobe and the deep lobe. It will be just behind the mandible. So that's what that's how you will identify it on the MR.
Can the external camera be on for the surgery? Because Prathamesh is, yeah, that's fine.
Please show the surgery, please.
So we are now going towards the upper end of the sternomastoid. You can see the sternomastoid coming into view. We have identified the parotid tissue and the tragus, and we need to now connect the two.
Dr. Prathamesh ji.
Yeah.
What cautery are you using?
So we are
What is the
using
power setting.
Yeah, we are using 20 watts coag power, and cutting is also at 20-25, and we are using a Covidian Valley Lab.
Okay.
This picture is through Spice camera, Vuitton.
Are you seeing the Spice camera right now? Yeah. This is the Vuitton. Yes.
Yeah, but I mean,
do you want the external camera?
yeah, I think external camera is a better picture. Yeah, this is
that
yeah, this is the better one.
The Vuitton looks a little reddish. Can you do some white balancing or something?
No, it's Clara and Chroma. If you adjust it to Clara, I think it will be better.
Okay, we'll try that.
I think standard mode also will be better.
Yeah, standard also will be better.
So we'll go to the standard mode, I think. This is the VTOM with the Rubina system.
So there is one more question about FNSC from Dr. Karthik. Is FNSC mandatory for all parotid tumors? And as the management is mostly the same for all parotid tumors, and that is adequate parotidectomy. So your opinion on this, sir?
Madam, I just heard the first half of your question. Could you repeat your second half?
Okay. Because the management is same even after doing the FNSC. So is FNSC mandatory? That is the question from Dr. Karthik.
Yeah, so for a couple of reasons, we think that FNAC should be done at the baseline. So first is, of course, if you know it's a neoplasm, you have at least a superficial parotidectomy that you will do. But FNAC also helps to differentiate between the neoplastic and non-neoplastic. So there may be a scenario where you just don't want to do any surgical intervention. Then there can be some scenarios, like if you have a lymphoma or if it is a intraparotid node. So in those cases, you may not want to do surgery at all. It will be just a chemotherapy case. So again, it is becoming a way to go ahead for the decision making. So third, it helps you prognosticate the disease. So if you have to counsel the patient, so if you are dealing with the benign tumor or the malignant tumor, so again, better counseling of the patient. So it should be considered in all cases.
So Prathamesh, are you on a digastric?
Yeah, so now that we have elevated the sternomastoid, and the next structure that we want to identify is a digastric. So you can see very well the sternomastoid, the lymph node and fibrofatty tissue, and the digastric. So this is a very good landmark which will then explore towards identifying the facial nerve. We have already identified the tragus and we have gone right up to the junction of the tragus with the external aortic canal. Now we will be dissecting in the parotid along the digastric and elevating all this fibrofatty tissue, which is the capsule, merging with the digastric and elevating it till we see the digastric reaching the digastric ridge.
Okay.
Can you see that?
Prathamesh, according to you, which is a better landmark to identify the facial, digastric or the cornless pointer?
So we use both the pointers, both the landmarks, and I feel that combination of the tragus along with the digastric is the way ahead, because you will get a good understanding of how that nerve is positioned in relation to the tumor. Many of the tumors which are in the superficial lobe will push the nerve down and out. On the other hand, tumors in the deep lobe will push it out. So as you are seeing the location of the tumor in relation to the digastric, you will understand how that nerve is going to be positioned. So use both the landmarks. I think the digastric is a very good landmark, but tragus is also very useful to understand its superior displacement, vascular. So now we have...
Prathamesh ji, I have a question. We have in some instances a little spillover from the tumor. That is, the tumor sometimes breaks, not intentionally, but sometimes it happens. So do you think that there is a chance of recurrence in such cases, and what is the percentage?
So even in benign tumors, pleomorphic adenomas, whenever there is a spillage, your recurrence pattern increases. So you should try and, as far as possible, avoid having a tumor spillage.
Yeah, but sometimes in recurrent cases, it invariably, sometimes it spills out. And what is the percentage of recurrence?
So I don't think I can tell you what will be the percentage of recurrence, but when you look at the data that has come in from the Italian group on pleomorphic adenomas, in wherever there has been a tumor spillage, the recurrence has been there. It may be, over the long term, in a few years, but in almost 40% of patients, they have seen recurrences.
Dr. Prathamesh, like to avoid the tumor spillage during the dissection, like is it like we avoid irrigation during in the surgical field? Is it required?
To avoid?
Because some studies tell that if you irrigate the surgical field, the chances of tumor spillage is more.
So if you have a tumor breakdown, please do not irrigate at that point. Try and clear whatever is spilled over and then contain that area. If you start irrigating at that point, there will be a displacement of those spilled cells all over. Okay. So as far as possible, avoid irrigating. If you have a tumor spillage, try and contain that initially. Okay. So now you can see that I am now focusing, as Samir asked, will I use only digastric or will I use the tragal pointer? Are you able to see this? Can we shift? Are you seeing the VTOM image?
Yes, actually, we are seeing everything.
Higher magnification and fine focus we need, sir.
Can we move to the VTOM image?
Yeah, we can try that.
Sir?
So little higher magnification and fine focus.
Can you see the VTOM image now?
Oh, yeah, then fine adjustment.
Yeah, so that is your great auricular nerve. That is the tragus.
VTOM is not good, boss.
Not good. Okay, we'll go on to the regular camera, please.
Sir?
If you can zoom on that, it will be great.
Zoom in.
Sir, Dr.
Tell us when to stop.
Yeah, I think this is okay.
Zoom is okay?
Yeah.
Sir.
Can you improve the light in the improve the light in the that's fine.
No.
Okay. Is it better now?
Yeah, better.
It's too bright.
Okay. It's too bright.
Hello?
Yes.
Sir, what you are operating is a very small tumor in the MRI. It hardly just less than 2 centimeters, I think.
Yes.
So what are you planning, sir? Is it adequate peritidectomy you are planning, or you are going for a classic superficial peritidectomy?
So I am doing a classic superficial peritidectomy. And
meaning because this is a demonstration you are doing, or do you do it routinely even if it is 2 centimeters?
I do it routinely because we are a training institution.
Sir.
What I would recommend is to do an extracapsular dissection. So as we gain experience, you have got intraoperative nerve monitoring, you should be doing extracapsular dissection. There is enough evidence now to suggest that the rates of recurrence and all following an extracapsular dissection are similar to that following a superficial peritidectomy.
Yeah, that's why
So
I'm
now,
asking, sir, is because it's very small. There is a lot
Yes.
of normal parotid tissue between the tumor and the nerve.
Yes. So now you can see the tragal pointer here very well. And this is the digastric. So between these two, you have got this parotid tissue covering the facial nerve. So you need to realize that now you will have three structures: the parotid tissue, you will have the posterior auricular artery branch, and you will have the nerve. So as you go closer to the nerve, you will encounter these structures. So one technique is to dissect a centimeter anteriorly, identify the nerve, and then remove the tumor around it, the parotid tissue around it. What I would recommend is to dissect this with using a bipolar cautery and dissect this gland anteriorly. Can you see what I'm doing?
Yes. Yeah.
So what happens is you may suddenly have a very ferocious bleeding here, and that spoils their entire field. So if you are gentle and you give cauterize little bits of tissue, I'm using a 0.7 mm bipolar cautery. You can dissect this. You can see how the parotid tissue engulfs the nerve all through. Keep sucking on this, please. Suction, very fine suction. So you can see how the parotid gland is getting separated. And as we dissect, you will start to see the artery and the nerve.
How much depth they have to go from there, sir?
So the depth is about a centimeter.
Yes.
But don't go by all these landmarks of a centimeter and all.
Sir.
What is in front of you is reality.
Yes, sir.
And remember, there's a lot of parotid tissue. You can see that it is not where we were thinking the nerve to be. Right from the top to bottom, we are thinking the nerve is there, the nerve is there. But remember that the nerve is very deep and it is within this parotid tissue.
Prathamesh, you are pulling the parotid anteriorly. There is some traction over there. So this traction, will it cause some damage to the fascia?
So long as the nerve is supported, Samir, there is no injury. Once the nerve is freed, that's the time you will get injury. So remember that what you are seeing is I am retracting. My colleague here, Anup, is retracting along with skin hooks. We are not using the traditional right angle retractors.
Yeah.
So that right angle retraction causes a lot of traction. So what we have realized using the nerve monitoring is that the traction injuries are the worst because you are not seeing it as it's happening.
That's right. That's right. Yeah.
Now you're seeing
So
that this is the vessel coming in view. Can you see the vessel?
Yes, sir. Retromandibular vein.
Yeah.
Yeah.
No, this is the posterior auricular artery.
Circular artery.
Are you using any magnification yourself?
I am not using a magnification. I'm having a VTOM in front of me.
Okay.
Scissors.
In case of revision surgery, identification of patient is difficult. Then how to identify, sir?
So you will use the natural landmarks, and what I use is imaging. Remember that the redo surgeries are usually because the surgeon may have cut corners and just removed a node or some dissected some nodule and removed and then declared it as a surgery, or it may have genuinely been a biopsy. All in all, no one actually goes so deep and identifies the nerve and then does inadequate surgery. So look out for the retromandibular vein. The retromandibular vein on the MRI will tell you whether the surgeon has actually gone and dissected it. When you compare the two sides and you find that there's normal tissue around the retromandibular vein, rest assured that no surgeon has gone and identified the nerve, and you will be in very good planes as you dissect.
So the vessel comes, that means you are very close to the nerve, is that right?
Yes.
Is the retromandibular vein is the landmark for marginal mandibular nerve or the entire facial nerve?
The facio-venous plane. So we are looking for the entire plane. So now you can see the nerve.
Yes, sir.
So you can see that once we had taken that artery, the next structure was the nerve. That's a tragal pointer here, and that's the digastric ridge. So this is the nerve right in middle. Now, from this point on, this is where the question where Janki was asking, what about tumor spillage, mosquito? So at this point, I would urge you all to read this article by Dr. Professor Kerry Olson from Mayo Clinic. He really transformed the way I discussed and dissected the parotid thereafter. You need to understand that the parotid has got a plane above the nerve, and we are doing a superficial or a suprafacial dissection. So normally what we are taught, identify the nerve, dissect the nerve and cut above, isn't it?
Right.
Now, if I keep doing that, I will get the parotid in usually 3 or 4 pieces. And that is what you are seeing in the pathology reports.
Right.
So what I would urge you to do, can the cameraman zoom in here? Are you seeing adequately?
Yeah. Actually, I wanted to ask you, do you like to take a help of nerve monitoring at this stage?
We will do the nerve monitoring too before we proceed, because this is the first step that you need to do. So can we show the nerve? I'm just stimulating. This is the unipolar stimulator.
Okay. Perfect.
Can you see can someone show the monitor, please? Show the monitor. Samir, are you seeing the monitor? Prasad?
Yeah. Do you see for only sound or you see for muscle twitching also?
So when you are operating, you just focus on the sound.
Okay.
If you have a trained assistant or an electrophysiologist, they'll actually tell you whether there is any. And what is more important is to note down the amplitude.
Okay.
How much is the amplitude? Tell me exactly.
Zoom out, karo. All branches are shown.
Yeah, so all 4 branches are shown, and the average impulse is about 1,000 milliamperes, microamperes. So now that you have done that, now you proceed with dissection. This is in keeping with the philosophy of the nerve monitoring checklist, which Anuja told you about. You have to first identify the nerve. Before you dissect, identify how much is the amplitude and then dissect. Now we will proceed towards the centripetal dissection. You move from periphery to center. So instead of cutting the parotid tissue anteriorly, I will be cutting laterally. Can you see that?
Yeah.
If you are not able to see, please let me know. I will readjust.
Can you get more light into the field?
Yeah. Can you turn the table? Can you move the table to the patient's right, and we can get more light in? Tilt the table, please.
Sir, any difference between the superficial periodicectomy and suprafacial periodicectomy?
So it is the same thing.
Same.
Can you see the nerve?
Yes, sir.
Yes. So you are now not going according to the branches. You are getting it more laterally.
You're at the trunk now.
Yeah.
You're not seeing the branching. Right?
Okay.
You are now moving the parotid tissue where there is no branch. So you're absolutely safe.
Oh, okay.
There is no branching here at all. At the most, one nerve would have gone to supply the digastric
Right.
or the stylohyoid. Right?
Right.
Now you're seeing
It
more
is
and more of the nerve.
Still it is main trunk, sir.
It is still main trunk, yes. Till you start seeing the nerve, marginal division, cervico-mandibular division, right? So we should see the cervical and the marginal mandibular.
So can I
Tell us if you're not seeing, okay?
Yeah.
So we can see
Your
beautifully.
left hand is actually was coming into the. Yeah, that's perfect.
Very clear.
I'm wondering why you're not seeing on the VTOM. It is so beautifully seen here.
No. This is very, very beautiful picture at present.
So what structure comes next to the digastric is your stylohyoid.
Okay.
So now you have to dissect above the stylohyoid. And medial to the stylohyoid will be your external carotid artery. So all these structures will now come one after the other. So you are seeing the nerve. So you see how the nerve has got stretched, right? So our assistants have to be told to keep that relax a little. Have to be told to keep this lax, not taut. Please pay attention. The operating surgeon will be focusing on the nerve and dissection. The assistants have to be told, please relax. Do not give traction injury.
So when there is difficulty in identifying the facial nerve due to various reasons, then what to do, sir?
I didn't get that question.
If difficulty in identifying the facial nerve trunk,
Yeah.
by certain reasons.
So when you are not seeing the nerve in its natural position,
sir,
after having identified all the landmarks, is that your question?
Same. Same.
Prathamesh.
Yeah.
I want to ask you, see, when you have some damage to the nerve, what the nerve monitor will show?
So there will be a loss of signal. There'll be a reduction in amplitude. So if you have caused a traction injury, now you have said that there's an average of 1000 microvolts impulse seen. And now you are testing again and you see it's only 200. You know that there has been some injury.
Okay.
Now you're seeing the first branch coming up.
Yes, sir.
Mosquito, please. So again, I'm dissecting the nerve, but do not cut anterior. You have to cut lateral. Can you see that?
Yes, sir. Very well.
When you all are doing extracapsular dissection, this is also very important modality, the nerve monitor, because you don't know where the nerve is at that point, and you are going to be dissecting around the capsule of the tumor, and you don't know where the nerve is. So for instance, if this was the tumor and I had to dissect, I would use the nerve monitor to identify before I cut. So I would then test the nerve and then I will cut it. So if my electrophysiologist tells me that there is a nerve in that tissue, I will not cut it. I will dissect.
Can you please demonstrate that? The difference in the sound very close to vicinity of the nerve and actually on the nerve.
Yes. So that is the nerve you can see.
Yes, sir.
Cauterize that, please.
Which branch is it, Prathamesh, now? Which you are dealing
This is the marginal, this is the main, this is the first division, the cervicomandibular division. You can see this?
Yeah,
Yes, sir. Can you just focus on the camera, on the monitor?
So can I take some virtual platform question, please?
1 minute, please. Let us show this, then we'll discuss. So that was the marginal division.
If you can see, the lower two are the lower trunk branches, the oris and the mentalis. So you can see the signals are in 1,000 for the lower branch when he was stimulating the lower trunk.
Yeah, very well appreciated. Yeah.
So now we will again dissect. We'll dissect and yes.
Can you stimulate the parotid gland itself? Then see how it is. Yeah.
Yeah.
Hello.
Give me that stimulator.
Prathamesh ji, Janakram.
Now you can see that. Yeah, Janki, 1 minute. This is the parotid, normal parotid. Samir.
Yeah. Yeah.
So that is the sound that you'll get, that there is no nerve impulse.
Okay. Yeah. Yeah.
Yeah, Janki, sorry.
Yeah, there are two things I wanted to tell. Number one, somebody asked Mario Sana, if you hear a train in the facial nerve monitor, what does it mean? Then he sarcastically answered, then you're a bad surgeon. So that is the first thing. Second, I think in this nerve monitor, I think there should be an improvement where, as you said, the instrument should be connected to the nerve monitor instead of using a separate probe.
Yes, Janki. So that's what I said. The continuous nerve monitoring is the way ahead.
Yeah.
And we need to move towards that. So in the thyroid surgery, they have now the continuous vagal monitoring.
Yes.
So your instrument that you are using, if it is connected to an electrode,
yes,
and as you dissect, you're getting the sound.
Yes.
Then you know that you're causing some injury, some traction injury, some thermal conduction, something whilst you're doing the injury.
Yes.
So, and that time you can prevent it. After having done that, you're checking the integrity.
Exactly.
Makes no sense.
Yes, yes, yes.
So
Another
you're right.
thing, sir, this also is useful in SSEP for this one, the sensory
Awake
nerves
state
also.
monitoring. Yeah, absolutely. So the awake brain surgery that they do is basically the same thing. They're actually checking for the cortical tracts.
Yes.
Whilst they're doing the tumor dissection.
Yes.
So they know that this is an active functional component. They should not dissect that tract.
Exactly. Yeah.
So you can see now the retromandibular vein coming onto the external jugular vein.
Beautiful.
And this is how we will use that. It is also giving a traction. So I know that I have to remain in the plane above it. So you can see now the vein coming up and the cervicomandibular division being dissected. So there is a maximal removal of the parotid whilst preserving the function. And you're getting the entire tumor out together without causing the piecemeal resection or any seedling. Now we are seeing the cervical branch coming up. Yeah. Anuja will show the application of the continuous nerve monitoring. Can they show that? Can you show the clip? Samir, can you see the clip?
Not really. Not yet. Yeah, now.
Yeah.
Now we can see that. Yeah.
So what they do is they place that clip around the nerve. So now having dissected this nerve, I can place the clip around it.
Okay.
So when I am dissecting, it is stimulating the nerve as well, and it creates that completes the loop. So while you are dissecting it, you will get an impulse, and you'll know for sure whether you're actually causing any traction injury.
Yeah.
Is this available with Medtronic?
It's metonic only. It's metonic.
Okay, okay.
So what is the difference between partial superficial parotidectomy and extracapsular?
So now we are seeing the cervical branch coming. 1 minute, please.
We couldn't hear you. Can you just repeat your question, please?
Sir, what is retrograde parotidectomy?
Retrograde identification of the nerve. There is no retrograde parotidectomy.
Yes.
In cases wherein you have got entire fibrous tissue here and you can't identify the nerve, then you will go from periphery to center.
Yes, sir.
So you will identify, you will do a thinned out dissection at the masseteric fascia
Yes, sir.
and then try and identify the nerve and then trace it backwards. We are doing an antegrade dissection.
Yes, sir.
And you can't identify this, then you will do a retrograde dissection.
I think there are lots of studies done by the Stanford group on a retrograde parotidectomy, and they do mainly extracapsular dissection of the parotid tumors. And they found there was no difference between the paresis when they did the retrograde dissection.
So what would be your indication, Anuja, of doing
So maybe like the tumor which is really going till the stylomastoid foramen and you really cannot see the main trunk at all. In that situation, maybe you can come from retrograde level so that you cross the tumor and then you can get the main trunk. That will be the one of the, or the a revision case where there is so much of a fibrosis that you cannot find the main trunk, then you will go from the area which is not operated. That will be a retrograde approach. That will be two indication maybe in my book to go for the retrograde. Otherwise, I think antegrade usually it's a norm, and I think it is a well described technique to do the procedure. That's what I feel. How you do about the retrograde? Do you do it for any other indication?
No, I will not do it per primum. If in case I am facing a problem, I'm not able to identify the nerve, and like you said, it is very rare. I may have used it very sparingly.
Prathamesh, what is your experience about facial nerve neuromas in this region? I mean, have you encountered any and how you managed it? Particularly the facial nerve neuromas in this region which mimic like a parotid swelling or a pleomorphic adenoma.
Yeah, so we have seen a couple of schwannomas.
Right.
So we have, because we are dealing with these tumors coming onto the lateral skull base, so we have patients presenting to us with a large swelling in the mastoid, not looking like a parotid. And then when you do an MRI, you actually know for sure that this is a schwannoma. And luckily for us, the ones that are manifest are already having some degree of nerve palsy. Otherwise, it becomes a challenge, like in any schwannoma, when to sacrifice it.
Yes.
Would you actually sacrifice the nerve, or would you want to, observe? So
Right.
our philosophy is to observe. We will not unnecessarily go ahead and dissect the facial nerve schwannoma. We will counsel the patient. We will ask him what is the symptoms. If he has no palsy, it doesn't make sense to go ahead and do the surgery. Many times it is coming on, it is dumbbelling. It dumbbells from the vertical component along the stylomastoid foramen and then comes out.
Okay.
So at that point, you will then end up sacrificing from the second genu right down, and then you'll have to reconstruct.
Okay.
So if the patient has no facial nerve palsy, it doesn't make sense.
Right.
We had a couple of patients with the nerve having a schwannoma in the vertical segment, which was coming up to the first genu. In those, patient had tinnitus, patient had hearing loss. Now, in those cases, you can't do anything. So you
Right.
counsel the patient that yes, surgery might be beneficial. So I would look at it very critically. Does it really benefit the patient? If it benefits the patient, then go ahead with the surgery.
So clinically, if there is no facial nerve dysfunction, you will just try to observe that.
I will keep the patient under a close surveillance.
Okay.
I will do a sequential MRI and identify what is the degree of discomfort the patient has, and is the nerve palsy developing or progressing, and then go ahead.
Okay. Okay. Great.
So you can see this is the retromandibular vein.
This
Some branch.
You will preserve till the end, or you are just
We'll preserve, because unless this is coming into your path of dissection, this seems to be more superficial than the classic retromandibular. So I'm not sure that this is the branch coming from the retromandibular, but I will preserve it till the very end.
Okay.
Okay.
Yeah.
So now you're seeing the divisions coming up. This was the cervical division.
Yes.
And that's a marginal division. Can you see now?
Your hand is coming in way, the left hand. Yeah,
that's a cervical division.
Yeah.
This one.
Yes.
And this is your marginal going anterior.
Yes.
So now we have still dissected lateral. We have not dissected anterior and cut the tumor.
Yeah.
Bipolar. Yeah. So now we will.
Prathamesh,
Yes.
Prathamesh ji, you are not even using a loop.
Right now I am not using a loop, Janki. That's what I said.
Eye is super, boss.
He's actually not even looking at the screen.
We can't operate without a microscope, and you're not even using a loop.
No, I think that is wrong, Janki. Everybody learns, right from the time they're being taught. So I personally feel that all the colleagues should use some form of magnification. Should. Because you can't depend on your naked eye and all the time. And if you are doing a critical surgery where the nerve is important, you would rather use a good magnification. So I would be safe for the patient. Because we have been used to doing this, we are continuing it. But I don't think that is an excuse.
Okay.
Now you're seeing the nerve?
Yeah, very well.
Okay, so now we are again in the plane over the facial nerve.
Sir, whatever the vein exposed is not retromandibular vein, sir. It's looking like.
It's not looking, you're right.
Yeah, because retromandibular little thicker and curvilinear.
And it is very thin.
Yes.
So I can actually sacrifice it, but just for the sake of
that's
surgery.
The retromandibular vein, sir.
Yeah. So just for the sake of surgery, I'm just going to preserve it so that we identify the nerves, right?
Yes.
Dr. Prathamesh.
Yeah.
Is there any role for endoscopic parotid surgery, sir?
Endoscope, robot, all have been used. And a lot of people are doing now robotic parotidectomy as well. But I don't think that it is something that will be very popular. One, because of the costs and the equipment involved. And two, because of the time taken for the surgery. So though the proponents of it and those who are masters robotic surgeons, they will demonstrate the surgery in very short time.
Sir.
But we need to understand what is the implication for us as practitioners.
Yeah.
Do we really need to do it? So we don't need to do it. What is the advantage? Advantage is for cosmetic purposes. So is the cosmesis the only thing that you require? If the patient demands it, then I would send it to the surgeon who actually does all this in a big volume. Remember, even in Tata Hospital, we are doing about 40 to 50 parotidectomies in the whole year in 3 units. So the volumes are not much. So for you to gain experience in these type of surgeries using high cost equipment is not justified. Scissors.
The people consider thyroid and parotid, because in most of the centers in thyroid surgery, some people are doing endoscopic surgery and robotic intraoral. So from that point of view, whether we should encourage endoscopic parotid surgery.
It's not about encouraging or not. There are some people who are pioneers who will start off, and then all of us will follow it if it makes sense. As of now, I'm not sure there is any indication for it.
Okay.
I don't know what others have to say. Samir?
Prathamesh,
Yeah.
since it's a small tumor, I mean, you know the level of the nerve now. So would you
Yeah.
like to do remove all superficial parotid gland, or you have to resect a cuff of normal parotid along with the tumor, leaving some gland for cosmesis?
Absolutely, you can. But now, having said that about cosmesis, tell me what kind of cosmesis will you offer in a partially resected nerve gland, and then what about the function? When I look at it holistically, there are two areas of the parotid. One preauricular, second is retromandibular.
Right.
Now, if I have the tissue involved in the preauricular region, and 80% of the nerve glandular function is preauricular gland, how am I able to preserve any function at the end of the surgery? I won't be able to do.
Oh, not about function, about the depression which you cause after doing entire superficial parotid.
So there are various methods to overcome that. So most important in my criteria is a function. Am I actually preserving glandular function? If I'm not preserving glandular function, then why am I struggling?
Okay.
That's one. If I am preserving glandular function, I can understand if you're doing only a deep lobe resection, 80% of the gland function is preserved if I preserve the superficial part. Here I'm actually going through the superficial part. So what is more important to understand is, can I do an extracapsular dissection wherein I remove only the tumor with a cuff of normal tissue around it and then close it back? So the proper question is superficial recommended, or should we all be doing extracapsular dissection?
Okay.
So what I feel is we should do an extracapsular dissection if our focus is to do a gland preservation, function preservation. Now for cosmetic reason, you said for cosmesis, you can take free abdominal fat graft, and you can use that graft to actually overcome that hollow that occurs after parotidectomy.
Okay, okay. Prathamesh, I'm Dwaraknath Reddy here. Are you able to hear?
Yes, please.
See, this once you do the dissection part is done, because Nupur is waiting there for the case. I think it looks like the case is intubated. So once you be with that dissection, then we'd like to switch over to that case. So once this dissection is over, please let us know. I think in the meanwhile, I think we will not go for many of the just demonstrate it, and then we don't go for many of the questions now, because that case is ready there. Nupur is
Absolutely.
waiting. Okay?
Please go ahead. Please go ahead.
Thank you.
Thank you. Thank you. Scissors.
Prathamesh,
yeah.
How many times have you ever come across Fraze syndrome after the surgery?
65% to 75%.
Okay, and how did you manage those cases?
But most of them is because you're asking the patient, do you have this, do you have that? If you ask, only 5% of those patients actually complain.
Okay.
So there's a difference between you asking for the symptom and the patient complaining. So if I say that Fraze syndrome being reported by the patient is very rare, 5% and less. But when you ask pointed questions and you ask him, do you have this wetness in front of the ear? Do you have do you have some redness? They will then tell you yes. So that is very high. 60-70% of patients will have it, but they are not troubled. So they will not report it to you.
Okay. So the story remains the same. No suggestive questions should be asked.
No, if you're true to your craft and you want to know how to improve, then you please ask.
Yeah, okay.
How can you present the phrase syndrome, sir?
Yeah. The next question, Pratham, you didn't answer. How do you manage those?
So those patients who are symptomatic, then we will give them Botox injections, and that relieves the symptoms in most of the patients. And all.
We lost you, sir.
You don't believe in tympanic neurectomy or something like that?
No, I do not practice that. Does anyone have an experience in that?
No, no.
So here you can see, Samir, the retromandibular vein.
Yeah.
That's the return.
Right? That's the retromandibular vein joining into the facial. And that's the external jugular. And you can see how the nerve is coursing above it.
Superb.
Excellent.
Prathamesh,
So
before you
that's
go
our
off the
cervic-
camera.
That's a cervical.
That's
Hello.
cervicofacial, this one.
Yeah.
Prathamesh, can you hear me?
Yeah, go on.
Before you go off the camera, let me compliment you. The way you have managed this case, right from the presentation and how you have involved everyone in the surgery, that is really commendable. That is a real sign of a leader. Hats off to you for this and a beautiful presentation.
I would like to thank Dr. Anuja, Dr. Richa, my colleagues here in surgery, Anup and Vidula, and Meenakshi, because they have really put a lot of efforts in making these presentations and trying to enhance your, learning experience today. Thank you very much. Chalo.
Could you hear the big round of applause, Prathamesh?
Yeah, thank you very much. Thank you.
Yeah.
This seems so well. It is getting recorded now. Click. One more. Pen drive.
Dr. Prathamesh ji.
Yeah.
We'll have a 5 minutes break. And then.
No, please carry on. I think Nupur is waiting.
Okay. Thank you very much, Dr. Prathamesh ji. Let us give a big hand of applause to him. Such a beautiful demonstration of parotid. Bloodless. Usually it's full of blood, but not even RBC we saw. Very, very nice, sir. Thank you very much. And that highlight was the retromandibular vein, which you actually traced. A very, very nice presentation. Thank you so much, sir. Thank you so much.
Thanks,
I hope you come to Hyderabad today evening.
We are not joining there, Hyderabad today. We'll join you next time, Janki.
Okay, sir. Sure. We'll miss you, sir. We'll miss you for the dinner. Okay.
Thank you.
Thank you so much. So, yeah, we can stop the projection.
Thank you, panelists, for chairing this session. We had a wonderful start today. Let us take few moments to seek blessings and light the ceremonial lamp in honor of Goddess of Knowledge, Ma Saraswati, by offering our prayers. I would like to invite dignitaries Janki Ram sir, Sudarshan Reddy sir, Sampath Kumar sir, Sridhar Reddy sir, Indra Devi ma'am, Pradeep Shaure sir, Venkateshwar Rao sir, Dwaraknath Reddy sir, Shyam sir, Nageshwar Rao sir, Venkatramana Reddy sir, Mr. Nitish Srivastava, Sun Farmer, and Mr. Amit Shukla for the lamp lighting ceremony. Anand Acharya sir, sorry. Vanilla, ma'am.
Ya Kundi.
Not down yet. Thank you, everyone. Yes, ma'am. Sir.
Good afternoon, everybody. I think it's a proud privilege that Janki is here with us. I think he has practically now he has become a Hyderabadi now because with all us. So we welcome him over here for doing this important program. See, without me, you are taking the photo also now. I had to come there. I'm joking. Okay, anyway, I congratulate the entire team. For that matter, we all had the best of the stalwarts who has done the job today. Right from Milind, then we have seen Prathamesh, and we are going to see Nupur and a series of the people. They are going to do the wonderful job. This all could happen with the involvement of Janaki and the team. And last but not least, I should thank the entire Sun Pharma for, I think, taking care of this sort of a situation and percolating this knowledge to so many people around the country, maybe across the globe also. So I think it's a really wonderful occasion. I'm sure that many more are going to come in future. Naturally, when Janaki is going to be there. Thank you very much.
Sir, I need your blessings, sir. We need your blessings. We are a team. Sir, just want to tell you that 4,900 doctors are seeing this program from all over the world. And all credit goes to Sun Pharma. Really good, really great program. I just want to announce that Professor Nupur Madam is going to start a case now. Very interesting case of papillomatosis of the larynx. It's a very, tricky case. She's going to start. Dr. Purva will introduce. After that, I am going to Vasavi now, and we'll be doing two cases today. Very, very interesting cases of a tumor post-pituitary going everywhere possible inside the skull base, which we are going to demonstrate, and also one hemangioma of the clivus. There are only 2 cases reported in literature so far. And luckily we got that case. And that's also another JNA. So 3 cases are going to be demonstrated after Professor Nupur, 2 cases, and tomorrow we'll have 1 case. So please enjoy. I think there is no lunch as such, son. So it's just a working lunch. Yeah, it's a working lunch. So feel free. Thank you very much. Thank you very much, all of you.
Dr. Janki Raman.
Thank you, Dr. Janki. And once again, on behalf of the Sun Pharma, I extend a very warm welcome to all the delegates who have come for this conference and all the delegates who are sitting across the 80 centers across the country. So thank you so much for making us to be a part of this function. My special thanks to all the faculty members and the panelists for making this the conference a glorified and a wonderful conference. It has always been our endeavor at Sun Pharma to provide the platform for the academic feast of all the clinicians, and this is such a event to provide you the best of the best. Thank you so much.
Thank you, Srivastava sir. Mr. Nitish Srivastava sir is cluster head for our acute division, and he is very instrumental in supporting our scientific activities. So thanks a lot. So I have a privilege again to introduce one more expert, Dr. Nupur Kapoor Nerurkar. Madam is consultant laryngologist and head Bombay Hospital Voice and Swallowing Center. She is a DNB coordinator for ENT and laryngology, and as a fellowship director. She has been instrumental for around 11 years in Sion Hospital in teaching. And then since 16 years, she is laryngologist at Bombay Hospital. She has Hargovind Fellowship Award for laryngology training in USA. Her area of interest are laser surgery, neurolaryngology, planomicrosurgery, ADSD, LEMG, professional voice, and office procedures and dysphagia. She has notable achievements with her. So you will like to add? So she is past president of Association of Phonosurgeons of India. 2016, she has established the Bombay Hospital Voice and Swallowing Department in 2018. First and only Indian laryngologist to become fellow of the American Laryngology Association and ABEA. Chief editor of a textbook on laryngology and author of Atlas of Phonomicrosurgery. She is gold medalist as a junior consultant and junior consultant awardee. First prize in Jaiswal video session, AOI Hyderabad in 2005. She has also won the 3rd prize in senior consultant award in Bhubaneswar, and David Howard Prize by British Laryngology Association, Malaysia in 2012. This is just a brief about her because we have short of time, but then Janki sir will like to add something.
Yeah, the case has been intubated. So only 2 lines I want to add about Professor Nupur. One thing in common is that we are all students of Professor Kirtane. So that way we are very well connected. Second point is, I was one of the very first to invite Nupur madam to Trichy. So she came and demonstrated a vocal cord polyp. Do you remember, madam?
Absolutely.
Are you hearing us?
I am hearing you. Am I audible?
Yeah, you came to Trichy and honored us with a beautiful case. And now again, we are seeing you in action. Over to you, madam. Thank you.
Thank you so much, Janki. I hope I'm audible for all of you all.
Would you like to keep the mic near you because your audibility is a little low?
Can you make it louder or get the mic near me, please?
Yes, ma'am, we can hear you.
Can you make it louder?
Keep your
Is it
mic
any
a
better
little
now?
low, near you.
Janki, is it any better now?
Better now, better.
Better now? I have to add on to what you said, Janki. The first time you invited us, Jaykumar and I were driving from the airport, and we were told, Dr. Janki is busy shooting right now, but he'll meet you. So we were wondering, you're shooting wild animals, what are you shooting? And that's when I discovered you're an actor, you're a singer.
Madam, actually your voice is a little muffled. Can you just adjust your mic, please? Because we are not able to hear you.
Can you get the mic nearer me, please?
So, sir, madam's mic is okay. Can you increase the level from the hall?
Level in the hall. No,
Yes,
no.
sir.
Can you? They are telling you you increase the level of the mic. It's too low.
Just get the mic.
Or you have to take off that mask. The mask is too like COVID
Yes.
mask.
Is it any better now, Janki?
A bit better, ma'am.
No, madam.
No, you're going to make me operate without a mask. Yeah, I think so. Or just get it
Madam.
very close to. Put it
We
in.
want to hear your sweet voice.
Hello?
Hello.
The mic is in the mask now. Is it
Now
any
it's okay.
better?
Now better, better. Wow, fine.
Okay. All right. Fantastic. So you missed the story about what I said as to when you invited me and you were busy shooting and then we discovered you're an actor also. But I thank you so much for your kind invitation. I thank Sun Pharma and of course I thank my mentor, Dr. Kirtanu. If I'm audible enough, I'd like to immediately start by explaining about the
Madam,
case.
sorry, madam. See, you are a voice specialist. I don't have the thing to comment. But all of the audience are telling that your voice is not heard properly. I don't know. Your voice is a little muffled. I don't know why it is like that. We are not able to clearly hear you.
Mask law. Surgical mask law. Okay, I'm going to change my mask, Janki. Colors. I'm going to just give you a brief history about the patient and the movement. Dr. Hema and Dr. Devi are my current client.
We are not able to understand you.
Yeah, ma'am. Just remove this mask. Use a normal mask, ma'am.
Yeah. No, your mic is out.
Can you hear me now?
Madam? No.
No, ma'am.
It's not a mask problem. I just taken my mask down.
Can you put the mic close to your mouth, please?
Yeah, 1 second, sir. We are adjusting.
Madam, can you talk now? No.
I don't show any paper here. Can you start giving the history on that? Maybe that might be better. Hello? Am I audible?
Dinesh ji, there's a problem with that mic, Dinesh ji.
Yes, sir. Sir, we are changing the mic. 1 second, sir.
Change the mic.
Can I have my mask?
No, change the mic.
Hello?
Madam, we are able to hear you.
Hello. So we have 38-year-old patient with a history of juvenile onset respiratory recurrent papillomatosis. And he has a history of 36 years ago that he had his first surgery at the age of 2 years. And in that first surgery, he underwent colostomy because of breathlessness at that time. And soon after his first surgery, he was decannulated. And till now, he has been operated 30 to 40 times approximately, and he's been under our care for past 8 to 9 years. And he's been undergoing surgery every 1 to 2 years approximately. His viral type is type 6.
Excuse me, madam. Sorry. Excuse me, madam. Dinesh, please, the mic is not okay. Please, we are not able to hear properly. Because
yes.
Yeah,
just give me. Yeah, just give me 1 minute, sir. We are sorting out the technical things. 1 minute, sir.
We didn't understand whatever madam spoke.
Can you hear me now any better?
No, madam.
No, ma'am. No. Your voice is fading a lot. 1 second.
It's very muffled.
Yeah. Ajad, is there, Mike? There's a technical guy. Is there, Ajad? So just kindly change the battery. I can understand what is the problem is there. So.
He just changed my battery actually.
Dinesh, is it the problem with the battery or something else? Because
sir, there might be just he's changing the mic. The sender or receiver
you
might
give
be.
your mic to her, no? Because you are so clear.
Yes.
That's better.
Hello, yes, sir.
Yeah, Ajad. Yes. Now your voice is good. Can you hear me?
Yes, sir.
ठीक है. तो ये माइक दे दो मैडम को.
नहीं ये हैंग माइक है, वही सेम, मैंने कुछ चेंजेस नहीं किया, वही सेम रखा है.
यस यस मैं आपको फोन पे अपडेट कर रहा हूँ. आप ये माइक तब तक दीजिए जस्ट टू स्टार्ट एट एंड देन आई विल टेल यू.
Dinesh, his mic also is not good. His
Hello,
mic
is this
also is not
better?
good.
Is this any better?
No, 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 no. We want clear voice.
हेलो
हाँ.
हेलो बाहर जो बंदा है उसका माइक लेके दे दो. हेलो
It could be better.
सर दिनेश सर आवाज क्लियर नहीं है, स्लो है, कैसा है मुझे बताइए.
आवाज फेड हो रही है दोस्त. आवाज आपकी क्लियर नहीं है. जस्ट पिक माय कॉल.
अभी चेक. हेलो.
No, no, it's muffled, boss. Oh, it's not clear.
हेलो अभी सर कैन यू हियर मी.
No, 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 no. We can hear, but it is very distorted, muffled.
What about the person outside? The audiovisual person outside has a thing like this. क्या वो सिस्टम आपको इधर थोड़ा नजदीक लाना है? I don't know.
Just give me 1 minute, ma'am. We are not going to take more than that.
Okay. Hello. Dinesh sir. Hello.
Just pick my call.
Till the technical glitch is resolved, I'll just introduce the panel members for this session. I would like to invite Dr. Krishna Kishore sir, consultant of Medical College, Andhra Medical College, ex-superintendent Vizag, holds interest in anterior skull base and cochlear implant. Dr. Vishnuvardhan Reddy sir, former professor of ENT, Usmania, working in Malareddy Institute, research fellow laryngologist. Dr. Kanchan Pathak sir, consultant ENT surgeon at NM Multi Super Speciality Hospital, West Bengal, and advisor to Indian Cancer Society. Dr. Captain Sudarshan Reddy sir, former HOD in Government ENT Hospital, current AOI Hyderabad President, and Professor of Government ENT Hospital, Koti. Dr. Dushyant Ganasuni sir, consultant ENT surgeon and laryngologist at Dr. Rao's ENT Hospital, Hyderabad. Dr. Sampurna Ghosh ma'am, consultant ENT surgeon at Max Cover Hospital, Hyderabad. And the moderator for this session are Dr. Ananda Acharya sir and Dr. Nageshwar Rao sir. Thank you.
Thank you. Is the voice clear?
Hello.
Hello, madam.
Yes, ma'am. Yes, ma'am.
Is the voice any better?
Yes, ma'am.
May I start then? I'll give a short history myself. The patient is around 43 years old, male, adult, case of recurrent respiratory papillomatosis. He has had a juvenile onset of papillomas, and if we can just zoom over here onto this photo. So this particular patient was diagnosed with juvenile onset papillomas at the age of 2 years, which is when a tracheostomy was also done on him, unfortunately, at an outside hospital, but he was decannulated pretty quickly. He's had about 40 surgeries done so far, and he's presented to us about 8 years ago. We've been managing him, where he needs surgery almost once a year, sometimes once in 2 years. So if you see, this is the kind of image we always put up in the OR, so that the anesthetist, surgeon, nurses, everyone knows what is a glottic chink, what is the pathology like, and there's no problem as to the laterality of the lesion. So having seen this, I'd like to just move as to what we've already done to save time. We have put the scope in, we've intubated the patient. Janki, I'm audible now, I hope. This is the laser safe tube which we've used. This is a Mallinckrodt laser safe tube. And as you can see, there are two cuffs that this tube has. The reason there are two cuffs is that if one of them ruptures during the use of laser, we still have for safety another cuff. And why would it rupture if it's a laser safe tube? Because everything in a laser safe tube is safe other than the cuff. This is still made of material which can be inflammable. We typically in laser cases would inflate this not with air, but with cold water or cold saline, so as to kind of have a buffer effect created. So we have intubated this patient. Our patient has been intubated with a 5.5 number laser safe Mallinckrodt tube. Having done that, we have also covered his eyes with moist gauze piece, as you can see over here. And we have also covered the entire face with moist mops. Now, this is all for laser protection. Besides this, our anesthetist, I'd like to introduce you to Dr. Pradnya Kulkarni, who is the head of Department of Anesthesia in Bombay Hospital. We take good care that we are not going to be using any inflammable gases like nitrous oxide, and the oxygen, the SpO2 is going to be less than, is going to be less than 25. Is that 25? So that we don't have an environment which is ready for a fire. So having intubated the patient, typically what has been described in patient position is Boyce's position. But what we use actually is more, what I personally like to use is a neutral position. So what that means is, of course, we are never ever putting a shoulder underneath the, shoulders of the patient, but I'm also not putting any kind of a headrest underneath the head. So I'm not giving a Boyce's position where there's flexion of the neck on the chest and extension of the atlanto-occipital joint. Mine is simply a neutral position with extension of atlanto-occipital joint. But if needed, a Boyce's position can be used. In very difficult cases, a flexion position can also be used for intubation. Having intubated the patient, we always keep on the neck of the patient, as you can see over here, we put like a big gamgee and we tie a mastoid bandage. This is a mastoid bandage. We tie to one side of our OT table so that if we need a lot of anterior commissure pressure, then the OT boy will, give pressure on this, and the gamgee protects it from having a very bad mark on the neck, and we will sort of tie it to the other side. And the other thing which we do is we typically will always use the chest piece on a Mayo's trolley. Now, this Mayo's trolley has been modified a little bit so that it can be attached to the OT table itself over here, so that every time we move the OT table up and down, the Mayo's trolley will also move up and down. And so this assembly of ours need not get disturbed. So it's not a separate attachment which is on the floor, but it's attached onto the table. So as you can see over here, we've got a chest piece in, and I've used a Klein-Sasser laryngoscope for the introduction. So the introduction of the laryngoscope is basically, if you're a right-handed surgeon, we put a little bit of jelly on the tip. We make sure that the patient has got a tooth guard to protect the upper teeth at least, and this patient does have one. After which we will introduce the scope first by having my assistant hold the lower teeth and I'm holding the upper teeth in a downward direction. As soon as I see the epiglottis, I will lift up the epiglottis and go up to the false vocal folds, not trying to push all the way into the subglottis or even the true vocal fold, which is when chest piece gets attached and we have a look at the laryngeal introitus. Now, just a quick look here onto the trolley. You can put the telescope and camera on this. So this is what a typical trolley would look like. I hope you have the picture there. So sometimes we have edentulous patients, in which case this plastic with stainless steel tooth protector is extremely useful to give good support, especially in edentulous patients. We also keep an anterior commissure laryngoscope. As you can see over here, this is a Dido laryngoscope. I find it extremely useful in the difficult larynxes, but otherwise, we use a Klein-Sasser laryngoscope, as I have introduced in this particular patient. The laser safe tube I've already explained to you, and this is an infiltration needle, which is 22 centimeters in length. It's bayonet shaped so that your vision is not affected, and the tip is 26 or 27 gauge needle over here. It's a very thin one, and we use this for the infiltration. Then, of course, we have our microflap elevators and a universal handle. This is the universal handle. Here we can attach a sickle knife, microflap elevator, whatever you may want to use. And then, of course, we have our cup crocodile instruments. But what I find the most useful instrument really is the heart-shaped or the Boucher forceps. So I just want to show you this. This heart-shaped or Boucher forceps is something I would encourage all of you all to have in your setup, because it's an extremely elegant instrument where you can hold the tissue. Not all tissue is big, so you don't want to morselize it. There is a lumen within it so that the tissue doesn't get fully crushed, and it also grips the tissue very nicely. So if in the beginning you don't have a right and left heart shaped, at least have a straight or a upward heart shaped. And another instrument I would like to quickly show you are these instruments which we have made for ourselves, because we do get many references with difficult laryngeal exposure. So we have made these instruments which are flexible tip instruments for that very, very challenging larynx, where you may want to put a 70-degree telescope in and flexible tip instruments to take a biopsy at least, so that you don't have to abandon it. And then here we have, of course, a vocal fold spreader, which can be used to retract the false vocal folds and see the ventricle, or to retract the true vocal folds and see the subglottis. So besides that, on the trolley, we have these patties, as you can see, which have all been sort of counted, and they're all dipped in 1 in 10,000 saline adrenaline solution. Now that my scope is in, just hold this, I'm going to be taking a telescopic view of our lesion, and then typically preoperatively, we always take a photo. We give the preoperative and postoperative photo to the patient. It's important to do that for documentation, because lesions recur, like papilloma, keratosis, etc. Can we have a white balancing? We prefer not to give CDs of surgery, but we do always give the photo of pre and post-op. Are you able to see now the endoscopic photo?
No, ma'am, we are seeing the surgical picture, your picture with the setup.
Okay, so can we stop my photo and give the endoscopic, please? Only endoscopic photo now, please.
Yeah, we can
Okay,
see.
are you able to see it now, I think?
Yes, ma'am.
Yes, ma'am.
Visible.
Right. So what we see here are typical papillomas, fronds of papilloma at the anterior commissure, photolina. But you can also see the right false and true vocal fold, and you can see that the ventricle is also got a linear papillomatous growth. Can that be seen here?
Yes, clear, ma'am. Ventricle
We can
is
see, and we can see the Mallinckrodt tube, and the cuff is lower down, not coming in our way. Now, if we just do a spectra A, please, Karna. Sometimes when you're operating on malignancy, you may want to use a spectra A light to see or look for the IPCLs, which are the intraepithelial papillary capillary loop patterns, which are these brown dots which you see here. Now, papilloma will give you false positive IPCLs, which is what we see here. We know this is not a malignancy. Photolina. So considering, yeah, thank you. Now I'm going to be switching on to the microscope view. You may not get a picture for a little while. Can I have the microscope? So keeping in mind the patient has been operated over 40 times, it's important to see that has he developed any anterior commissure webbing, etc., which are the things one really wants to avoid. We want to avoid that. And if there are any questions till now about just scope, introduction, etc., I'd be happy to take them while I'm setting up the microscope. The microscope is being set up, of course, at 400 millimeter. And we have the laser set up, but my plan, because this is a bulky disease, is first to use the microdebrider and then do the finer work.
Setting, ma'am, the microscope, want to ask a few questions, not about papilloma, but other cases, like when the patient is very fat and short neck and there is a lesion in anterior 1/3 of the vocal cord, it becomes very challenging first to do the exposure. The actual surgery may be very short duration, but the exposure becomes struggling. So any tips about fat, short neck patient and anteriorly how to expose?
Yes, absolutely. So the question is, how do we tackle a patient who is a difficult exposure for whatever reasons it may be, because of a decreased extension of the neck or a short, fat neck? The way I do it in my mind is I go with steps. The first thing I do is the position I've given the patient. So I first work with a neutral position. If that doesn't work, I'd go with a Boyce's position. I would always want to take first a Klein-Serser laryngoscope. If that doesn't work in exposing the larynx for me, I would use an anterior commissure scope. When I feel that I'm not able to see the larynx, whatever I do, very often I'll want to withdraw the laryngoscope. So that means if I am up to the false vocal folds, I may want to withdraw it and come more towards the laryngeal surface of the epiglottis. And along with that motion, give a lot of anterior commissure pressure, as I mentioned, with the bandage which is already there. Having done all this, we tie the bandage and we make sure the anesthetist relaxes the patient completely. Very often we've noticed that very challenging cases, after 20 minutes of complete relaxant anesthesia, and external counter pressure and internal distension, you are able to now see the lesion which earlier you just could not. So you have to be patient sometimes and give it 20 to 30 minutes while you are attempting other things. And finally, if it is just impossible, then we use a 70-degree any angled telescope along with flexible tip instruments and take a biopsy. On occasion, we also use a flexible bronchoscope with a side channel of instrumentation through the bronchoscope and try and tackle the lesion. I hope that answers the question. And I hope now we are on to, can we give please the microscopic picture to the delegates? Are you Clara Chroma hai? Are you able to see the picture of the papillomas?
Yes, ma'am.
Hello? Microdebrider?
Visible, ma'am, visible.
It's visible, right? Yeah. So the first thing I'm doing is I'm placing a subglottic patty inside. We already know that this patient has got HPV type 6. So once I've done a viral,
zoom out a little bit.
Done a viral typing, I don't keep repeating the viral typing, okay? That is not necessary. However, the histopathology, every alternate surgery, I would want to repeat the histopathology simply because sometimes you may start getting dysplasia. Did you say you wanted me to zoom out?
Yes, ma'am. It is out of focus little bit. Yeah.
Oh, please let me know. Is it better?
Better, ma'am.
Should I focus more or is it okay?
Fine focus is needed.
Fine focus. So just let me know when to stop. I'm just let me know if it's getting better.
Excellent. Better, ma'am, better. No, again it got hazy.
बताओ मेरे को focus का please.
Defocused है मैम अब तक. Right now.
This is best.
Fine.
Okay. All right. Thank you. So now we have operated on him 1 year ago. Yes, and we have the histopath. So I'm not going to be taking care. But just to show you how to, we should take a small piece of pathology, heart shape to the left, scissors to the right. So typically every alternate surgery I'd send a pathology, not every year. And whenever we take the biopsy, there is a bleeding.
वासवी हॉस्पिटल लकड़ी कपूर मालूम है कि नहीं?
Can I have a scissor, please? Is everything okay?
पता है? वासवी हॉस्पिटल लकड़ी कपूर.
1000. ठीक है, पहले biopsy. What I'm doing, doctor, right now is I'm simply taking a biopsy for histopathology, not for viral typing. Static big one. Try the blade to me, please.
वासवी हॉस्पिटल लकड़ी कपूर ने
What are the rotations we are on?
लकड़ी कपूर.
What are the rotations we are on, please? Sorry? No, make it 1000. Laser suction to me.
Madam.
Or just give me a suction here. 1000 is fine. Okay. So we've done the pathology and now first I'm going to do the debulking with a microdebrider blade. I'm sure everyone is very familiar with the use of microdebrider, but a laryngeal blade is simply longer blades. You get two types, tri-cut and skimmer. Think of the tri-cut as basically your cutting burr and the skimmer as your diamond burr. That is the way kind of it functions. And so what I'm using right now, if you see over here, this is the tri-cut blade. It's about 24 centimeters in length. And I'm going to do a debulking with this and then the finer work possibly with the skimmer or with the laser. Okay. Go back to the microscope picture, please. Are we on? Is the picture on?
Yes, madam.
Okay.
Would you also consider
So
microflap
this
technique?
is just the debulking I'm doing. Sorry, sir, what did you say? I'm just saying this is the debulking. It's 1,000 rotations per minute. Your suction needs to also work efficiently because it takes care of the bleeding and also sucks the tissue which needs to be debulked. Were you asking me some question? Suction blocked है I think? नहीं, ठीक है. Darshana, big hemostatic patty please with a thread.
Ma'am, the previous surgeries were also done by you?
So about 30 surgeries were not done by me. He was referred to me by about 7 or 8 years ago. And then we've been managing to operate on him every alternate year. Actually, I have also injected him with Cidofovir twice. But unfortunately, it did not help him at all. What I mean by that is, Cidofovir should help by decreasing, one, the frequency of the next surgery needed, the time interval. It should increase the time interval, decrease the frequency, and also the papillomatous growth should decrease. But at least in my whatever small experience I have with Cidofovir, I've realized that the juvenile onset patients don't do as well as the adult onset patients do. And anyway, we know the way the disease pathology works. Ritesh, the suction check, karna? Adult onset anyway seems to work better, in terms of frequency of disease, etc., than juvenile onset. So I've operated on him maybe 4 to 5 times, Ritesh Nikalna.
And you gave intralesional Cidofovir or anything?
Intralesional Cidofovir, 1 milligram per kg body weight was given by me. मैं length change कर रही हूँ, बाद में remember करना. So the maximum one really gives is 1 milligram per kg body weight. And you can dilute it or use it concentrated. And typically one should do 3 such injections at the interval of about 3 to 4 weeks. We need to remember that Cidofovir and also Avastin for that matter do create a cumulative toxicity. So we need to keep a count of every time we're injecting and what is the total injection given. And just for some of the delegates who may not be familiar with Cidofovir and Avastin, Cidofovir is an antiviral, but Avastin is basically an anti-angiogenic growth factor agent. And nowadays, there seems to be a very good result when you give it as an infusion for patients who have bronchial disease or very aggressive disease, which you can't really get to with the debrider or the laser or the wand. So I think the first paper was published 4 years ago in Laryngoscope, where an infusion of Avastin was given to 8 patients and 7 of them did really dramatically well. And the infusion is typically given as a dose of 5 to 10 milligram per kg body weight and every 3 weeks for 6 times. Now, this is good, as I mentioned before, for the very aggressive tracheal bronchial diseases because a drug like Avastin does have its own side effects. I have 0 clinical experience with infusion Avastin as a treatment modality.
Hello?
Yes.
Hello, could you use coagulation at this stage because it will lessen the bleeding at the same
I
time?
just want to finish saying what I was mentioning, that I have 0 experience, take this disease, with Avastin as a infusion modality, but I have injected Avastin lesionally and I did not get as good results as lesional injection of Cidofovir provided. Now, to answer your question, absolutely, one can definitely use the coagulation wand to achieve what we are doing, the debulking. And I have done it occasionally. I think they're going to come out with an even better wand, which is thinner. Currently, there are only 2 sizes available, but the company has told me that apparently they're going to come out with an even thinner wand specifically for laryngeal surgery. And then I think that would be something to look forward to because obviously not every center would have a laser, but I think nowadays almost all centers do have
Yes, we have
microdebriders.
less bleeding in that.
Ma'am, about the diameter of the wand.
Yes, for a coblation, or are you asking me about
no, you mentioned about the coblation that the diameter makes an issue. So presently I tried with, because Bonds company has 4 varieties, unlike the last only 2 varieties, and one of them has really tiny diameter of wand, which I have used in pediatric airway as well. So that problem has been solved by that.
So then that is something which is very useful.
Yes, ma'am. That's a
and that's
new.
excellent. All laryngeal surgery, it's a very good cooperation between the anesthetist and the surgeon, because we really need the patient to be completely anesthetized. Any motion of the vocal fold bothers us. So there's a very good fine tuning which is needed. So we're just going to take the patient a little bit deeper right now.
Madam, one question. The patient is having almost the whole lumen is covered by the papilloma. Was the patient?
So can you ask that question again to me, Doc? What did you say?
It's a whole lumen was almost covered with the papilloma. So the patient having some respiratory distress is very likely.
No, actually, that's a very interesting question you asked me, and I'll ask you to have a look at this. Either zoom karenge, please. Either. See, can you see the photo there? The thing about papillomas is, however big they become, they are like grapes attached to the stem, okay? And they tend to flop inside and outside. So you can see over here that the glottic chink is more than adequate. So even though when I'm doing the surgery, it looks like they are so huge, they move with respiration. So for papilloma to cause stridor, they really need to become really big. So patient has no problem with breathing whatsoever, this particular patient.
Okay.
And because papillomas are typically very soft lesions, even if a patient comes to you in stridor, one must try to just push the tube in or do a little microdebrider and put the tube in rather than doing a tracheostomy. A tracheostomy one really wants, we should avoid. Because the chance of then papillomas growing at the tracheocutaneous junction, when there is a change in mucosa and when there is trauma that has taken place, is extremely high. And then that becomes a very difficult story to sort of take care of. So we really want to avoid the tracheostomy. And if a tracheostomy was done, then to decannulate the patient at the very earliest.
Okay, thank you.
Does that make sense? Like this particular patient, though he was tracheostomized, I believe, when he was 2 years old, thankfully he was decannulated also very quickly, which is so important. Otherwise, you get the subglottic papillomas, and then you can have a downward spread. The other thing is, one should, as far as possible, try to do a viral typing, if possible, in your city. Even if it's not available in your hospital, but in the city, because you get an idea as to how aggressive the disease is and whether there is a chance of malignant transformation. Something very interesting about that I'd like to share is that it is not just 16 and 18 which are, associated with malignant transformation, but you'll be surprised that sometimes you get a no type, TYPE. I mean, it is a papilloma, 100% confirmed on histopathology. Viral typing is no type. Those are also known to be associated with a malignant transformation. And we have in the last 6 months, isn't it, Janvi? In the last 6 months, we've had 2 such patients. I think the suction is not strong enough, who have a no type and who have transformed, one to invasive and one to severe dysplasia. I hope I'm clear about that, what I said.
Yes, ma'am.
Can I have a hardship forceps? Can you give me the suction stronger?
Ma'am, this is Dr. Archana.
When we do the no typing, we can have our antennae a little higher up. Second thing is that also encourage your patients now. You can send this for histopath also. Give me that. Give me a big patty to get immunized. And not with Cervarix, but with Gardasil, which is 6, 11, 16, 18. Because it's been shown in a lot of studies, a very nice paper out of Australia also, which shows that eventually when we do these vaccinations with HPV, the herd immunity develops. And so finally, maybe a decade later, the number of papillomas which we see will really go down. Can I have the suction? As it is in the West, where HPV vaccination has become a norm. Can I have the suction, please? You've got a bigger subglottic patty for me? Here. Get a bigger subglottic patty also. And
Madam,
now get the
what is the decision-making point for you that when to do the redo surgery? Because a patient may not have stridor. Up to what size you will allow it to grow and tell them, okay, you need the revision?
Yeah, that's a very good question, because with papillomas, that is always the dilemma, right? So, of course, you don't want it to get anywhere near airway discomfort. But when it is hoarseness, which a patient finds debilitating, that is a situation when I decide that, okay, we should go in for another surgery. Not that I just see a papilloma. Very big subglottic patty. So if I see a little bit of papillomas in the ventricle, etc., but it's not bothering the patient in any way, get bigger patties than this, then I wouldn't jump in. Typically when there is hoarseness, nowhere, don't let the patient get to a stridor situation. So I have patients who are coming from out of town, very big patty for the subglottis. And now, the patients also know, the patients and very often their parents, because many of the patients are juvenile onset, and they hear the change in the voice, and they know that they need to bring the child back. Because otherwise, how often do you ask them to follow up becomes the other question. So I do try to encourage patients to, meet with the local doctors also. Farzana, can I have the debrider? So that there can be a good watchful planning. And only when necessary, we go in and give another GA and do the surgery. Also, some people ask that, when should we then go ahead and do Avastin or Cidofovir? So that is something, I think the decision should be taken only if a patient needs surgery more than 3 times, in a year. Or if the disease is tracheobronchial, big patty, going from the trachea to the carina, to the main bronchus, you don't want that situation to take place. Debrider, please. So after the let me just give a little better position. Are you all okay with your picture? Is okay?
Picture is okay, ma'am. Yeah.
Yeah. Is it still okay?
Little glare is there, but okay.
Can I have the infiltration now? And I want a very big patty because I want to give a laryngeal wash.
Nupur ma'am, this is Dr. Archana from...
So now that we have more of a carpet growth, I'm going to get a better exposure of the vocal folds and the ventricle and perform a little bit of infiltration, subepithelial infiltration, to bulk up the SLP and then use the laser possibly. I'm on the left, I'm on the right, anterior commissure right now. And we don't want to be operating on both the sides of the anterior commissure. So if we have decided that we are doing the right side, then we don't do the left side.
Ma'am, will you please give a few tips about the microdebrider speed, the skimmer, how you are moderating the speed?
Give me a very big subglottic patty. So like I mentioned before, the microdebrider blades are tri-cut and skimmer. Tri-cut is like your cutting burr and skimmer is like your diamond. So typically I use the tri-cut speed at around 1500 to 2000 rotations. And the skimmer I use at around 800 to 1000. Typically the tri-cut is used, give me another patty exactly like this, sister, with a thread. Typically the tri-cut is used for debulking. As you saw, we were doing all along. Till now we haven't used the skimmer. And then the skimmer is used for like carpet-like growths to skim the surface of the true vocal folds, etc. And that's something which you can also do effectively with the laser suction. And then you also have blades of different lengths. Am I talking to Dr. Sampurna?
Yes, ma'am.
Yeah, so you also have blades of different lengths. So you typically are using 22 to 23 centimeter blades here, but if the disease is in the trachea, then you can use 24. If it's near the carina, you can use 27. So you get tracheal blades, tracheal microdebriders.
Okay, ma'am.
We have a patient who's a doctor from out of Mumbai who has severe tracheal disease. So we've been injecting cidofovir regularly in him, and we do it after we've debulked with a tracheal blade. Right now, I'm doing a little bit more debulking in the right ventricle near the anterior commissure.
Ma'am, any role of monoclonal antibody or interferon when it has gone up
Yes,
to trachea?
So as I just mentioned, your Avastin is your monoclonal antibody. And the infusion, as I mentioned to you, is very, very useful nowadays. Studies have shown, coming especially out of Boston, about its role in disease papilloma spread into the trachea and the bronchus. Intralesional, the role is iffy, okay, not so great, but infusion injection under the care of an oncologist has shown good control. I'm going to position my scope a little further in now and go to, you can give the outside picture for a minute. Can I have the light clip? I'm just as we remove disease from the supraglottis and go towards the glottis, we can go further in with our scope, and that's what I'm doing now. And then I'll probably chashma dena and just do a little bit of infiltration and maybe also show the use of the laser or the skimmer microdebrider. Light clip, please. Light on chahiye. Let him just put the light on. Table up, light on. Thank you. Okay, no problem. Darshan, I want a very big, please ask for some really big subglottic patties. I'm going to probably use the laser now, so your nitrous is still off, right? One more big patty like this. Zyada fold mat karo, Darshan. With a thread abhi dena. Give.
Madam, role of intralesional bevacizumab.
Bevacizumab?
Yes.
Yes. Yes, as I mentioned, one can inject intralesionally Avastin. I've not had terrific results with it personally, as I mentioned, but it can be done in 0.75 ml. You can inject 5 to 10, even 20 milligrams and do the injection sequentially 4 to 6 times. And so these intralesional injections, be it bevacizumab, which is Avastin, or be it cidofovir, should be done for patients who have disease which needs surgery 2 to 3 times a year, or is disease which is very aggressive. Now we'll go to 400. Suction to me, please. No, just normal suction first. Do they have a pic? Is your picture? I take the patty out now. Probably not in focus, I think. You all are not in focus?
Yes, ma'am.
Well, actually, I'm not in focus. So now I'm in focus. So I'll get your, are you all in focus still?
Madam, in such cases, do you prefer staged procedure or single sitting procedure?
Is focus. Laser on. Laser suction, please. Now that I'm going, sir, just 1 second. I'm just saying that now that I'm going to use the laser, I'm putting a laser suction and attaching it to the side of the laryngoscope. And I just want to show you, we are putting the laser. This is the CO2 laser. Can you show this picture also in PIP? CO2 laser, which we are using. And the time off, you can make it less. And shape size 1 is fine, put it on. So you see that there's a laser suction over here. Ye de dena foot switch.
Madam, do you have any?
Can you see the settings here? Yeah. So these are the settings of the laser in the scanning mode, which we are going to use, and we are using all laser safety protocols. So I'm going to do an infiltration now and then a little bit of laser debulking. And yes, sir, what was your question? Infiltration.
Madam,
Yes, what was the question, sir?
in such cases, do you prefer single sitting or staged procedure?
Yeah, so when it is going to the anterior commissure, I will operate on any one side of the anterior commissure.
Yes.
Right now, I'm performing a subepithelial infiltration of the right side ventricle and anterior commissures, you can see. Correct? You can see that infiltration. So definitely stage the anterior commissure always. You can imagine otherwise with 40 surgeries, what kind of a web the patient will otherwise develop. But if you don't address the anterior commissure at all, then you will never get a clearance there. So at one stage, go all the way up to the anterior commissure on one side and then on the other side. I hope that makes sense. The laser is on now. Can you see the
Yes, ma'am.
AccuBlade?
12 o'clock push.
Can get the depth to 3. Now this is one surgery where you are actually totally justified in using the laser, using the suction directly on your vocal folds. And the other surgery you do that is Rinke's edema. Okay? Why I'm saying that is when you're operating for cysts or you're operating for polyps, you don't want to use a suction directly on the SLP because you're saving the SLP. But here you have massive epithelial disease. So you, like I'm showing now, we do the laserization for the debulking and directly we can suck the charred area. I'm focusing on the right side right now. I've already mentioned to you what are the laser specifications. It is at 10 watts. The depth is 3. 3 corresponds to 750 microns because 1 corresponds to 250 microns. And my speed is little fast because I'm not doing phonomicrosurgery work on the true vocal fold currently.
Ma'am, there is one small query.
Just hold this in your hand, Farzana. I'm just positioning the ML scope a little differently right now because my laser beam should not reflect. Can you all still get a picture? I hope. Yeah. So currently I'm in the ventricle on the right side. Any questions about this laser settings or advantage, disadvantage?
Yeah, madam, can this laser
Yes,
smoke? Can this laser smoke spread the papilloma virus? There is one school of thought.
Sorry, can it what the papilloma?
Yeah, this
Can it what?
HPV, can this laser smoke spread the HPV virus? One school of thought is there.
Sorry, can the laser smoke spread
This
the
smoke coming from the
virus?
laser.
Oh, the laser smoke, can it spread the virus?
Yes.
Okay, so to whether you're asking for the patient, the OT personnel, whose so there are first of all, when we operate on papilloma cases, we should all be masked because the laser plumes can have the virus within them, right? That is what theoretically we know. Therefore, when I did my training abroad, there actually are special masks through which the HPV virus cannot sort of infiltrate. Now, having said that, it's very interesting that in literature, there are only 2 case reports of a doctor getting papilloma who was treating patients, and both of them were gynecological doctors who were taking care of patients who had cervical warts or condylomata acuminata. No ENT surgeon. So obviously the chance is very, very low.
Very low.
But we must always have a very good, nice suction available for the plume. That is very important. So that's a very, very good question that you ask.
Yes.
Can I have a big cotton ball, please?
Madam, to add to what has been said, like,
Cotton ball.
papilloma circulating in the OR is very much a possibility. That's why they say that theaters have to be fully equipped for this type of procedures. Central vacuum should be there to take these cases. That's why office practice of treating laryngeal papillomas is a big question now.
Yes.
Right? Because in
Well,
adult,
though I appreciate what you're saying, but office papilloma surgery now seems to be the direction where the West is moving for the almost last 20 years. Almost 20 years they're using hemoangiolytic lasers, be it the KTP laser or the pulse dye laser or now the true blue laser, where for all adult patients, they're really favoring using the fiber laser under local anesthesia without giving GA or admission to the patient. So your point, of course, is very correct that, you can't tackle the laser plumes then. So it would be interesting to note that does it actually show a documented problem in any of the treating physicians? Can I have a vocal fold spreader, please?
Ma'am, there is one small query.
I'm putting a vocal fold spreader in just so that we can distract at the anterior commissure. Yes, please go ahead. And cotton balls, Dina. Is your picture okay? Just tell me that, please.
Yes, madam. Please.
Okay. Yes, please
Explain.
go ahead with your question. Cotton ball. Yeah, please go ahead. Dr. Sampurna, you had a question.
Ma'am, this is Dr. Archana. There is one
Dr.
question.
Archana, please go ahead.
Ma'am, this CO2 laser you use, and is there any implication on the endotracheal tube selection for the anesthetist?
You are asking me about the laser safe tube?
No, ma'am. The endotracheal tube selection for anesthetist.
The size? You're asking about the size for ML-scopy?
No, ma'am. I'm asking, is there any implication of selection of type of endotracheal tube for the anesthetist because we are using the laser? This question.
Yeah, so we are using a laser safe tube, no?
Yeah.
Aluminum foil.
And this is a 5.5. Typically in adult males it is 5.5 and females 5. I don't know whether you were there in the beginning of the case, but I discussed the importance of using a laser safe tube and the importance of all laser safety protocols to be maintained in the theater while doing a laser surgery. What I mean by that is no inflammable gases, no nitrous oxide to be used. Oxygen should be less than 25%. We should cover the eye of the patient with moist gauze pieces or spectacles, which come along. Can I have another big cotton ball, please? Which come along with the laser system. And we should cover the face of the patient. And we should make sure that there is no reflection of the beam during surgery. And everyone inside the theater should wear protective eye cover.
Thank you so much, ma'am.
I hope that answers your... Okay, sure.
Yes, ma'am. Thank you. Because on virtual platform, thousands of students and other doctors also.
Absolutely right. Absolutely right. So right now you see I've put a vocal fold spreader so that I'm able to, when the papillomas are front, sometimes you can't make out which one is from the right side, which one is from the left side. Big cotton ball. Give me a laryngeal wash also. Now, of course, we don't want to spread the papilloma virus into the subglottis. So therefore, we have to be careful when we give the wash that you definitely have, these two cuffs of the endotracheal tube on top of which I have a subglottic patty. But I do sometimes give a little bit of wash during surgery because it helps obviously in getting a better plane of vision for me. And I do a suction immediately. Can I have another big cotton ball, please? So my plan, as I've mentioned before, is to attack the entire right side all the way up to the anterior commissure. So as you can see, I'm using the cotton balls very often to retract tissue. But don't ever keep the cotton ball in situ because, you will lose it. So you can't ever do that. You can keep patties with a thread in situ sometimes because you have the thread. But you have to be very careful about your count. You don't want to lose some small cotton balls and fledgets inside.
You are very senior surgeon doing very frequently laryngeal papillomas. On a single patient, how many times you have done, madam? In those cases, how you are counseling the patient?
About what, sir? Counseled about what?
Recurrent papillomas. How many times you have done on a single patient? How
The
you are counseling?
maximum.
Recurrent laryngeal papillomas.
You're asking me what is the maximum number of times I've done in the same patient?
Yes, madam.
Okay, I think my maximum would probably be about 13, 14. And counseling
my
is
God.
not really a problem because the first thing I counsel a patient on diagnosis,
Madam.
the first thing I tell them is it's called recurrent respiratory papilloma for a reason.
Yes.
In fact, I just want to share with you that when I have a patient of keratosis, histopathologically proved keratosis,
Yes.
I counsel them exactly how I counsel a patient of papilloma.
Yes, ma'am.
Just give me a debrider. I'm going to debulk a little bit on the standby pe laser karna. I'm going to debulk a little bit on the left side. And then do the finer work of the medial vibrating edge on the right side. Tell me, are you all okay with your picture? The anterior commissure, are you really seeing it very well?
It's visible, well visible, ma'am.
Is it any better now?
Yes, ma'am. Just keep little centralize the
focus,
picture. Madam.
Exposure is nice. Little focus will be helpful.
Focus, sure. Can I have the microdebrider blade? Just hold this. Can I have the foot switch of microdebrider here? Just let me know if it
Please
gets
centralize
better.
the picture, madam, and fine focus it.
Just tell me, is that better? Better now?
Yes,
better,
madam. Yeah, excellent.
Okay, good. Can I have the microdebrider? What I'm just trying to do right now is I'm just debulking a little bit on the left side so that I can get the medial vibrating edge better on the right. What are the rotations we are on, guys? 1000 is fine. I'm not making it raw, mind you, huh? Now see, papillomas itself are epithelial disease. As long as you don't totally debulk them, it will serve as what you can call like a stent or a keel or what itself, you know? So you just don't want to make it raw.
Ma'am, as we know that there are two age groups affected, like juvenile and another is after 40 also recurrent papilloma comes. So do you find any difference in their presentation or rate of recurrence or any sort of
Absolutely.
uniqueness?
I'll tell you something interesting. Give me a big cotton ball. There are 3 modes now described. Frederick Dickers has shown a third modality of presentation at the age of 72. And when we went back retrospectively to see our records, it was actually correct. We were getting patients at the age of around 70 also. So there are 3, can I have the suction please? 3 modalities. But to answer your question, yes, like it has been documented always in literature that the juvenile onsets are much more aggressive than the adult onset papillomas. That is very much what we also see, cotton ball. And whatever we may do, you know, whether it's cidofovir, Avastin, anyway, the adult onset seem to behave much better. So that is one difference, definitely, which we see among the 2 groups. Can you give a little more anesthesia? Pradnya, please.
Madam, how often do you get to do tracheostomy in juvenile laryngeal papilloma? Maybe presenting in late stages.
I don't want to spoil my record by saying I have never done laser on karna, laser on, but honestly, sir, till now it is never, but I'd really keep my fingers totally crossed. But I must say one thing that, another big cotton ball, that, you know, being a referral center, it may be that we don't get the brunt of the patient in Strider. Someone else is taking care of that and then referring to us. You know, so that may be a reason why we've been fortunate. But is it on? Yes. But we've not done till now.
We at Hyderabad, we work for government ENT hospital. All our presentations are very late stage in Stride.
Yeah, there's a suction. I can imagine.
Yeah, most of our
I can
colleagues
imagine
are
that.
here.
But if you have a laryngeal microdebrider available in your center, just one, which can be ETO'd, subglottic patty hai na? Then, you know, I would really encourage you to try, if possible. I know it's easier to say than to do it when you have a child who's come in full Strider. Try to debulk and see whether you can just get a tube in. Because these papillomas are typically soft and very forgiving to the introduction of a tube.
Sure.
And the only time the papillomas are not forgiving and they become hard and infiltrative is when you have to worry about malignant transformation also. Cotton ball.
Madam, what will you suggest the gynecologist to prevent the papillomas in newborns? Prevention is better than cure. Na? What will you
So
suggest?
though they said that, though it is said that cesarean section is the way to go, okay, for mothers who have condylomata acuminata so that their children do not develop papillomas, the studies have shown that only 5% of patients, only 5% of mothers whose children had GORRP actually had condylomata. So there's so much which is not understood about papilloma. Why is it there was only a 5% patient group if that is supposed to be the etiology of vertical transmission of GORP? So really, frankly, sir, I think in today's age, the answer is vaccination.
Vaccination, yes.
Immunization. That is the way forward. And we are very delighted to hear that this Pune group, which helped with the COVID vaccine, the Poonawala team has now come out. I mean, many of you all may have read about it, that they have pioneered HPV vaccination, which is going to cost as low as 20 rupees, I think. So that would be so terrific because that will change the whole game plan of things. You know, like if all us Indians, boys, girls, adults can get vaccinated, then herd immunity, and in 10 years, we will really see a difference. Not only for women for cervical cancer, but for this papilloma group of patients. So I think that would really help.
Madam, what is the
role of achieving clearance on the right vocal fold?
We appreciate the way you are handling the CO2 laser with great precision, and it's look like very artistic. Yeah.
Thank you.
Big applause for you for your excellent handling of the CO2 laser here.
Thank you
Very
so
precise
much,
and very accurate.
I'm
It
good.
requires a
Thank
lot
you
of
so much.
skill. Yeah.
I am right now decreasing the extension a little bit. If you see what I'm doing, I'm decreasing the extension because if you can see now, I want to go to the ventricle posteriorly. So I will also use a microflap elevator pointing to the right side so that I can see into the ventricle better. Cotton ball. Thank you, sir. And I'm indeed fortunate that Bombay Hospital has been kind enough to get all the equipment that we need. Not only do we have this laser, which is with us now for 12 years, but we have just purchased a new laser, which will be with us in 2 weeks' time. So I think technology is, we are becoming very technology centric, which has its advantages and disadvantages. I'm just going to move it so that I don't get a beam reflection. Dikh raha hai picture kuch?
What is your idea about diode laser here? Diode.
Kanya, can you just take answer? There is motion happening. Just 1 second, sir. I'm just trying to get a picture because I'm operating on the
please. Yeah.
right side. I want you all to see the ventricle on. Can you see now? Should I zoom it a bit? Better now? I can zoom more actually.
Yeah, it's good.
Is that
It's
better?
good now. Yeah.
Okay.
Now we are seeing a perfect image here. Good.
So what were you asking, sir, about diode? Na?
A diode. Your idea about diode
Diode
laser.
can be used. Diode can be used for Kashima cordotomy. You know, for airway work. I think diode on the vocal fold, it's a bit too much thermal damage for the vocal fold. But for airway, it is totally acceptable. Now, I just want to tell you, see this cotton ball, it's such a useful way of operating, you know, because not only it cleans the tissue up, but you can provide, you can perform medialization, lateralization, push into the ventricle without causing damage, trauma, and at the same time, the bleeding will get sort of, you know, collected in the cotton ball. So I really like to use cotton balls soaked in this saline adrenaline. I find it very useful, but we published a paper called carbon granuloma formation following transoral laser microlaryngeal cordectomy. And one of the things we proposed in that is maybe the cotton fibrils, which we inadvertently leave behind, may cause a little bad healing. Therefore, I started doing the laryngeal wash after the completion of every surgery. Pranaya, please take under again. So I hope that makes...
Madam, what is the reason such an extensive papilloma on this card, but the true vocal cord and margin of the pre-margin of the vocal cord is very free from the papillomatous?
Yes, so see,
what is the
beautifully you
cause?
see the medial vibrating edge.
Yes.
Now the cause, sir, is we know now the virus is there everywhere. And the body decides where the growth is going to take place. It is not that there is no virus in the medial edge. So I wish I knew the cause, but nobody in the world knows the cause. Why it develops in some areas and not in others. And it has been proved that non-papillomatous growth areas also are positive with the virus. Can you give me little pressure from the right side, Farzana? Dr. Farzana is giving gentle pressure, bus, from the right side. This is another trick you all can use to see into the ventricle. See, we can now see this disease here, which was hiding, correct? Which I am using a microflap elevator to retract the false vocal fold. And Dr. Farzana is giving pressure from the right side of the neck to push the vocal fold so that we can get the ventricle clear of disease also. Because this is the hidden area. A little bit more, Farzana. One sec, I'll move the laser suction to this side now.
Madam, do you believe in
that's good.
injecting the subclinical areas also, madam? Those that are not evident.
There are two pe karna. Injecting with what? What was the question? With what?
Yeah, injecting the Cidofovir in the subclinical.
So subepithelial infiltration of Cidofovir is extremely useful in patients who have disease which is recurring almost 3 times a year. And I have personally done injections of Cidofovir in about 11 to 12 such patients.
Hello.
And I have adult onset patients who have completely resolved of disease for more than 10 years. The juvenile onset, unfortunately, has not done well. That's fine, Farzana, leave it. And one of my juvenile onset patients, after 2 injections of Cidofovir, developed multi-drug resistant tuberculosis with a cold abscess in his neck. Now, I don't know if there's any correlation between one and the other, but it did happen. Crocodile to the right with a big cotton ball. So he it got me a little anxious as to why did that happen? Did it cause an immunocompromised situation for him? What was the problem? Patient is a little bit light, please, Pranaya. So we've almost finished the clearance of the right side. On the left side, I'm only going to tackle a little bit posteriorly, and then I'm going to give a laryngeal wash to the patient. And let me just see the...
Madam, how about the role of microflap technique in limited lesions?
So, yes, that's a very good question, because when it is an adult onset papilloma and there are fronds, 1 or 2 fronds only, give me a fresh subglottic patty. Then, you can do a very effective microflap excision, but by microflap, we are not trying to say that you retain that flap, obviously, right? Because it's an epithelial disease. So you elevate the flap to remove it, but using the microflap technique. And that can be done very efficiently for adult onset, typically, where you have small fronds. If you check my YouTube channel out, it's Nupur Nerurkar. I have many videos of these techniques.
Sure. Well, do you undertake a voice therapy in the kids, madam?
For papilloma patient, not really. For papilloma patient, not really.
No need at all.
I mean, no, because it's an epithelial disease, and I'm just debulking the false vocal fold anterior commissure. It is not the true vocal fold. Okay, I know I'm going to the left side, but it is the false vocal fold. So that's okay, because I've gone to the right true vocal fold anterior commissure. So about your question, sir, give me a cotton ball about the voice therapy. In fact, I just want to mention in papillomas which are near the anterior commissure, give it on a straight now. You don't ever want to make the mistake of telling them to take voice rest. No, never. You should never give them voice rest. Because if you don't want a web formation, iatrogenic, you want the vocal folds to keep moving. So tell them you want them to talk for 10 to 15 minutes per hour. Now, when I'm operating on the false vocal fold, can you see that I've put a cotton ball just below the false vocal fold so that I do not cause any raw area on the true vocal fold anterior commissure, because I know I have operated on the right anterior commissure completely. Yeah. So put a cotton ball or a patty where the beam will get prevented from hitting. Can you see over here, doctors, the disease on the left anterior commissure here, all of this? Yes?
Yes, ma'am, visible.
Correct. So that I'm not going to touch, okay?
To prevent synechia?
To prevent synechia. So what is the definition of anterior commissure? How many millimeters? It is 3 millimeters. Minimum 3 millimeters you cannot touch, but it's better to be safer and keep it to 4 or 5 millimeters. Now, when we say millimeters and all, how do I know how many millimeters it is? It's fancy to say 3 and 5. Now, that is another advantage with this laser. See, I can exactly measure. Right now, my shape size on the laser is 1. This is 1 millimeter. Now, Ritesh, you can make it into 5, please. Now, see what happens. Make it 3 actually, Ritesh. 3 karo. Yeah. See this? Can you see my blade? Okay. That is 3 millimeters exact. So, that is my anterior commissure. So, I don't want to make that much area raw on the true vocal fold. Switch it back to 1.
Madam,
I'm just going to be doing.
Can you show in the external camera how you are applying the laser? Can you?
How I'm applying what?
With your hands, how you are applying laser?
Oh, okay, okay.
External
Sir, either joystick पे लगाएंगे, either.
Yeah, that we want this.
Yeah, yeah. Make it 1 millimeter length and make this into again 20. This is the joystick over here. This is the joystick. You can have another stick over here, which is a hand support, where you can support your hand and use a joystick. You can move the joystick up and down and you can rotate it. See what happens to the beam when I rotate it. It goes. Do you have PIP? Do you have PIP?
No.
PIP hai?
Not getting.
So basically, when we turn this joystick around, that beam is rotating by 360 degrees. So when I'm operating, I'm not looking down. My hand is just holding it and I'm seeing on the screen which way I want the beam to go. Correct? Straight, right, whatever it may be. किया आपने? थोड़ा उनको इधर का पिक्चर और PIP भी दिखाएंगे.
We are getting both, ma'am.
Okay, good. So you can see now I'll operate and you can see my hand motion. What I'm doing is now I'm operating beyond the anterior commissure at the level of the false vocal fold, and then I'll do a little bit in the ventricle. Cotton ball, please. Does that answer your question, sir?
Yes, yes.
Okay.
That
You just retract a little bit here.
Yeah.
अभी वो 1.5 कर देना. Cotton ball फिर से. Debulking a little bit on the left ventricle posteriorly. And then we probably may have maybe done. I know my timing is 3, though I did start half an hour late, but still I think I'll be done soon. Has Dr. Janki induced his patient? Because I know he has some superb cases to do. Please ask Dr. Janki to let me know whenever he is ready. I will wrap up. I know there are 2 nice cases you all want to see. So this I'm doing posterior debulking with the laser.
Madam Sampurna here, one last question.
Yes,
what is your experience or what is the future of the flexible laser?
So the flexible laser is here to stay. Here to stay means in the world, I mean, for 2 reasons. One is that no anesthesia needed for adult patients, office procedure for the patients. Now, whether they are small polyps, give me a microflap elevator pointing to the left, whether it's papilloma, whether it's leukoplakia, whether it's small varices, can be very effectively handled with a fiber laser. Second thing is, if we are going to move towards robotic surgery, then that is something which again needs a flexible laser, correct? So if we are moving towards not only doing supraglottic, but even finally with the thinner arms, glottic conditions, using a robot, then definitely flexible laser comes into play. So it's something I think we definitely have to think about. And I do know that the True Blue laser is now available in India. It's much cheaper than the KTP laser. I have no shares in any laser company. I'm just mentioning what is the facts. And it's something one should think about. I think probably a doctor in Ahmedabad has bought the True Blue laser, he was telling me, and I know I have used it too. So there are lots of advantages, Dr. Sampurna, and I think a combination of the free beam laser and fiber laser is amazing. So the new laser which we bought, which is a CO2 laser, has got both. It's a duo. So it's got a fiber laser as well as a free beam laser. But when I say it's got both, it has got both at 10,600 nanometer. That means it's not a hemoangiolytic laser, right? Because the wavelength remains a CO2 wavelength. So ideally one can have both CO2 as well as a hemoangiolytic fiber laser. I think that is a very ideal situation for any laryngologist or any tertiary referral center. Does that answer your question?
Yeah. Thank you, ma'am. Yeah.
I'm just going to give a laryngeal wash. And then maybe you can let me know if you need to switch. Sister, keep a laryngeal wash ready.
Yeah, just
So just to concisely say what I've done, posteriorly, I'm just debulking in the ventricle as well as a true vocal fold. But I have kept almost 5 to 6 millimeters anteriorly. I want to take no chance with glottic web formation. And the right true vocal fold, I have debulked completely all the way up to the anterior commissure. The minimum amount of time I am going to wait between next surgery and now, minimum, is going to be 6 weeks. I will, of course, evaluate the patient with scopy prior to placing him for another surgery. Any questions for me? Give me a wash. Just take the laser suction out. And give me a wash and give me a fresh subglottic patch.
Hello, madam.
Yes, sir.
What would be the chances of a web formation in a extensive lesion like this bilateral vocal cords extension to anterior commissure?
If I operate on the suction not working, if I operate on the left vocal fold, not working, it's not working. If I operate on the left vocal fold also at the anterior commissure, there is a very, very high probability of a web formation. Pradnya, under for 5-10 minutes I need at least. So therefore, as I mentioned, it's not only 3 millimeters, but almost 5 to 6 millimeters, which I have left untouched. Can you see that big frond of papilloma sitting there on the left side, anterior commissure? Can you see this?
Yes. We can see that.
I'll just over
Can you
here. See,
use
all the way till here.
Madam, can you use mitomycin solution to prevent
No,
the
it has no
fibers?
role, sir. No role whatsoever in papilloma.
No
and
role.
if you're talking about web formation,
Yes.
then don't even do, don't do a situation where you have debulked and de-epithelialized both the anterior commissure and then hope for mitomycin to act. Don't ever do that. You know, because you and I both know how challenging, Pradnya, please, how challenging is web formation to treat. So we don't want to reach that situation. So definitely, please don't try to achieve picture perfect ever in papillomas. We have to keep the physiology of the larynx in mind and not let a web form. So therefore, keep that staged surgery like a doctor had asked about earlier. Definitely keep all this carpet of papilloma intact. It is your friend. It is a patient's friend. This patient has gone through 40 surgeries and there is no web. And we don't want to now create a problem of web formation. Correct?
Excuse me, ma'am.
So basically, I just want to tell you that what I'm going to do is there's few dots I see in the ventricle here and a few papillomas in the ventricle here posteriorly. Just this. These two I'm going to remove. But I'm very happy to let Dr. Janki start his case whenever he needs to. Please.
Good afternoon, ma'am. Hello?
Yes, sir.
Good afternoon, ma'am. Excellent demonstration. So, what is your post-operative care for all these patients, ma'am?
Okay, so this patient will receive no voice rest at all. He will be given some kind of a PPI for a month because I just don't want acidic environment for healing. And on table right now, we give one antibiotic shot. After that, we give no antibiotic at all. We give some paracetamol for 3 days, TDS. And we give Chimoral Forte or, like trypsin, chymotrypsin for TDS for 7 to 10 days. We ask the patient to drink at least 2 liters of water. That is not this patient, any patient, of course, just for good laryngeal hydration, because the larynx, like everything else, there is a systemic hydration and a surface hydration. And a lot of studies have shown that increased hydration, of course, will help in the mucosal wave, thinner mucus, less chances of mucus retention, cysts, etc.
Any role of any nebulizations, ma'am?
I personally do not give nebulization to any patient unless I'm operating, let's say, subglottic stenosis or something like that. Then sometimes I do give antibiotic and steroid nebs. That is a different situation. But I don't give in these particular later on these kind of patients. No, I don't. Also, steroids, I only give one shot of intraop steroid, usually if the patient is not diabetic. If the patient is very diabetic, I may even miss that unless it is really needed. But I don't typically
some
give...
of the delegate from the Vishakhapatnam
Yes.
asked me by phone the role of podophyllin application.
Sorry, role of what?
Podophyllin.
Sorry, what?
Podophyllin application. PODO.
I have no idea what vodophyllin actually is.
You don't know.
What is vodophyllin?
That is useful for the skin warts. Papillom of HPV.
What is vodophyllin?
Podophyllin.
It's a cytotoxic agent like a monoclonal antibody?
No, antiviral, I think.
Ma'am, we have another question.
I have no knowledge to answer you.
Chemical
Sir, I don't know.
Yeah.
I don't even know what is vodophyllin. What is vodophyllin? Google and tell me.
Ma'am, there is another question from the audience.
Yes.
So, what is the role of
Yeah.
Can you give me pressure from
that
the
is
left side,
Tuja?
Role of what, sir? Tuja.
Yes, ma'am.
Tuja was used by a lot of our senior teachers. I think while it's being used, some patients did report a lot of decrease. And when the Tuja use was stopped, then very often the recurrence was like a rebound effect where it was even worse than before. I think that if anything, if this Tuja had to work and give dramatic results, there would be no reason why we would have stopped it today. So very frankly, I've never used Tuja, but I know some of my teachers have mentioned to me that they used to use Tuja, etc. So, I even tell my patients, go ahead, eat a lot of cauliflower, broccoli, cabbage, who knows?
Okay.
It can't harm you.
Does this patient has been vaccinated, ma'am, after getting papillomatosis?
No, sir. In fact, that's a great question, Crocodile to the left. We have we do a lot of our papilloma work for free because a lot of these patients are socioeconomically not so well off and they need to come back again and again and again. So we advise vaccination to all of them. And he has, in fact, been telling me that he cannot for the costing. So I'm going to help him out with a trust and make sure he gets vaccinated because he has nothing against the vaccination. He's just not been able to do it. In fact, that's what we were discussing today, that we will help him with that. 3 injections, 0, 1 and 6 months. Gardasil injection, not Cervarix.
Do you have any experience that whenever we give any vaccination post papilloma surgeries, is there any chance of less recurrence for these patients?
It's, too early to tell, honestly, because it takes a while. The idea is that One is herd immunity, and the second idea is that no new points should develop of papillomas. But really, one can only answer these questions after 5-6 years of having given the vaccination. So, for me personally, it's too early to make a comment, but I have seen the results, especially the one out of Australia, and they have shown terrific results. So, that's not my experience. I don't have enough clinical experience because of not enough long-term follow-up as yet. But yes, internationally, it's been showing really good results.
Okay, ma'am. Okay. Madam, what are your recommendations on ultrasound of neck in the serial follow-up of laryngeal papilloma?
I mean, I would say if doing a flexible laryngoscopy is a huge challenge in some center, then that is something. Ultrasound of the neck has been described, yes. It's just I feel that almost everybody has a flexible scope. Now, when you have small children, tiny children, 1-month-old child, as long as you have a flexible laryngoscope which is thin enough, you don't have to give any anesthesia. Just mummify the child in a blanket, in a bed sheet, zero anesthesia, keep the SpO2 monitoring, and just do the flexible. It's just barely takes 2 minutes, and it gives you the best answer regarding glottic chink, regarding the mobility. So, I mean, if there's some specific reason where one has to do it, okay, but I mean, I just feel in today's world, every center should have a flexible scope.
Thank you, ma'am.
Ma'am,
Once again,
there is a
explain
question.
about the position of the.
Sorry, I cannot hear you, sir.
Ma'am, once again, please explain the position of the patient.
Okay, so this particular patient of mine is in neutral position. Zara outside camera denge either. So this patient has got no head ring underneath the head and no shoulder or pillow or anything. It's just a neutral position. So when I say neutral position, there still is extension of the at the atlanto-occipital joint. Correct? That's all in this particular patient. But the typical position described for ML scopy is Boyce's position. In a sitting position, Boyce's position is a sniffing position. So what we do for rigid laryngoscopy, like this sniffing position. But on the table, a Boyce's position would be flexion of the neck on the chest and extension at the atlanto-occipital joint. So you will need to have a kind of a ring here to provide the flexion of the neck on the chest. That is a Boyce's position. And sometimes intubation itself by the anesthetist is so challenging that they can use what is known as a flexion position. So to get both at the neck on the chest, flexion, and atlanto-occipital joint, flexion. So literally you hold the head of the patient up like this with your stomach and you intubate. Now that is obviously not the way then you can operate. That's just to get the tube in. Idhar wire kuch atak raha hai. So these are the various positions one can use for MLS. But after having used the position to get laryngeal exposure, which I already described, is you keep this Gamgee here, bandage here, give a pressure at the cricothyroid membrane, which is external counter pressure, internal distension with the use of the laryngoscope, general anesthesia, so the patient is completely relaxed and the muscles relax, and with the constant traction of the pressure, there is a laryngeal drop that takes place. I hope that answers your question.
Yes, ma'am.
Ma'am, there is one question about voice changes post-operative for these patients, how common it is and what is the management?
Voice
change post-operatively.
A voice change in we expect an improvement in the voice in this papilloma patient, or are you asking a general question?
Question is general, but I feel they are expecting related to the papilloma.
Okay, so in this papilloma patient, of course, we are expecting an improvement because we've debulked it. One vocal fold is going to vibrate very well. We only have some papillomatous lesions on the left medial vibrating edge. And when we do the stage surgery, the voice will further improve. But in general, if the question is generally, then any patient of mine who's coming for surgery, I would tell them that yes, there is a 2% chance. So can you take the patient under, Pranav? A 2% chance of voice deterioration, which has been described. Can I give a telescopic look to them once? 2% chance of voice deterioration described in literature It's not happened in my hand typically that the voice deteriorates, but it can happen. So we take that kind of consent. So what do you do so that patient ko andar le lo? I have not finished. I want to show them telescope. So you do the basic principles of phonomicrosurgery. Don't damage the anterior commissure. Don't go too deep into the superficial lamina propria. Even when you're doing papilloma surgery, one of the reasons malignant transformation can take place is when you, with the laser or with the debrider, not only remove the epithelium, but you remove, let's say, the ligament. You go deep. Then the papillomas go deep into the muscle, and that is one of the factors causing malignant transformation. So what we have to remove in papilloma, light on karna please, is we have to remove the epithelium which is diseased completely. Completely, why do I say? Because the virus actually lives in the basement membrane. The basement membrane is the deepest part of the epithelium. So you want to remove the epithelium completely, but you do not want to remove the SLP.
Ma'am.
Superficial lamina propria. Can you all see the telescopic photo, please?
Oh.
Can I, ye picture de rahe hai?
Yes.
Take a photo, please. Oh, I can see Dr. Janki is waiting already with his CT and MRI. Photo liya?
Ma'am,
Guys, we are going to wrap up now. Dr. Janki is ready. If there's any last question, I'm very happy to take it.
Madam, what is this scope, madam? It's very long and wide.
Well, I'll tell you, this scope is a present from Dr. Peek Wu, one of the best laryngologists in the world. He came to Bombay Hospital 17 years ago to do surgery demonstration, and he saw I don't have this kind of a Hopkins 10 millimeter, 0 degree laryngoscope to take photos. When I was dropping him to the airport, he took it out of his bag and he said, Nupur, keep it and take photos. After that, of course, we purchased more, but this one is 17 years old and it's still working.
Ma'am, in any of the case, do you use shoulder bag? Shoulder bag?
Yes. Sometimes in small children, I do. Sometimes for tracheal work, I do. These are the only two situations.
In its place, can we use laparoscope, madam?
In the place of this?
Yes, madam.
You can use your 0 degree nasal endoscope. Here, see this. This is you all have a 0 degree nasal
4 mm,
endoscope.
it's not accessible.
No problem. You will get a photo out of it. Maybe not as big as this, but you will get a photo. So you all have this. You can use a 0 degree nasal endoscope. Please take pre and post-op photos. Give it to the patient for documentation, whether it's leukoplakia, malignancy, papilloma, so they know you removed it. If it's come back, it's a recurrence of the disease.
Ma'am, why in small children you use shoulder bag? Why in small
Why
children?
don't I? Sometimes when I'm doing posterior glottic work, I want a different angulation, and the neck of the children, the flexibility is different than adults. So sometimes I want a little bit of more posterior view in children. So that is the only situation where I may use it, but typically no.
Ma'am, one last question, please. Bevacizumab, on demand, multiple questions on that.
Sorry, say that loudly, please.
Systemic bevacizumab, therapy in GORRP and duration of treatment, and in general, role of bevacizumab in papilloma and your protocol on that. This is the last question, ma'am.
Okay, I've already actually spoken about this. Give me the spray. Bevacizumab as an infusion has shown very good roles. This is a spray I'm doing of 4% lignocaine to prevent laryngospasm. We are going to release the bandage also. The infusion seems to work very well on patients who have tracheal and bronchial disease, which is very extensive, where the dose which is given is 5 to 10 milligram per kg body weight as an infusion under the supervision of an oncologist, 6 cycles at 21 days. So that means after every 20 days. But intralesional injections have not shown such great results. This should be done or considered only in patients who have very aggressive disease, which is in the trachea, bronchus, and the lungs. You can monitor the condition, how it is, whether improving or not improving, by doing serial CT scans or MRs.
Thank you, madam. Such a wonderful demonstration. First of its kind. Excellent.
Thank you.
Rather excellent. And we have to thank you, and special thanks to Dr. Janakram Garu to arrange two lunches at the same time. One is real lunch, the other is academic lunch today at the lunchtime, madam. Excellent demonstration. Nearly 4,000 to 5,000 people are observing your surgery, madam.
Thank you so much. It's been a pleasure. Thank you, Janki, and thank you, Sun Pharma and Dr. Kirtane. Thank you. Bye-bye.
Thank you, madam.
Excellent demonstration by you, madam.
Thank you, ma'am. Thank you, Bombay Hospital team.
Purva, you can start.
Thank you, ma'am. Next, we have Dr. Janakiram, sir, operating JNA and a skull-based mass. I would like to invite Dr. Abhishek Srivastava, consultant ENT surgeon at Swastik ENT Center, current secretary of AOI Ranchi. Dr. Mohan Reddy, sir, founder and chief ENT surgeon of Nova ENT Hospital, Hyderabad, past AOI president. Dr. B. Nageshwar Rao, sir, additional professor of ENT Government Medical College, Nellore. Dr. Sham, sir, HOD of Mahavir Hospital and Research Center, Hyderabad. Dr. Bhupender Rathod, sir, professor of ENT Gandhi Medical College, Hyderabad. Dr. Ranveer Singh, sir, as from SMS Hospital, Hyderabad. Dr. Subramanyam, sir, senior consultant at KIMS, Secunderabad. Dr. Venkataramana Reddy, sir, senior professor, worked in Government ENT Hospital in Gandhi Medical College. And Dr. Monica Reddy, ma'am, assistant professor in Gandhi Medical College, to be the panelist and chair the session. Yes. Yes.
And we have Professor Anthony also. Okay. Pack the nose. Pack the nose.
Shall I start with the case?
Yeah.
Patient is a 12-year-old male, a resident of Karimnagar, present to our OPD with the complaints of unprovoked profuse bleeding from left nasal cavity, relieved spontaneously in the past 6 months with 4 to 5 episodes spaced by 20 days. Patient also gives complaints of left nasal obstruction since 6 months. No other complaints or any known comorbidities. On examination on diagnostic nasal endoscopy, there was a mild deviated nasal septum on the right. In the left nasal cavity, as we can see, there was a pinkish smooth mass obliterating the nasopharynx with a corneal banking effect. Rest of the ear and throat examination were within normal limit. I would give it over to Janakiram, sir, to discuss the radiological findings.
Hello.
Sir, over to you.
Yeah, before I start, first of all, I thank Sun Pharma. I thank all my brothers and sisters, and especially all the delegates who have come all this far, and also people who are watching all over India through and also it's being transmitted through the net. I really thank. 3 very interesting cases which we are going to demonstrate during this workshop. The first of the case is the JNA, because now it's juvenile angiofibroma. Let us go on to the CT scan straight away. Can you focus the CT? So what is the CT? I really believe on just the CECT, that is contrast enhanced computerized tomogram. I generally don't even see the axial cut. I generally plan my surgery with the coronal cut. Image also. Have you got it or not? Okay, fine. So we have the CD, and we can actually plan the surgery better if we have the CD. Now let us scans. Can you make vertical? So I don't want the slant. Okay. This is the thing. It's
Sir, can we ask you and questions and disturb you, sir?
You please disturb.
Yes, sir.
Want you to disturb me.
Be asking questions frequently.
Yeah. Keep asking questions. Let us make it very nice session. Okay. Let it be a two-way communication. Okay. The first thing I'll see in a angiofibroma is, so how is the septum? Septum is in the middle. The second I have to see, so the septum, the other side of the nasal cavity. Always I look at it because I have to see if, basically I'm a four-handed surgeon. So I always do binostril approach any skull base. This is very, very important. I never do uninostril. uninostril surgery for skull base. I do binostril. How do I get a binostril approach is what I will always think about. Then, so I see the septum. I see where this JNA arises. I mean, till what level anteriorly it comes. So here it is not occupying the vestibule. That's a very good sign. If it's in the vestibule, then we have other techniques. We will discuss about that later. Now, this can be just secretions because there is no contrast enhancement. So here you can see contrast enhancement at the level of the middle turbinate. So I think just posterior to the anterior end of the middle turbinate, the mass is originating. And here is the posterior ethmoids. And the anterior ethmoids are free of disease, you can see. Then this is the maxillary sinus, which is free of disease as expected. And you can see that this is actually the JNA, which is widening the sphenopalatine foramen and going into the pterygopalatine fossa and infratemporal fossa. How do I say it's going to the infratemporal fossa? If you draw a line from the infraorbital nerve, anything lateral to it is the infratemporal fossa, and anything medial to it is the pterygopalatine fossa. So here it's definitely going into the infratemporal fossa. So according to our classification, Janikram's classification, 2C. 2C. Now it is then after that it's going into the sphenoid sinus. It usually erodes the floor of the sphenoid sinus, occupying the nasopharynx on the left side. So this is a complete extension of the JNA. So again, extension from just posterior to the anterior attachment of the middle turbinate, then nasal cavity, then pterygopalatine fossa, then infratemporal fossa. See the inferior orbital fissure is just abutting the inferior orbital fissure. Professor Renuka Bradu madam has got a beautiful classification on the inferior orbital fissure. Nobody in the world has produced that. I love it actually. Touching the inferior orbital fissure, going inside the inferior orbital fissure. So that way I respect the madam in a big way. She's really analyzed her, JNA series. Now, you can see that it's eroding the floor of the sphenoid sinus, going inside the floor. And then it's just in the nasopharynx. That's it. But the more important thing I want to know is where is the blood supply? For that, I have to look at the internal maxillary artery. See here, this is the third part. You can see it's going between the lateral pterygoid muscle. That's the lateral pterygoid muscle. It's end on. It is seen end on. Here also it's seen. Then it is coming here, and then here it is supplying. You can see it's supplying almost anteriorly. It's supplying, and anterolateral it's supplying here. So this is where I'm going to ligate the internal maxillary artery. We generally don't embolize the JNA because we will ligate the vessel and go for it. So now, how am I going to plan this case? I always say the fourth dimension of a surgeon should be planning. And especially in skull-based surgery, we need extraordinary planning, or else you cannot do a surgery with ease. And that too, it's a very young boy. I don't want blood loss. And so hemoglobin kitna hai? Hemoglobin? Hemoglobin is 10. I don't want to transfuse blood for this patient. So I would try to conserve as much of blood as possible. So what will be my first step? My first step will be an incision on the other side. I will do a septal window. So that will be the first step so that I get a cross-coat access. This is the first step. I will lateralize the inferior turbinate, lateralize the middle turbinate, and then I'll go in for a septal window. And then I will try to remove the posterior part, most part of the septum, posterior most part on the right side, not on the left side. I will not touch the tumor at all. So that will be my second step. Third step is I will do anterior posterior ethmoidectomy. I will just enter here into this cell and also into the sphenoid sinus. So that will be my third step. Then my fourth step will be an endoscopic modified Denkers, and then I will approach the internal maxillary artery. I will clip the internal maxillary artery, and then I will go for the tumor removal. So this is all I have to do. So this is what is called a planning. A complete planning should be done so that your surgery looks very smooth. You have planned your surgery. So with this, you can ask me questions if you want.
Yes.
I think
Sir, pre-op embolization is done in this case, not necessary.
What?
Pre-op embolization.
No, we never embolize.
Not in this case. Routinely, do you practice?
No. We don't embolize at all. We don't embolize our JNA. Reddy sir is there. So Dr. Mohan Reddy sir is there. All of them are very close to us, and You can all interact, sir. You're all dons. You can interact with me. You can see that. Is the picture quality good, please?
Very nice, sir.
Okay, you can see the JNA there. All of you, can you see the JNA there very
Yes, sir.
clearly?
Yes, sir.
Okay,
Yes,
I'm
very-
being helped by.
Very clear.
Huh?
Yes, we can see.
Yeah, packed. I'm being helped by three people here. I have the luxury. One is Dr. Shilpi Bhattacharya, Lakshmi, she is a favorite student of mine, and Dr. Shivakumar. And you can see here that I'm just going to pack the nose on the left side, but right side. So everything should be planned before you just go and just start. I always say there's no point in just going and operating without any planning done for the surgery. So here we are.
There are many junior consultants and postgraduates are watching, sir.
Yeah.
What are the do's and don'ts in the face in brief within 1 minute?
What are the
Do's and don'ts in the face for the juniors and postgraduates?
mean? Fess or
As you
skull
have
base?
time,
You mean fess or skull base?
routine, any endoscopic sinus surgery.
Routine endoscopic sinus surgery. I think we have published the 15 commandments.
Yes, sir.
So I think you will have to learn the just read that book. So how the position of the patient, reverse Trendelenburg, and also head and slightly elevated and neutral position, holding the endoscope, and how we introduce the instrument, what is the distance of the instrument, all that I think we have written in the book. I think don'ts is don't operate on a JNA as your first case. This is my important. So if you want to do skull base, do a lot of FES before you start doing skull base.
Yes, sir.
So that is something which is an important don't. You can see here that the nasopharynx is involved here. Can you all see
Yes,
that very
yes.
clearly?
Yes, we can see the
Adenoid
patch.
here. This is not the mass, this is the adenoid. Okay, the first step which I'm going to do is already plan surgery. Planning is extremely important, as I told you. So the first step is lateralization of the inferior tablet on the other side, not the involved side. The second is middle the involved side. Please, all these are completely planned by me. So read the plan again so that you plan the surgery. So these are the things which I always surgery very simple. Now the next step is going to keep going. This is in 1,000 adrenaline, 1 in 1,000, unquantified, undiluted adrenaline. And infiltration, please. Now I'm going in for the full window. So because I want a cross-coat access, I want a cross-coat access. I can't do it with a big posterior appendectomy like what I do for the pituitary. I'm just in for techniques.
So there was some connection.
Use both the nostrils. I'm telling you.
Janki sir, we
Your
lost
mic,
you for
your
a
mic
moment.
is getting broken. Please adjust the mic.
Janki sir, there was some network issue. For a moment, we lost you. So can you please repeat? Janki sir, can you hear us?
Hello, theater.
Hello, Janki sir. We cannot hear you.
Hello, can you hear me, please?
Yes.
Yes, now we
We
can hear
lost
you.
you for
yeah.
moments.
Yeah.
So can you please repeat what you said last 2 minutes?
So I said the most important thing is to get a binostril access. When you're a
400 surgeon. If you are a 200 surgeon, this might not be required. But since I am trained by the Pittsburgh group, I always do binocular access. If it is going to be a binocular access, then it's so easy. It's so comfortable. Believe me, it's so comfortable. And you will see how this is going to help me during the surgery. But of course, if you are trained in two-handed, that is, if you hold the scope, then it's a different ball game. You don't need to do the step at all. But I am a surgeon who doesn't hold the scope at all. I don't hold the scope. I don't like to hold the scope. I want somebody else to hold the scope. So this is what is called the septal window. This is called the septal window. See what I've done right now. I've just elevated the.
What is the size of the septal window, sir? Appropriate size.
I'm going to show you that. So this is actually the elevation. Hold this. Hold this. So Lakshmi is holding it. And now I'm now going to make the window here. See the window now. So yes. I'm just, it's like a septal correction only. So this Priya's elevator is designed. Yeah, this is by me. It is used as a knife also. It is used as a knife also. It can be used as an elevator also. So see how I'm using that. So there's no specific size or something like that, but inferior part of the cartilaginous septum we remove.
Yes.
Can you see that very clearly?
Yes, sir.
So I'm removing this. Sometimes what I do is I just transpose the septum and then retain it back later. I mean, you can do whatever, but basically the idea is to get a binocular access. So I'm operating from Vasavi Hospital, which is in Lakadi Kapoor. I really thank the management for having, given this theater, and that too, we are doing most of the cases free of cost. So thank you very much, management. So see that. And now what I've done is I'm now removing that piece of cartilage. So that's the window which I've created. Can you see that clearly, please?
Yes, sir.
So this is my first step I planned during my surgery as well. So that's the first step. So ordinarily what a two-handed surgeon would have done, he would have started with the endoscopic modified Denkers. Am I right or wrong?
Yes.
Now you see here, that is irrigation with warm saline. Now I'm going to force my suction like this and put it here. You see here. See where my suction is pointing. Can you see?
Yes, sir. Yes.
It is pointing towards the infratemporal fossa.
Yes, sir.
So that is the idea. To get an access to the infratemporal fossa, I'm doing that. Now, give me the knife.
You mean warm saline means the?
Warm saline at 40 degrees. It
30.
causes hemostasis by activating the extrinsic pathway of hemostasis.
Yes.
See, I'm making a horizontal incision. Can you see that?
Yes,
I'm making a horizontal incision. That's a vertical incision. So there is no chance of a septal perforation. Can you see here now?
Yes, sir.
See what happened now. So I've converted it into a binocular access. A uninostril access has been converted into a binocular access. That is the first step in JNA surgery for me. Okay, right. Now give me the coblation. Now I'm taking the coblation. What coblation is this? So this is actually the bonds. I love this because it's cheaper and it's far more aggressive than the other one. So I love it. Now you see what I'm trying to do now is I'm going to take a little bit less irrigation.
12,000.
So that's the posterior most end. See that? Now can you see that I'm just coagulating that's ablation.
Yes.
See how powerful this is.
Infiltrated med.
Okay, that's it. That's all the septum I have to remove. I don't need to remove much, very little of the posterior septum, because sometimes the JNA can get attached to the posterior end of the septum. That's
Septum.
why I'm removing this. Okay,
Yes.
right? And also the access to the nasopharynx will be direct. That's why I'm doing this. Okay. Now, having done that, my surgery on the left side, the right side is over. Now I'm going to the left side. Suction. Now it'll be a straightforward endoscopic modified Denkers. And then see that now. Very beautiful. See, one thing is, if I do the Denker, no, it is very difficult for me to do the ethmoidectomy. So I would like to do the ethmoidectomy, then I will do a Denker.
Yes.
This is something I want to tell you. If you do a Denker, it is difficult to do an ethmoidectomy. Why do I have to do an ethmoidectomy in this case? Anybody can ask the post. Oh, there are no postgraduates at all, so I can't ask any questions. They are all consultants. I should not ask. Okay, the reason why I want to do an ethmoidectomy is because it is the best way to access the inferior orbital fissure. So that is why, give me a pack. That is why I do an ethmoidectomy. Pack. That is why I do a pack. That is why I always do an ethmoidectomy when we want to access the inferior orbital fissure. So all these kuti points, small points, should be kept in mind. You might be thinking, why is he doing a ethmoidectomy? Not all required. No, it is required. Once, if it is going to go inside the inferior orbital fissure, maybe a type, I don't know, B or something like that, according to Professor Bradu's classification in the inferior orbital fissure, then you definitely need to, backbiter, drill the medial wall of the inferior orbital fissure. Backbiter. Thank you. Backbiter, please. Wonderful, wonderful. Thank you. Now I'm just going inside. See what I'm trying to do now. I'm just going for an uncinectomy as usual. Uncinectomy as usual. Anyway, I'm not bothered about the middle meatal antrostomy right now. The reason is anyway I'm going to do a Denker. Give me the debrider now. Ball probe, then debrider. Yeah. So, what is the BP, madam? Madam, I need to reduce the BP, please. I want the BP 90 and then I want the pulse rate as 60. This is how we operate usually, not 120, right? So that's the uncinate process. All of you,
Yes, sir.
the moderators are there. I mean, are you able to hear me, please?
Yes, sir. Very clear.
Are you able to see the picture, all of you?
Yes, sir.
Why no questions at all?
Because as usual, everyone is engrossed with the visuals.
What, boss?
As usual, everyone is engrossed with the visuals.
Sir, spellbound is more, apt to what?
अरे मोहन रेड्डी गारू कैसे हैं आप? See the lamina papracia. See, I'm stripping the mucosa from the lamina papracia. Why? Because I have to expose the inferior orbital fissure. These are all the nuances in JNA surgery.
Janki.
Sir, how are you, sir? Welcome, welcome, sir. I missed you in the morning, sir.
The great job you are doing. Congratulations to you, first of all.
Sir,
It's
your blessings, sir. Your blessings.
so
sir.
many people. I've been watching. So many people are gathered here and heard 100 centers. Really,
Sir.
A great job.
Your blessings, sir. You're all our gurus.
I'm learning from you.
No, sir, it's mutual, sir. Okay, now actually, why did I do
I
this?
mean it really, I'm telling. See.
Sir, it is the greatest honor for having you here, sir. Nothing more I can say.
Hello, sir. Hello.
Yes, please.
Sir, I'm Dr. Abhishek Srivastava. I just want to ask you if the.
I didn't get your name, my dear friend.
My name is Dr. Abhishek Srivastava. I'm from Ranchi.
Hi, Dr. Abhishek. I know you. Yeah. Please tell me, please.
Sir, I just want to ask you if the tumor would have invaded into posterior ethmoids, then you would
But
have.
I wouldn't do this.
Okay.
I wouldn't do this.
Yeah. And
if the tumor was there in the posterior ethmoid, how will I do this? I will not do this.
Okay.
I will be doing the that last.
Okay.
But anyway, if you want to expose the inferior orbital fissure, you have to expose the ethmoid, boss. This is the very simple mathematics.
Yeah.
The mathematics of inferior orbital fissure is all about exposing the ethmoids, posterior ethmoid. Hey, why the bleeding is so much? What is the BP? Madam, you have to reduce the pulse rate is 110. Why? Madam, please, madam. 110 में नहीं कर सकते हैं, madam. ये बहुत bloodless surgery है. Suction. See, we have few RBCs only coming out. Here it's fully bloody. We should have the pulse rate 60. 60 only we should have. You can't have it at 110. 110 is very high. One more pack, please. Madam, give some esmolol drip, something like that. I don't want this pulse rate because the audience will think I'm a bad surgeon. Being seen throughout the world. Yeah. But the pulse rate should come. No. Oh. How can I do it? Ethmoidectomy. How can I use coagulation? I'll do that. Okay, suction. Okay. Now, having done that, so I've done the ethmoidectomy. Now, I'm going to start with my
Modified Denker.
Denker surgery. You can see here, the first step in the Denker is the inferior. Hey, தண்ணி இல்லம்மா அவங்க பண்ணலனா இது வந்து பிளாக் ஆகும். come on ரொம்ப பண்ணாத. அத இதுலயே பண்ணிடுவேன். Already BP is very high. So I usually take off the turbinate.
Yes, sir.
Usually with the scissors, but since the BP is slightly high, I don't want to do that here. Now I'm going laterally. Can you see here?
Yes.
See how beautifully we are able to manipulate the scope. Now here you will find the turbinate branch of the sphenopalatine artery.
Postnasal artery.
Yes. No, not postnasal. This is the turbinate branch, inferior turbinate branch of the
Lateral branch.
Yeah, correct. Okay. Now I'm going to take off all this. Irrigate. See how beautifully Lakshmi is helping me. So I'm eating off all this soft tissue. Okay, lovely. Having done that now, so I'm now going to define the anterior piriform aperture.
Sure.
Now, okay, that's anterior. Can you all appreciate the anterior piriform aperture? Nageshwar Rao
sir.
garu.
Not yet, sir. You have
No.
to. No. Now it is going to see.
Clearly seen.
Hmm.
People are watching you with a high pulse rate here.
People what?
With a high pulse rate, they are all watching.
Fully involved in watching.
High
sir.
pulse rate. There is no bleeding at all. What is? Sir, this is not a case for high. Tomorrow you see.
Yes, sir.
All
Now
the pulse rate will be 500 when I'm operating. That is a very, very difficult case. That is a clival hemangioma. I think there are only 2 cases reported in literature. I went through literature. Okay, now, Madam BP, thoda kam karo, Madam, please. 107 zyada hai, Madam. Aapko,
sir, here authenticated person in India for JNA. Have you done any JNA case in female?
Yeah, what?
Female patient. In
Female,
J-
never.
Never.
Never. When we got a few reports,
Yes, sir.
but hold this. When we got the immunohistochemistry, it didn't fit in. It became either angiomatous polyp, some lymphoma, something like that, lymphoepithelioma. Give me a cobblator.
Hamartoma.
So, if you do a complete study, then you find that these are actually not true JNAs.
Yes.
So, I don't think, maybe even if you read the old literature,
Yes, sir.
they would have told that, these are not really true JNAs.
Yes.
This is definitely hormone related tumor.
Yes.
That's why flutamide helps. No, that's why flutamide helps.
Yes, yes, sir.
Okay. Now, having done that, you see that's the intraorbital now. Can you see the intraorbital
Yes,
now
sir.
very clearly?
Very
my dear?
beautiful. Very beautiful. Yes.
Yeah, come. Now I'm going to four-handed. Now Shilpi is going to help me now. My eye, I call her. My eye because she shows me the endoscope.
Sir, please show the external picture of the four hands.
External picture, please. Yeah.
How they are holding the scope.
Can you see now?
No, sir.
You should hold it. You should hold it.
Yeah, now it is.
Can you see?
Yes, sir.
Hey, you move, Shiv Kumar.
Endo picture, please.
Endo picture.
Endo
please.
picture. Endo picture, please.
Endoscope picture, please, sir.
Endoscopic picture.
Yeah.
Yeah, got it.
You both the PIP.
Yes.
Hey, what happened? Man? Why did it become like this, man? This is actually the Medtronic drill.
Yes.
I know I can't do anything. Carl Stores only has got a. So these are called osteotomies. I do the osteotomy. They're all measured osteotomies.
Yes.
It all depends on where the tumor is. So my planning of the osteotomy is also dependent upon where I have to reach. If it's going to be the cavernous sinus, then I'll go for a very high osteotomy. If it's going to be the parapharyngeal space, I'll go in for a very low osteotomy. So all these are.
Can we use lux forceps, sir, at this moment instead of wasting
What?
time in
Can I
drilling?
What?
Lux forceps to break the bone. Can we use it now?
Can you?
Yeah, we can use whatever we want. Only thing is I do it in a very controlled fashion.
Yes.
Now you said once you are doing the osteotomy.
Bone nebula.
You can use mallet and gouge also.
Yes, sir.
Why is it coming out like this? Now I'm going to remove this bone. Okay.
Yes, sir.
Now we are planning to do a study where we will reposition this bone again with plate and screw. So I will show you now the next two cases. We have done in Trichy now, and we put a mini plate and screw. We are still waiting for the result because it's the periosteum is preserved. I'm hoping that it will survive suction. So that is our new technique. Suction, please. Can you all see the maxillary sinus, all of you?
Very beautiful, sir.
I have still not taken off the inferior turbinate. Okay. No. I'll just take a drill a little bit and then I will do that. Drill, please. Hold it, Shilpi. Yeah, a little bit more and then I will start removing soft tissue. So here we are.
In a large tumors, to get access to the anterior wall.
What?
In large tumors, to get access to the anterior wall of the maxilla. Sir. Hello, theater.
Hello, yes, sir.
Yes, sir. Yes, sir.
Yes, sir. We can hear you, sir.
Yes, sir. In large tumors, to get access to the anterior wall of the maxillary sinus. At this moment, what is the steps to taken, sir? In large tumors, to get access, more access to the anterior wall of the maxillary sinus. What is the question?
How do you get in large tumors access to the maxillary sinus?
It pushes the posterior. No, I don't understand the question, sir. Please, can you please?
In other cases, in large tumors, to get access to the anterior wall of the maxillary sinus, sir, at this moment.
Anterolateral wall.
Yeah, anterolateral wall.
Anterolateral wall is not coblation. It is not.
In any side, only the it is prolapsing in the sinus.
Coblation. Tanni. Now, where do you find the nasolacrimal duct? That is very, very important.
Yes,
please understand that the nasolacrimal duct is 1 centimeter, 9 millimeters posterior to the anterior end of the inferior tube. Tanni kudra.
Yes.
So you see that that's a nasal. Can you all appreciate
Yes,
it,
sir.
please?
Yes, sir.
See the anterior wall of the nasolacrimal duct.
Yes, sir.
Hey, elevator. So that's the maxillary sinus.
Yes, sir.
This is the inferior turbinate. See how beautiful it looks. Just I need the better.
Elevator.
Now, how many of you can see the nasolacrimal duct so nicely?
Very, very beautiful, sir.
Now, you see here,
Like
this is the nasolacrimal duct.
Yes.
So, I have not yet cut the nasolacrimal duct. And what we can actually do is just transpose it. You don't even need to do anything to it. Give me a scissors now. Scissors. Scissors, please. Scissors. Nikal do. Scissors. Now you see here. See, I'm going below the valve of Hasna. This is below the valve of Hasna.
Yes.
Blexley. Give me a scissors. Scissors, please. Now, I'm just going to cut off the inferior turbinate. Can you see that? I'm cutting off the inferior turbinate, please, all of you.
Yes, sir.
Now, can you give me the... Okay. Now, that's the nasolacrimal duct. Transecting the nasolacrimal duct. I can transpose if it is going to be a small tumor. I generally transpose it. Scissors, Sariya kudu. Why the scissors is not cutting properly? Suction, please. Okay, now the pulse rate has come down. You can see that's the tumor. Can you all see the tumor here very beautifully?
Yes, sir.
Tumor medial to the middle turbinate.
Yes, sir.
Very nicely seen. Ethmoid has been completely, yeah. Now scissors again. Now I'm going to take off the now give me the okay. Having done that, what is my next step? What is my next step? My next step is to define the posterior wall of the maxillary sinus. Give me a big pack. Give me a big pack. I hope the picture is clear. My voice is clear.
Yes, yes, absolutely.
Because there is no sound from the other side. I'm a little scared.
All are deeply involved, sir.
No, not deeply involved. Deeply sleeping. After a good lunch by Sun Pharma.
Everybody is sitting.
I can hear a little snoring sound also. Especially Nageshwar Rao Garu is snoring.
No, sir. No, sir. I'm very active.
He's neck deeply involved.
Okay, you see, I did that septal window, no? How is it useful? Now you see the usefulness of the septal window. No. This is ethmoid. Now give me a scissors. Okay, here we are. I'm going to cut the middle turbinate. Always resect partially the middle turbinate because JNA is always attached to the middle turbinate. So you better resect a little bit of it, not completely, a little bit of it. Okay, right. Okay, right. Now, having done that, give me a good pack again. That's a little bit of the middle turbinate. Okay, give me a long pack, please. Give me a good irrigation, please. Good irrigation. Yeah. Irrigate. Madam, we are only irrigating. You have to count the irrigation fluid only. Bleeding is less only, but there is irrigation, lot of irrigation. Okay, right. Now, come on. Shall we start, Shilpi? Now, the next important step is we are going to delineate the posterior wall of the maxillary sinus. Okay. So, what is this? This is called the, what sign is this?
Hallman-Muller, sir.
That is the Hallman-Muller sign. Hold. Now, I'm going for the binostril technique. You see how this binostril helps me. See how? I'm now going through this septum. Sorry. Wait, you're pulling it.
No.
Oh. I'm going through this septum and I'm going through this. Yeah, come. Now you see what happened now.
Yes, sir.
So I have such a cobblator. Yeah, cobblator, Tanni. What happened to you, Shilpi? Yeah, come nearer. No. Why you are far away? You should come near. All others should be far away. Irrigate on the scope. See, the bone is gone here. Can you see that clearly,
Yes,
please,
yes.
my dear friend?
Yes, sir. Eroded. Push one of the magnets sinus.
Okay, now give me the drill. Quick. Drill, please. Yeah. Drill. Okay, here we are. I'm now going with the drill. See how the binostril technique helps me.
Yes, sir.
I don't have any hitching.
Yes, sir.
No hitching at all. Okay, give me a elevator. Cat's paw. Right, thank you. Now I'm just going to take off that bone.
Yes.
You can see that's the posterior wall of the
Maxillary sinus.
maxillary sinus. Can you all appreciate it, please?
Yes, sir. Very beautiful.
What is that? Hey, go closer.
Periosteum of the.
Ah, that's the periosteum. Here, what you can do is just reflect this periosteum.
Yes, sir.
Just reflect this periosteum. That's all. Give me now the corblator.
First, we will see the fat.
Now, the first step is to identify the IMAX.
IMAX. But we'll see the fat, sir, first.
Blue. Blue, See, what you are seeing here? Anybody, what is this? What is this? Hey, go closer. What is that? Anybody? Quick.
That maxillary nerve, sir.
That's a greater palatine. See here, it's going towards the greater palatine foramen from the pterygopalatine ganglion.
Yeah.
The moment you see such structures, next minute you should be able to identify all these.
Yes.
Now I'm identifying the IMAX. Tanni.
When the fat is collapsing, can we remove that fat, sir? Or
Yeah. Usually I do that. But since it's a very small tumor, I don't want to remove the fat.
Yes.
Usually I remove the fat.
Yes.
You're right. Okay, now what I'm going to do is to search for the IMAX. You see how I search for the IMAX now?
Yes.
There's a specific technique which I use for that.
Sir, either bone is cancellous or the bone erode the tumor erode the bone, sir. Why this is very soft?
No, the erosion of the bone, no. The erosion of the bone.
Because of small tumor.
No, the tumor was eroding the bone. See, it's very, see that
Yes,
eggshell,
Yes, sir.
eggshell bone. Okay, now let me get the Freer's elevator. Now I'll show you the artery now. Within a minute, I'll show you the artery.
Yes.
See here. Sorry. Now see here. The moment I press this out, that's the tumor. Greater palatine nerve. Go closer, please.
Getting admitted.
Can you see the artery or not?
Yes, sir. Pulsations. See that pulsations.
Come out. Come out.
Yes.
Now I'll use my cobblator again.
A loop-like structure, sir. That's here.
Yeah, I'll show you. I'll show you. This is the greater palatine nerve.
Yes, sir.
Now give me the cobblator now. Cobblator. Blue.
The angioma is that is here.
No, let me see the MRI, then we'll see. Almost over. This is almost over. Once I find the IMAX, it's over. It takes a few minutes for me. Give me the debrider, man. I don't like to fight with this fat. So I generally take off this fat. Debrider. See, I'll teach you a simple technique for this. See, take the debrider.
Yes, sir.
And the debrider pulls the fat out. See here. It will pull the fat out. See here, I keep it inside and then I move like this and come out. A lot of fat. Hey, why the debrider suction is not working? Suction is not working. Give me a pack. Come, quick. In the pack. Okay. Shilpi, go. Go closer, please. Go closer, please. Okay. Debrider, please. Yeah. Now I'm just going to take the debrider. Easiest method to identify the artery is this. Take off the fat. And we also studied the cheek on long term. I have a long follow-up such cases. And removing this doesn't alter any of the beauty of the patient. But in this, actually, I use very less coblation.
Yes.
Because I don't coblate too much of the fat. And see, hey, go closer, please, Shilpi. You direct your debrider downwards and outwards. Always downwards and outwards. Reason is,
Sir.
that is where there's maximum fat.
Sir.
That is where there's no artery.
Sir. Janikram, sir.
Yeah.
Sir, once please tone the maxillary artery and control the bleeding in this case, sir. We want to see. Air the maxillary artery and control the bleeding.
He can do anything, no problem.
Yes, sir. Sir, once.
He can coil the internal carotid artery also. If you want, he will show inside in one case. In the next sessions. Boss is able to do ICA coiling also, no problem.
Yes, sir.
Sir, some of the delegates want to see maxillary artery bleeding, sir.
Maxillary artery bleeding you want to see,
Yes, sir.
Why, boss? This is a 10-year-old child, boss.
10-year-old and 10 HP.
Sir, that loop is in IMAX, sir. Here.
was very fat, boss. ये निकलता रहेगा.
Yeah, no
He is very fat.
loop lag ఉంది కదా సార్ సక్షన్ దగ్గర
He is very chubby.
Let him be very chubby.
అది
Boss is very fat.
Let him be chubby.
suction is not proper.
He likes it.
There's something like liposuction.
Yes, sir.
I do it invariably in all cases. You know, this helps in two ways. Number one, if this one is going towards cheek, no, this is the best technique. If it goes towards cheek, this is the best technique. Number two, if it is posterior also, no, you can clearly identify the muscle.
Shilpi, concentrate, no? Close, yeah. Okay.
Now see. You want to see, no?
Yes, sir.
See, how do I control this? It's very easy. Just keep that suction there. That's it, finished. Give me the coblation. And then what you do is you just keep this. And that's all. See, there's nothing. No, you need not worry about any bleeding here. It is just by pack. That's it, finished. See, it took really around 5 seconds for me to control it. Not even 5 seconds, rather. So that's it, finished. Now what you do, cut panna. Coblation. ये बहुत बड़ा है यार. If you have the four-handed technique, nothing like it, boss. You can actually play with any structure here. In skull base, see here. Now see how I'm visualizing it. See how
Four-handed, the assistant surgeon also should be
Yeah.
sound in technique, sir.
See how she's showing me now.
Yes, sir.
Ready. Okay, right. Now I'm just pushing this.
Dr. Janikram.
Yeah. Can you see the muzzle here? Temporalis muscle, all of you.
Yes, sir.
Wow, see that now. I'm able to see.
Yes, yes, very clear, sir.
That is the lateral rectus. Lateral pterygoid.
Lateral pterygoid, sir.
Pterygoid.
Yeah, it's just out of my curiosity. I'm asking this question.
Yeah.
Tumor volume is small and the fat volume was big. So here we are removing the fat to access the small tumor. But classical saying is like sinuses act as a cushion effect for the face when we have an impact with the facial injuries and so on. So here everything is removed, debulking everything from the sinuses. Will it have anything adverse?
Sir, this is actually the fat. We are not doing anything in the sinuses, number one. Number two, the buccal part of fat, if you remove, there's nothing which happens. We have been following up such cases. Absolutely nothing happens. But all the more, of course, in this case, it's a small tumor, it's okay. But this is a classical teaching by me that you have to see the temporalis muscle laterally, lateral pterygoid posteriorly. Without that, don't ever try to remove a JNA. This is what I always insist. So this is like more of a teaching stuff which I did. Of course, for this case, I need not have removed it. I mean, I agree. Give me a coblation. See, but you see the lateral aspect. It's so beautifully seen. There's no evidence of tumor absolutely whatsoever. Can you all appreciate that very clearly?
Yes, sir.
And another thing is, see, the coagulation or the suction, it keeps coming. Give me the, now can you see the artery here? Here. Give me now the, give me the ball probe. Give me the clip. Can you see the artery here, please, all of you?
Yes,
All of
sir.
you, can you see the artery?
Yes, sir. Loop round. Loop.
See how nicely you are able to delineate the artery. There is no fat, there's nothing. So easily we can do that.
Yes.
Of course, with the fat also we can do, but it is I'm just, see, as a teacher, I should teach the easy way, not the difficult way for you.
Yes.
To me, I think this is the easiest way to get the anatomy. One more. Can you now see, all of you? See how beautifully we have clipped the artery.
Yes, sir.
Go inside, go inside, go inside. See, let them see. See how beautiful it is seen. Hold this like this. Hold this like this. So what was actually bleeding? Anybody can say what actually bled? That is the posterior superior alveolar artery, which actually bled. Very small bleeder was there. That is posterior superior alveolar. See, that's all. Finish. Leave it. Now, can you see that, all of you?
Yes.
Yes, sir.
Very, very clear, boss. What more you want? See that. Clearly removed all the tumor out. And now it's just a matter of removal of this. Only thing we have to take care is the inferior orbital.
Infraorbital nerve.
Inferior orbital fissure. I'm going to show you how to remove the inferior orbital fissure part. Okay, right. Now, having done that, now the vascularity of the tumor is gone.
Yes,
Okay?
sir. Yes, sir.
Now, what I will do, suction, suction, suction. Suction, suction, suction block. Now, the only thing remaining is the sphenoid component. That's all finished. I am done with it.
So,
Hey, why
Dr.
is suction?
Archana,
Suction, suction, suction. Suction block. Suction, suction, suction. Give me 3-4 suctions. I don't want suction to be blocked now. Now I'm going in for uninostril technique.
Yes, sir.
I'm suction, suction. Hey, suction, suction. I'm not happy with the suction. I'm not happy with the suction, please. Coblation, please. Coblation. Okay, I'm done with it. What is the time now? Almost done. Now that is the posterior ethmoid from which I'm removing that pack which I kept. Coblation now. I'm now going to take off the, see that's the posterior ethmoid, that's the septum here. Coblation.
Attachments.
Now I'm going to take off the attachment from the medial aspect, right?
Yes.
That side septum I have already removed. Go closer, go closer. Any doubt so far, my dear friends?
So, Dr. Archana from this side, say, one request for the students who are virtually attending the workshop. So, what are the important steps? First thing is, please summarize whichever steps you have performed today. And then second, what are the risk factors or complications you are expecting? How to deal with that so that it will help them in future if they...
Yeah, good question actually. See, give me a drill. Give me a drill. So in JNA surgery, the most important thing we'll have to remember is bleeding. Because JNA is notorious for bleeding. And people say it's a small JNA. You know, Professor Karao keeps telling there's nothing like small in JNA at all. There's nothing like small. Any JNA can really show its color. And once it's bleeding, believe me, it's a small child. And all these have very less blood volume. So you don't want to lose blood. We have seen in workshops where patients have developed shock. hypovolemic shock. So the most important thing you have to take care of is the bleeding. This is to me, I think that is the single most important complication of a JNA. Now, apart from that, we have other complications like trigeminal cardiac reflex, which we have already published. Patient can develop bradycardia. Apart from that, immediate post-op, you might have crusting. Because you're doing a skull-based surgery, you might have crusting. So that's the sphenoid component. Can you all see the sphenoid component there, all of you?
Yes, sir. Sir, this sphenoid component entering into the sphenoid through the ostium or erosion of the
It erodes the floor.
erosion
See,
of the
it erodes
antral
the
wall.
floor. Can you see that clearly?
Yes, sir.
See that? See the floor being eroded?
Yes, sir. Yes, sir.
I'm pushing it downwards now. My dear friend, you can see that very clearly. I'm pushing it
Yes, sir.
downwards.
Yes.
Okay?
Usually,
Now, the most important thing is the inferior orbital fissure part.
yes.
See that? Now I have almost
The
forced it
JNA,
down.
yeah. The JNA usually doesn't have any attachment within the sphenoid sinus,
Yeah.
except in the
Except when the anterolateral wall
cavernous
is
sinus.
eroded going towards the cavernous sinus. Now you see here, this is the most important drill. See here. Now you see, this is what I said about the ethmoids. You see here, this is the ethmoids here. You drill this area. If it's going inside the inferior orbital fissure, you drill what is called the ethmomaxillary. Go inside, my dear friend. It's okay. Wait. Don't break the scope and say that. Sorry. I'm sorry if I told you. So you have to drill this area. And if you drill this area, you will open up the inferior orbital fissure. This is the key. If the inferior orbital fissure is involved, if the superior orbital fissure is involved, you should go here. If the cavernous sinus is involved, you go here. That's the maxillary strut.
Yes.
So this is the key to JNA surgery. Now that's it. Once I've done this, I have now exposed the inferior orbital fissure. The only thing you might find is a little attachment to the V2, which you have to protect now. I'm going to show you how to do that. The pterygoid wedge, of course, I'll do last. Okay, right. Having done that, now I'm ready for the tumor. Madam, I'm going to take the tumor out. Now give me the coblation. Let me coblate this artery here. So all of you now got the idea of what I'm trying to do? All of you?
Yes.
Give me a scissors. For coblation. Give me a coblation. Coblation. Hereafter all coblations. Tanni. This is posterior to the nasolacrimal duct. Nasolacrimal duct is anterior to it. Now, can you see that clearly?
Yes.
This is the nasolacrimal duct is here. The mucosa of the superior wall of the maxillary sinus. Okay, right. Here we are. Now I'm going right inside.
So do you
That's
preserve
all the
infraorbital
mucosa. Suction.
Sir, infraorbital now do you preserve or?
Of course, we have to. I'll show you the infraorbital nerve. I'll show you the infraorbital nerve. You have to preserve the infraorbital nerve. How can you give numbness in a patient, that to a young boy? So here I'm going to cut the artery here. Can you see that artery here?
Yes, sir.
All of you? Yeah, I'm just going to cut that artery now. Okay. Now see, I'm separating that artery. Can you all appreciate that? All of you?
Yes.
Yes, sir.
Yes, sir.
Pushing it laterally.
Yeah. Now I'm done. I'm now going to deliver this JNA from the infratemporal fossa. And when I do that,
So there's one question from the one of the expert from the hall. Embolization has any role if there is bleeding?
what? Embolization what?
Has a role. Embolization have any role if there is bleeding?
where is the bleeding? I would just want to ask you where's the bleeding.
No, no, not in this
Not in this case,
Not
sir.
in this
routine.
case, sir.
No, when you can do it without bleeding, why you want to embolize? Why you want to spend extra cost? And embolization has got its own hazards. And it gives a pseudo confidence, you know. It gives a pseudo confidence that it will not bleed. And you go inside, it starts bleeding, you will blame the radiation oncologist saying that, no, he didn't do the embolization properly.
Sure,
Oh, sorry, interventional radiologist. Okay, sorry. Sorry, Shilpi. Thanks for correction. Black sleeves. Okay, now I'm ready. I'm going to go for the tumor now. Done. Okay. Now, you see here, that's the inferior orbital fissure.
Yes, sir.
Now, I'm
show
just...
the inferior orbital fissure. Can you once show the inferior orbital?
I'll show you. Now, give me a elevator. Elevator. Now, so I think in this case, if I say there's something which is most tricky, I would say inferior orbital fissure, but it's only touching the inferior orbital fissure. If I had got a going inside the inferior orbital fissure, superior orbital fissure, I would have actually shown better. Okay, fine. Hold head. Show me Shilpi. Now, this is the inferior orbital fissure. See that now. See that. That's the inferior orbital fissure. Okay, I drilled this bone. Previous. Hey, can you? Pause. Sorry, my dear friend. Now, I'm going to remove that from the inferior orbital fissure.
Yes, sir.
Now, it's touching the inferior orbital fissure. That is just the periosteum. Can you see that?
Yes.
That is the component in the inferior orbital fissure. All of you?
Yes, sir.
That is the component in the inferior orbital fissure, my dear friends.
Yes.
Now, see how beautifully the JNA is coming out. Now, having done that now, Are Shilpi. There's one more vessel coming there. Give me a... No, give me a... This one. Clip. One more vessel. Come on.
Could you name that artery, Dr. Janakiram?
No, can you give me a cobblator? So in this way, you can see everything you want to do and you can reduce the real blood loss.
On this floor.
Can you name that vessel? Is it Vividian?
Spinopeltine?
What?
Is it a branch?
Yeah. Going inside the tumor. Right. Having done that, now I'm going to remove that tumor now. Give me a... No, elevator. Always use the elevator to remove tumor. Okay, here we are. Now I'm going to do what is called the sweeping movement. It's called the rolling up movement. It's called the rolling up. Give me a bigger one. Bigger elevator.
Rolling down sphenoid component, rolling up.
Yeah, correct. Coblation.
Yes.
So I'm doing what is called the rolling up component from the nasopharynx.
Yes, sir.
So this we have described clearly in our book.
Yes.
So that's the posterior end of the septum. Don't use coblation the nasopharynx. Many people do that, and if you do that, you will leave behind residue. So that's just the posterior end of septum. Now, what I will do is I'm going to use the rolling up technique. See here, I'm just going to roll up. Hey, idillada, perusu kudra. Illayama. So it's in Trichy. Now I'm using the Takahashi then. I don't have a bigger elevator. This is called the rolling up technique. See here, you will find even the small, see.
Yes,
see
sir.
how it's coming out.
Yes, sir.
By gentle pressure, you give that.
Yes.
Closer, no, please. Not like that. You have to show me what I mean.
Septal attachment.
Yes, it can be cut with a couplet.
Can you see the septal attachment there? We have already
Yes, sir.
devascularized it. Can you give me the cobblator now? Beautiful. I have done it now. That is called the rolling up technique.
Yes.
And then we go for rolling down technique from the
Sphenoid component.
yes, sphenoid component. Correct. Okay. Now, having done that, now I'll go for the rolling down technique. See here. Now give me Takahashi. So I have done the rolling up. I'm going to do the rolling down. See here. Can you see the rolling down, all of you?
Sir. Very much. Slip has gone.
So the only caveat in this technique is that you might leave behind the pterygoid wedge component. When you do this,
yes,
you might leave behind the pterygoid. Give me a pack now. Finished. Tumor is over. Long pack. Over. That's it. Finished.
Yes, sir.
So rolling up, rolling down technique. All of you should practice that because don't use coblation at its attachment. If you do that, you might leave behind tumor. So the best is use a freers, a thick freers. Sorry, I kept it in Trichy, but we have a separate freers for this that will actually hook the JNA and pull it up.
So
okay, now.
So with your permission, can I take one or two virtual platform questions?
Of course, of course.
Sir, Dr. Pallavi from Jaipur, she wants to know, is clearing clivus always necessary after removing JNA?
Clearing clivus?
Yeah, that's a question.
Nowhere related to clivus here.
Clivus we don't clear, boss. Clivus only if it's involved we clear. Why should I clear the clivus? What is the reason? Only if it involves the clivus, I'll clear the clivus. Okay. Now, can you give me the oropharynx? Now, I'm just going to push this. See here, what I usually do is to keep one gauze piece like this and try to push it so that it doesn't come up.
Sir, will you do post-op CT? If so, when you will do post-op CT?
I always do post-op CT 36 hours after surgery.
36 hours.
Okay, this lux has been designed.
Still the
by
pack.
us. You can see here, this lux is a very nice instrument. It will not hold anything except the.
Some of the delegate is asking post-op follow-up of this case, sir.
Post-op follow-up 36 hours later, you take a repeat scan. That's all.
Yes,
and then see with the clip, it's coming out.
Yes, sir.
Yeah, see that?
Yes.
Okay, now having done that.
This is proof, sir. Nobody is sleeping. You are unnecessarily blamed us. Everybody
What is the proof?
Everybody is clapping, sir. There are big applause from the hall, sir.
Thank you, my dear friend. No, I want to teach. I don't want to get appreciated. This is very important.
So there's
Because
one more
I am beyond the age, and all of us who are demonstrating, we are beyond the age of, getting anything. Now, let us now see the landmark. More important is landmark. Now, what are the landmarks we have to see? The most important landmark after JNA surgery is the VDN nerve.
VDN canal.
If you don't see the VDN nerve, that means you have not done JNA surgery fully. So what I am going to do now is to demonstrate to you drill. The VDN nerve. Drill.
Sir, Dr. Navroz Mehta from Guwahati wants to know, according to branchial artery anomaly theory, JNA received supply from IC as well. So how to manage these cases?
What is the question?
There is one supply, blood supply from the ICI internal carotid artery also. If it bleeds, how will you manage? The question is, I think.
ICA, see, generally, only if it goes beyond the cavernous sinus, it's supplied by the ICA. There are only two branches usually which supply.
Median
One
artery
is
and
the meningohypophyseal, intralateral trunk, and the ophthalmic. Ophthalmic is the rarest out of the three. So this the dictum. If it is going to be supplied by the ICA,
yes, sir.
then do a DSA and then do a BOT, do a balloon occlusion test.
Yes.
And then you check whether we can do a coiling of the carotid. If it is massive supply from the ICA,
Yes,
do BOT. And then we can do either a stenting or a coiling, which we have done also. I think we have presented several cases like that. Now, I think we are the first in the world to do that also. Hey, suction, please. So the blood loss, how much was the blood loss? Around 80, 100 ml, 80 ml?
100 ml.
Okay, the blood loss was 85 ml, according to the anesthetist.
One more applause, sir.
No, I think without embolization, at least the people abroad might not believe us.
Yes, sir.
They will say, no, we embolize and all this stuff. There are many people seeing from all over the world. I just want to emphasize that if you are doing a proper surgery, give me a good wash.
Yes, sir.
You don't have to embolize, boss. You don't have to embolize. Okay. Okay, enough. Now drill. Now I'm going to drill the pterygoid wedge.
Yes, sir.
That is the pterygoid wedge. Drill. Now I'm going to identify the median nerve.
Yeah,
Very,
nerve.
very important.
Yes.
See, that's the medial pterygoid plate. That's the pterygoid wedge. See, that's the pterygoid wedge.
Yes, sir. Let me go inside.
The area safer area, sir. That's area safer.
Blexley.
Ready.
So I have to drill this pterygoid wedge till the level where I see the median nerve. Very, very important.
Yes.
Okay. Now let me see where the median nerve is. Oh, wonderful.
Yes, sir.
What are you seeing? Anybody?
Sir?
One big gold medal for the person who says, what is this? Anybody?
Which book?
Straight away gold medal.
Median artery.
No.
Sir?
No.
What is the question, sir?
This structure here.
Yes, sir. Median nerve.
This
Sir,
structure.
that's
Median nerve.
No.
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 That goes to foramina spinosus, huh?
What was that?
Foramina spinos.
Foramen spinosum. No.
Foramina. Is it maxillary nerve, sir? Foramina
No,
rotunda.
boss. See here. I'll tell you. Give me the hockey. Or give me the this one. See.
Yes, sir.
This is the communicating branch between the V2 and the median. See here. This is the V2 here. I'll show you the V2. Go inside. Go inside, my dear friend. Can you see the foramen here?
Yes, sir.
See, that's the foramen there. This is the median here. There is always a communicating branch between the median. This is the median canal. That's the V2. That's how the pterygopalatine ganglion is formed.
Oh.
Wait, I'll define it and show you. Only then you will agree with me, or else you will not even agree. You will say I'm wrong. See, all this is skull-based surgery. See here.
That bulge is ICA bulge, sir. That's above.
Wait. You see here now first.
Yes.
See this. Can you see the V2 here?
Yes,
all
sir.
of you, can you see the V2 here or not?
Yes, sir.
Okay, you see that there's a branch going like this. Can you see? Now I will drill here. You will see the median here.
Yes.
So that is the branch which communicates from the median to the V2, forming the pterygopalatine ganglion here. Drill. See how anatomy you are seeing, boss. This is you have to enjoy the anatomy. You go and refer to the Gray's anatomy, it will be there. See, now I'm drilling. I drilled off that communicating branch. What is this? What is this? Anybody? What is this? That's the lateral recess.
Maxillary strut, sir.
This is the lateral recess.
Lateral recess.
See the lateral recess.
Foramen rotundum and
Drill not clean. Now I'm going to show you the median nerve completely. Median nerve.
yes, sir.
See.
Yeah. Mucosa of the lateral.
This is mucosa of sphenoid sign. Go
Yes,
inside,
sir.
my dear friend. See, can you see the median now? Here, wait. Drill. I'll show you. I'll show you the median. Why? Now, give me this one. So, what is the median nerve landmark for? What is the median nerve landmark for?
Visceral part of the carotid.
ICS, sir.
Carotid
Visceral
artery. Carotid artery.
Yes, sir.
Horizontal part of the carotid artery. See here. Now, see the median now. Can you see the median now or not?
Yes,
sir.
Is it clear?
Yes, sir.
No, I will drill. You are not. The clear itself is not very clear.
No, sir, it is clear.
The
Very
clear
clear.
itself is not clear. Wait, I'll show you. Yay! Go inside.
Wow.
So sometime back you were talking about post-operative crest.
Give 1 second. Wait, I'll show you the median. Hey, black guy, this one. Ball probe. See here. This is the median now here. Go closer, my dear friend. I drilled it actually.
No.
That's the median now. There's no doubt about it. Only thing is,
Yes, sir.
come out. This is the V2. That's the V2. So that's the median for sure. I've drilled the whole pterygoid wedge. Yeah, you are asking some question.
I was asking, sometime back you were talking about post-operative cresting. So
Yeah.
you'd like to give some tip on
You
that?
give mu pyrosin washes. Mu pyrosin washes.
Thank you so much.
P-back washes.
Sure, sir.
Is that the optic nerve superiorly visible?
Yeah, I will just show you the anatomy of the sphenoid sinus. I think I'm through. Let me show you the anatomy, final anatomy. So you saw the V2, all of you saw the V2?
Yes,
Did you
sir.
see or not?
Yes, sir.
Median, actually I drilled the canal, so it has actually gone into the canal. Okay, see here. Now let me show you the anatomy. Yeah, give me a pack.
Ready.
See how beautiful the anatomy is. Wow. I love it. Okay. Can I see that ethmoid hemangioma? What is the time now?
440.
440.
440.
440. 1 second. I'll see if I can do one more case. That's a nice case. Before that, I want to see if tomorrow's case is good or Should I post this case tomorrow? Let me check.
Hello.
Sir,
I have a question. If the sphenoid component is too big and it is eroding into the basis sphenoid, then you pull the tumor down and do you drill out the basis sphenoid or you leave it just like that?
No. First, you pull the tumor down, the sphenoid component, and then you have to drill the basis sphenoid completely.
Okay.
That becomes sort of a invasion of the bone.
Okay. Till the dura we have to drill out.
Dura?
Till the dura we have to drill out in case we are drilling.
Not till the dura. Till the level where the tumor is, till the level where the normal bleed comes. The clivus bleeds, right? Till that level you have to come.
Okay.
Give me a pack. Now you see the cavity now. I'll show you. Okay, beautiful cavity looking nicely. We can see the cavity. I did that removal of the fat only for demonstration. This could have been done without it. I'm telling you. As I think Dr. Venkatraman Reddy only told. Yes, I agree with you, sir. But I see a better way is to delineate your anatomy. Because many people leave the residue there. Of course, you are very experienced. But I want to tell you what is the anatomy now. You see the anatomy now. See how clear. Give me the ball probe quickly. See here, this is the temporalis muscle here.
Yes.
The lateral pterygoid muscle is here. This is the lateral pterygoid muscle here.
Yes.
This is the IMAX here.
Clipped IMAX.
This is the IMAX which I clipped.
Yes.
The V2 goes above the IMAX. So I didn't even disturb it.
Yes.
But we are able to see the V2 here. Can you see here?
Yes.
This one here.
That's the medial part of it.
This should be the median, lateral recess.
Yes.
This you can see the carotid artery.
Yes.
Lateral opticocarotid recess, the optic nerve, that's the planum.
Okay.
So that is the maxillary strut. Superior orbital fissure is here.
Just again show the pterygoid wedge and meridian canal area. Precisely.
This is the pterygoid. See, this is the medial pterygoid plate.
Yes.
Pterygoid plate. This is the DPA. This is the, see that DPA. DPA means the descending palatine canal.
Yes.
Metapalatine canal. This is the pterygoid wedge between the medial pterygoid plate and lateral pterygoid plate. I've drilled.
Yes.
And it will lead you on to the median. This is the median. Actually, I drilled that median.
Yeah.
That's why it's gone into the bone. So that's the median, and it will give you the, it will go like this towards the lateral aspect of the carotid. Carotid is here. This is the paraclival carotid. It will go like this. So that is it. So that is the V2 bulge.
Yeah. Maxillary start again. Once again, show the maxillary start.
This is the maxillary strut here.
Maxillary start. And
This
then
is the V2. If this is the V2, that's the maxillary. Any bone above the V2 is the maxillary strut.
inferior orbital fissure area.
Inferior?
Orbital fissure.
Oh, sure. Give me the ball probe.
Ball
See,
probe.
I'm going to press the orbit. You see the press the orbit now.
Yes.
See that?
Yes, we
Yes,
can
sir.
see the movement.
Movement is.
Yes.
Can you see? I'm pressing the
Yes.
orbit.
Yes.
Clearly seen.
Yes.
Can you see that?
Yes.
Hey, press the orbit, man.
Yeah.
Can you see, sir?
Yes. Very clear.
Remove this completely here.
Yes.
No tumor. So this is the kind of examination. See, removing the major bulk of the tumor, I think most of them will do. But examining the cavity and ruling out any residue, small residue, is I think the most important part nowadays, because now more and more revisions are coming. So you should see that you remove it completely. This is my carry home message to most of you. Nasopharynx, you should not leave behind residue. For that, don't use coblation here. Use the rolling up and rolling down technique. See, that's the buccopharyngeal fascia and pharyngobasilar fascia.
Yes.
This is the basi-occiput, basi-sphenoid region. You can see here. See, this is the kind of examination you should do after the surgery.
Excellent.
No point in saying I have done the surgery. Okay, fine. You can do the surgery, but after the surgery, examine all like sinus tympani, facial recess, all the small areas. See, this is the third molar. Can you see here? The bulge. So we have not disturbed it. See, the small boy, no. Maybe second molar or whatever. There is a bulge here. You can see the maxillary sinus. So we have clearly, completely removed it. There is no chance of recurrence. Now, finally, you press and see whether tears are coming. The boy is crying or not. Yes, the boy is crying. Can you see? The boy is crying.
This NLD in a flush
That
with
means
the
nasal
inflow of
lacrimal
water.
duct is patent. Okay, so thank you very much. I think
One through the optic nerve. Optic
Excellent,
nerve.
Janakram.
optic nerve is here.
Fantastic.
Once.
Excellent, sir.
So there is one more question from the
This is
virtual.
the carotid artery. See, the carotid artery is the lateral opticocarotid recess.
Yes, sir.
And this is the optic nerve. Can you see here?
Yeah.
Can you see the optic nerve? Here,
Yes,
here.
yes. You can see the bulge. Yeah.
Superior orbital fissure area, sir.
Venkatraman Reddy Garu.
Yes, yes. Yes,
Is
sir.
it there or
Excellent,
not?
sir. Super.
So there is
The optic nerve, carotid
Yes,
artery,
that's optic.
lateral
Optic.
opticocarotid recess.
Yes. Sphenoid.
The carotid artery, that's the sella here.
Yes, Allah.
So this is the paraclival carotid. So this should be the VDN going towards like this.
Yes.
VDN is always inferolateral to the paraclival carotid. Always remember
Yes.
that. Inferolateral.
Yes.
Don't go medial to it. You will hit the carotid. So this is going like this, like this. It's pointing towards the horizontal carotid. Okay.
All the landmarks and the suspicious areas of JNA have been all cleared.
Yeah, very important. As sir says, we have to see the suspicious areas. Correct. Sinus, tympanic, facial results. Same thing. All the suspicious areas should be seen. Thank you very much, sir.
Thank you.
Thank you,
very
madam.
much.
Wonderful
Thank you, sir.
anesthesia. She has given some. Hey, show this. Show this. You see what is the BP she has given? See. See, madam has given. Can you see? Can you see?
Yes, sir.
Yes, yes, we can see.
Ideal situation for the surgery.
So I thank anesthetist
73.
team also.
History.
Wonderful anesthesia. Thank you, madam. I will see if I can post the next case. I'll just see the tomorrow's case and then I will plan.
Sure,
Yes.
sir. So there is one more question from the virtual platform. Can I?
Hey, can you get the MRI of that patient, tomorrow's patient? The clival hemangioma. This one, huh? Okay. 1 second now. See, hello, are you able to hear me?
Yes, sir.
Yes, sir.
This is the MRI of tomorrow's case. I don't know if I can demonstrate it because it's been referred one of the top-notch centers in India. Patient is coming, operated twice, and already patient is presenting with bleeding, severe bleeding. And you can see here. Now, when we go here, maxillary sinus here, can you see focus?
Yes. Yes.
The lesion is starting here and going towards the frontal lobe. Okay.
Yes.
There is no bone between the frontal lobe, only the dura is here. And you see the clivus. This is hemangioma. Operated twice as hemangioma. You see hemangioma.
This is a contrast study, sir.
This contrast, MRI contrast. See the carotid artery. See, complete hemangioma is here. I think we'll do it tomorrow. Only thing is this one, we'll have to take a pericranial flap. See, the patient is blind. Both eyes are blind. See, hemangioma extending towards the parietal bone. Can you see the parietal bone?
Yes.
Hello?
Eroded parietal bone.
Not eroded. It's full of hemangioma. Hemangioma inside the parietal bone. And it is, of course, this one I will not remove. I will remove this because the patient is presenting epistaxis. We will try to clear it tomorrow. Tomorrow is the ultimate case. But today we have another. Would you like to see another case or we will stop here?
Yes, sir. We want to see the another case.
One
That
more
is
case, sir. One
Yes,
more.
sir.
Beautiful case. But I'm going to take a biopsy, but it's a fantastic case. I think we'll start the other case. Other case is posted there. We'll start, madam. We'll start. Can we start that case? Yeah. Shilpi, can we start that case? Shilpi, can we start? Okay. We have any questions? We can answer the questions,
So there's
and then we will start the next case.
one question from the virtual platform, sir.
Hello.
So there is one question from the virtual platform.
Yeah. We can ask both virtual as well as platform from our
Sure.
audience.
Sure. So why ethmoidectomy will be difficult after Denkers? Why ethmoidectomy will be difficult after Denkers?
Ah, good. See, when you are doing the denker, what will happen is you reach the upper part of the maxilla, right? You reach the upper part of the maxilla. If you have reached the upper part of the maxilla, the uncinate, see the uncinate, what happens? The uncinate is the part of the inferior part of the uncinate landmark is gone. The inferior part of the ethmoid is also gone. So to find, see, from the uncinate, we are trained to get into the ethmoid. This is how we are usually trained and FES. So for a beginner, of course, if you are expert, you can do anyway. But for a beginner, start uncinectomy, bulla, ethmoid is always better. Virgin area, it's better. But if you have already done a denker, you don't have the uncinate process, you have taken a part of the bulla, you will be lost. That is why I always say, don't do an ethmoidectomy. I mean, if there is space, if the JNA is not occupying the ethmoid, don't do the ethmoidectomy before you do the don't do the denkers before you do the ethmoidectomy. Because if you do that, you lose the anatomy. This is why I say that.
Janikram.
Any other question?
Are there any observations from your side, like predicting the recurrence, looking at the histopathological pictures, like vascular component versus fibrous component?
Sir, my recurrence has always been dependent upon the site. My recurrences, my own personal recurrences have been purely site-based and not histology-based. Site-based means what are all the sites I have personally seen in my own case, as well as the other, I will tell you, we have published that also. The commonest site of recurrence in our case was the pterygoid wedge. This is the first. So that means initial cases, I never used to drill the pterygoid wedge fully like this. Number two was superior orbital fissure. Because I was a little scared initially when I started, that was one area which I left behind. Number three is parapharyngeal space. Parapharyngeal space, I never used to, properly examine, and especially the lower parapharyngeal space. Number four is pterygoid fossa. That is transpterygoid space. Sometimes we leave behind the tumor. Number five is around the carotid. So these are the 5 areas. Nowadays, I have improvised myself. Consciously, I see pterygoid wedge. Consciously, I see the superior inferior orbital fissure. Consciously, I see infratemporal fossa, pterygopalatine fossa and all easily will remove 100%. But certain like sinus tympani and facial recess area, these 5 areas I feel. Number 1, pterygoid wedge. Number 2, superior orbital fissure. Number 3 is any bone marrow, greater ring of sphenoid, clival marrow, any marrow spaces are always sites where it can recur, especially infiltrative variety of JNA. Number 4 is parapharyngeal space. Number 5 is around the carotid artery. Of course, around the carotid artery, sometimes the patient says, sorry, sir, I don't want you to remove because I don't want morbidity, then I will leave it behind. Wantonly, I will leave behind. But having said that, from others, when I get patients, recurrence, then I have seen again commonest site of recurrence, pterygoid wedge. That is why I keep insisting, when you finish a JNA, you should see the median nerve. If you have not seen the median nerve, you have not completed the surgery. It is like seeing the sinus tympani at the end of cholesteatoma involving sinus tympani. If you have not seen it, 100% it's going to recur. So this is the commonest site. Apart from that, many other sites, orbit, superior orbital fissure, all these we have seen. But the commonest site, we can easily do that. We can remove it from the pterygoid wedge.
Sir, any malignant transformations in your series?
Generally, no, sir. I have never seen, except for one patient where it was irradiated, young boy, and it was irradiated outside, and he came and we did, and it was a sarcoma. It was a sarcoma, but it was irradiated, and they had done 6-7 surgeries, so many things. So maybe it was a sarcoma before also, I don't know. But when I sent it for a biopsy, it was a sarcoma.
Thank you, sir.
Any other question? Dr. Krishna Kishore, sir,
Any
where are you?
role of role of post-op radiotherapy in any of these situations?
Yeah, very important question. Very nice question. See, suppose the patient doesn't want any mortality, morbidity, and he says, boss, I don't play with the carotid. You may be an expert, don't play, it's my life. Then we leave behind wantonly certain areas, come out. Then what is the option? You have to give. First, I try flutamide, tablet flutamide. If it doesn't work, we definitely send for radiotherapy. But radiotherapy, sometimes you can develop keratoconus fistulas also. So that is something which is to be taken. And also you might develop blindness, and all these complications of radiotherapy are there.
Right. Thank you.
Thank you, sir. Shall we study the scan of the next case?
Yes, sir, please.
Okay. Get me the next case scan, please.
So what
Very,
is,
very interesting.
what
This
is the
case,
dosage of glutamine?
very interesting
Glutamide.
case.
Glutamide.
Yes, tablet flutamide, yeah. Tablet flutamide, we give 100 milligram for at least 6 months or so. It's something like danazol. It's actually a androgenic, anti-androgenic tablet. And we give that. Yeah. So I'm going to read the next case scan. Very interesting case, because this case was referred from NIMHANS, which is the Mecca of neurosurgery. And I am really thankful to the professor of NIMHANS who phoned up. And I am thankful to Kumarasamy sir for this excellent, extraordinary case. And just see this case and you will understand why I am telling this is extraordinary. Where is the scan? MRI? Low. So I will try to finish it fast. I'm just going to take a biopsy and then I will plan for a proper surgery later. But you just see this case.
Sure, sir. Thank you.
So how is the audience? Any all went off? Huh? Once you give live relay, nobody will be there. I'm telling you. That is why we should not give web link. You boss, where is it? Where is the MRI boss? You got it now. You took it off. Huh?
So by that time, you will like to have some talk from your side on today's program.
Yeah. First of all, I actually wanted to talk. Really a great program by Sun. Sun is always shining, and Sun has shown that it will shine forever. Very beautiful program, very nice arrangements, and especially the cluster sitting. I loved that cluster sitting. Relaxed way to enjoy and see, and all the arrangements were done very nicely, elaborately. I really thank. It's a purely academic program, as we know, and we have had the best of the best people operating. Dr. Nupurji, we saw wonderful surgery. Then we saw Dr. Kirtane sir, and I am expecting him anytime now. He will come. And please, my dear friends, stay back for the gala dinner. We have arranged some nice dancing and enjoyment in the night. All this we missed during COVID, and we have to catch up on all that.
So we will be waiting to see the other side of Dr. Janaki in the
Not only other side of me, you please see other side of everybody. Everybody will start. I am going to pull Dr. Dwaraknath Reddy Garu and Krishna Kishore Garu on the stage and make them dance, you see. You ask them to talk. Why are you asking me to talk? You ask them to talk. Dr. Monica is also there, I think, secretary of AOI, and she's a very dynamic young secretary. And please ask her to talk. If she's there, I don't know if she's there.
Hi, yes, sir, I'm here. I'm watching you and
Okay. Madam, you should talk, madam.
sir, I'll ask you questions in the evening. So please come soon in the evening.
No, this is just a 30 minutes case. 30 minutes.
Yeah.
Hey, where is the MRI, my
From
dear?
the audience and all the respected doctors, if you want to share your thoughts, please feel free by the time we have the MRI and next patient waiting. Dr. Samir, you will like to...
Thank you, Shilpi, for the wonderful...
Sir, mere.
Anybody wants to talk or shall I start?
I think you can go ahead with Dr. Jani.
Okay. So this patient history you tell, Bhavya. Who knows the history? Come on, quick. Who knows the history? Shilpi, come. Tell. Huh? Purva, you know the history, you can tell. Who knows the history? Shivkumar.
Yeah. Yeah. It's nice to have you here, Dr. Janikram. We are very excited to have you here in Hyderabad, rather. The beneficiaries are too many, I should say, especially the residents and other trainees at different levels. I'm sure they will be very much benefited by your regular academic sessions and your teaching, your teaching methodology. Yeah, we welcome you wholeheartedly to this Hyderabad. Thank you.
I need your blessings. Yes, sir. I've been a teacher for the past 20 years and I would continue the same. Yes, you can go ahead, Shiva, with the Purva madam.
Yes, sir. A 58-year-old male patient who is a known case of non-secreting pituitary macroadenoma underwent endoscopic transnasal sphenoidal pituitary macroadenoma excision in 2017. The patient gave a history of left temporal hemianopia. Post-op, it was uneventful and patient was under regular follow-up. Now the patient presented with left-sided dental pain since 3 weeks with a history of decreased sensation over left cheek and left upper jaw since 3 weeks. Double vision in the right eye since 2 weeks. Patient underwent plain MRI brain, PNS and brain. I would give it over to Jankiram sir to discuss the radiological details.
Okay, so I think you got the history. The history goes like this. The patient was operated for a giant pituitary macroadenoma. And of course, they have done a great job in NIMAMS. It's the mecca of neurosurgery. But what happened is that the tumor was very fibrous over the carotid, completely fibrous. So anybody encountering a fibrous tumor on the carotid would never try to go and fiddle with it. So they have left it behind. Of course, I would do the same. But what has happened now is that the patient, after a few years, has developed a completely different lesion. And that lesion has caused the sixth nerve palsy, has caused V2 palsy, a V1 palsy, and also something related to the cavernous sinus infratemporal fossa. And he's got a big lesion. You can see, I'm going to read the scan. You can see here, that is the sphenoid. He's been operated transsphenoidal. So you can see that's the septum. That's the septum. And you can see there's a middle turbinate. And I think that has been resected a little bit here. And you can see the mass is starting here. Can you all see that? This is the maxilla here and the mass is starting posterior to the maxilla. Can you see? Hello? You have to say yes or who is the moderator?
Yes, sir.
Who is the moderator? Who is the panel?
Panel is sitting and just
the same panelists, sir, who were for the last case.
Okay. So you can see there is a mass here going right till the orbit here. And you can see the huge mass involving the infratemporal fossa, pterygopalatine fossa, involving the sphenoid sinus. And this area is actually maybe the pituitary tumor. This is the pituitary tumor. And there is another lesion going on both sides towards the foramen lacerum. That's the foramen lacerum. And you can see that is actually a huge tumor here. And the complete nasopharynx, the clivus is involved. You can see that's the clivus. This is the complete involvement of the clivus. And you can see it's going right. That's the basilar artery. That's the vertebral artery and basilar artery. It is sitting right over the dura of the vertebral artery. And it's involving the hypoglossal nerve on the right side too. So this is actually the hypoglossal nerve. You can see that's the hypoglossal nerve. And it's going right till the hypoglossal canal. And it is involving the whole of the basiocciput, basisphenoid, going till the level of the atlas vertebra. This is the dens. You can see that's the dens here. And it's going right till that. So here is a lesion involving the lower clivus, the mid clivus, and a part of the upper clivus as well.
and going towards infratemporal fossa, pterygoparietal fossa, both sides of the nasopharynx. Very sinister lesion. So what will be the differential diagnosis? So pituitary tumor operated already, but now this is the lesion, and anybody can opine on this. I want inputs from you.
Sir, could it be some form of a malignancy?
Yeah, so that is the first diagnosis I also think about. So very, very true. But what is the duration? Duration is more than 6 months. So,
Sir, looking at the enhancement with contrast, it looks pretty irregularly enhancing tumor. So, what should it be?
yes, I fully agree with you. I also think first because sixth nerve, fifth nerve, everything gone. So I would definitely place my diagnosis as a malignancy.
Can it be cranius, sir?
No, the second diagnosis I would like to put forward is a fungal sinusitis. So you can have an irregular, see, as sir noticed very clearly, irregular margins. See the irregularity of the margins. And see the involvement of the infratemporal fossa. Very, and see the massive erosion of the clivus going till the vertebral artery. These are all something which is eroding the bone and aggressively involving. But the patient at the moment is walking, except for a sixth nerve palsy and a fifth nerve palsy. And you can see here, this is completely involved. But the neck nodes are nothing there. No neck nodes. So that is what was very sinister. Why no neck nodes? And why only... so, see, there are three differential diagnoses I had in my mind. Number one is, see here, this is, first is malignancy. Second is a fungal sinusitis. Third, an invasive pituitary itself can present like this. So, when I correlate this with the previous, this one, the pathology, pituitary macroadenoma, I've seen invasive pituitaries going to the clivus. I've seen invasive pituitaries going right till the level of the pterygoparietal fossa. So, because I've done more than around now 950 cases, I've seen massive pituitaries. Of course, that will be suckable, very suckable. So, once I open up this pterygoparietal fossa or the nasopharynx, wherever I want, I can take a biopsy, either from the nasopharynx or from the pterygoparietal fossa. So, I'm going to find out whether it is suckable. If it's going to be suckable, I'll go in for the kill. If it is going to be a very fibrous tumor, take a biopsy and come out. Do you agree with me?
Absolutely, sir. Absolutely. The biopsy is a must.
So, what is the opinion of all the panelists? Any other opinion?
Is there any pathology which can be initiated by the previous surgery?
Diplopy is there.
What?
Any pathology which can be initiated by trauma due to surgery? Any other aspect like that?
Trauma to previous surgery. What? Like what? Like what are you thinking?
Must confirm the histopathological diagnosis, sir.
Yeah. So you see, this is something very sinister, sir. You see that small lobulations here?
Yes.
It can be meningioma.
Yes.
Yeah, very nice. Yeah, it can be a meningioma. Very nice. So that lobulation is a little sinister. It can be a meningioma.
This is patchily enhancing.
Huh?
This
What?
looks like patchily enhancing. I mean,
Yes. It's enhancing, but it's not uniformly enhancing, right?
will meningioma be patchily enhancing, sir?
Yes, very much. Very much. And I am suspecting a pituitary adenoma also like this. Because you see, what happens is that, I mean, you can have a spectrum of diseases. First will be malignancy only, but with this, why no node, sir? Why no node?
That's right, sir. But actually, there should have been at least retropharyngeal nodes.
No, there's no node at all. So, is it an interesting case, sir?
Absolutely, it's a very, very interesting case, sir.
Yeah, that's why I thought, okay, let me show at least the biopsy and I will get back to you. If it is going to be suckable, then that's it. I will go for the kill. So I'm just waiting for it to be a sort of a liquid tumor. Let us see.
So will you stay back with me? I will, if it is going to be a heart tumor, time taken will be around 15 minutes. If it's going to be suckable, around 45 minutes. By 6 o'clock, I'll be there with you.
We are there with you till 9 o'clock. No issue, sir. You just continue.
But we need to do the banquet, sir. Gala dinner.
No problem, sir.
Okay, I'm going to the other
Post
theater.
chair, post-
Thank you.
Gala dinner morning 6 వరకు.
Morning 6. Super, super. Where is Shilpi? Shilpi?
6:30 అయిపోతుంది. Fast గా చేస్తాం.
As we having some time, I am taking this opportunity from Sun Pharma team and Docomo team. Myself, Dr. Archana, we are giving you one form for the feedback and request to fill in the form. And at the end, there are two open-ended questions about your feedback for the program, which scientific topics you will like to have it in future or any suggestions for the current program. And the second part is about any product suggestion, because we being a company like Sun, if there is any requirement for any particular product, molecule, or any new formulation which you feel can be helpful in clinical practice. So our request from Sun Pharma team to please feel free to give the suggestions. Thank you. Dear audience on the virtual platform, because here we all are aware in hall that sir is inducing the next case for the interesting case which he just mentioned about. He will be doing the biopsy, and by the time he will again connect on video, we may have 3-5 minutes if you want to take a break, because it was really tiring for all of you. Since morning, all of you are sitting at one place. And from our side, I will really want to say sorry, because we could not take few questions which audience had given in the first and second sessions, Kirtane sir's session and Dr. Pratimesh sir's session, because of the constraint of time. And we had committed that we will try to take it in evening, because those two experts are not available right now. We cannot take those questions. So please excuse us for not taking those questions from your side.
With the permission of the chair and our Dr. Jankram sir, there are many seniors in the auditorium. Can they explain any bad experience with pituitary and JNS? I may attention to the senior surgeons in the hall. Any bad experiences in your practice with the pituitary or JNS? Anybody with in this small break, with the permission of the chair and the chief of the faculty?
Yeah, we had a case of nasopharyngeal angiofibroma post-operative period. We had a diffuse ooze, persistently diffuse ooze, but we could not figure out any mass lesion there. So we did not have any other way. Then we were advised to send for radiotherapy. We sent it to NMJ Cancer Hospital. They gave some subclinical doses, and they controlled the bleeding. That's one case. Of course, another case, I think it is from another unit. The patient had come with a profuse bleeding. Maybe it might be a carotid blowout, I think. I don't know the details, but it was an NPF that was operated some time back. Yeah, that is another case. Yeah.
Dr. Krishna Kishore Garu is the very senior surgeon doing highest number of cases of cochlear implants in Visakhapatnam, in Andhra. Can you share some experience in the cochlear implant surgery difficulties?
My God, you are dragging me into a different area. It's cochlear implant surgeries, as you all know, it's a very Just like stapes surgery, it is also a tightrope walking. The most important aspect of it is to be able to perform a good posterior tympanotomy, wherein, as you all know, the facial nerve is the main thing there. So you need to learn the good technique. Of course, some people perform the various technique also, but I'm used to use for this posterior tympanotomy technique only. It is very much varying in its dimensions, and you should be able to make out the difficulties. And my advice to the youngsters is, whenever you perform a modified radical mastectomy for cholesteatoma cases, you better perform a posterior tympanotomy before going for the canal wall down technique, so that you will get well versed with the how to expose the posterior tympanotomy, and to expose the round window. The key. See, the facial nerve decompression is a different technique. We all do facial nerve decompressions, but when it comes to cochlear implant, the angulation and the wing, the trajectory is entirely different, because you are going to work out with a very thin down posterior bony canal, and removal of the bone towards the facial nerve as much as possible, and defining the cordofacial angle. And the key is you should always be drilling more near to the incus buttress, just to leaving 2 mm of that is incus buttress. That is the area which is safe area. If you are starting your drilling down, you are more likely to land up on the facial nerve. So just 2 mm from the incus buttress, that is the safest area. You have to go more of an anterior direction of drilling, flattening the bed there, and then you will enter into the, if you are lucky enough, you may find the sentinel cell, you can open up nicely. Sometimes you don't find the sentinel cell, rather all of that area, first the facial recess area is completely sclerotic bone sometimes. So then you have to be very, very careful about that. Okay, sometimes you may find difficulty in exposing the and locating the round window niche and all. Sometimes there may be a lot of edema and all that. So you will learn that as you go on doing that with the good decongestants and all. You have to dissect off all the edematous mucosa. Then we'll expose the bony niche. Then there may not be much problem. Nowadays, mostly majority of us, we are doing the round window insertion only. Earlier days, in the beginning stages of cochlear implant surgeries, we used to perform the cochleostomy. So in the cochleostomy days, unless you know the perfect way of doing the cochleostomy, I mean to say the positioning, you may sometimes go into the scala vestibulae. So you need to position the cochleostomy properly in the proper. So nowadays, lucky that the technique has changed, and now we are going more by the round window insertion technique. So once you are in the round window insertion technique, means you are sure that you are going to be into the scala tympani only. Okay, that way. Yeah, that's how we go with this thing. Anything you would like to know, you can ask me. Yeah.
Sir, Dr. Subramanian garu, your experiences in cochlear implant surgery, JNA? Yeah, yeah, okay. Sir, your experiences in skull-base surgeries and any, especially JNA?
Yeah, I don't know whoever is hearing or not. I don't know. Anyhow, about the JNA surgery, as Kishore knows, and we all started very early, quite early. In year 2000, I have presented my work in Washington, D.C. My presentation was endoscopic approach for the synovial tumors. In that, I have presented JNS also. In those days, there was no coablator, no debrider also. Before 2000, we have not been using all those things. Not even insulated suction cannulas. So I have developed my own instruments, insulated the suctions, bent some instruments, used some ear instruments, insulated them. And I have classified the tumors and approaches also I have designed for the tumors, because the tumors surgery, those days, very few have been done, especially for inverted papillomas, people have done by that time throughout the world also. So JNS also we have done at that time. So I used the insulated triangular knife, picks, all those things. And I have told the surgical approach techniques like lateral avulsion of the turbinates, resection of the turbinates, and posterior septal resection also. I have mentioned at that time. As far as I remember, there was nobody described as a septal resection for tumor surgeries in the sinuses and all at that time. So feel happy for that, being one of the first few to do that, all these approaches. And later on, I've gone up to the maybe up to the just abutting the tumors, abutting up to the cavernous sinus. Even afterwards also, I have not gone much beyond that. I have gone to the pterygopalatine fossa, infratemporal fossa also limited. So for reaching these tumors in the lateral compartment like pterygopalatine fossa, infratemporal fossa, I have mentioned the surgical approach like medial maxillotomy, inferomedial orbitotomy, those days, and then transmaxillary approach to the pterygopalatine fossa after doing a medial maxillectomy and all. Those were the instruments I used. And later on now also, I use them as Jankiram showed now to do the posterior septal resection. I use my same instruments, the insulated triangular knife and picks. I can do a bloodless resection of the septum, posterior part, using those. I now combine all these instruments, debrider, coablator. For doing the modified Denker, I use goose also because we can remove the bone very fast. Use the coablator for the medial wall mucosal ablation. Use the debrider for the turbinates, inferior turbinate removal. And later on, I use the goose for the removing the angle of that maxilla, medial, inferior angle bone. I break it. Once we break it with the osteotomies, directly it will go up to the lacrimal duct. Straight away, the bone will come out easily with the using that goose, and the lacrimal sac will be seen like that, and then resect it. So then I've been watching Satish Jain and Janki Ram. They have gone much beyond into the cranial cavity, the cavernous sinus, and all those areas. And I'm learning now from them. And I've been doing, now the number is not so much from like them. So I can say definitely they are very versatile, very much confident, and we can all learn from them now onwards. And based on my own earlier experience with all these things, I think I can pick up faster from them. Thank you. Thank you.
Humble words, sir. We know that you have your own expertise. So you saying this is a big thing, but the expertise from you all is also a significant contribution for the therapy and society. Pleasure, sir. Honor for us.
Madam, Can you speak to the auditor, OT? Yeah. No, not to sir. If any other people are there, you can contact.
మీ ఎండోస్కోపిక్ టెక్నిక్స్ మైక్రోస్కోప్ ఉపయోగించాలి.
Most of the case may be ended with the biopsy.
Manipulation కష్టం. ఇదంతా అవాయిడ్ చేస్తుంది.
Okay. So why they have not started the camera?
PG చదువుతున్నారు ఒక కేసు చేసి
Next egg biopsy करेंगे. हो जाएगा.
మైక్రోస్కోప్ లారింజియల్ బయాప్సిస్ సెప్టోప్లాస్టిస్ టింబరోప్లాస్టిస్ అన్ని మైక్రోస్కోప్ ఎండోస్కోప్ ఇక్కడ సెప్టోప్లాస్ట్ ఐఎమ్ డూయింగ్ విత్ they will do I'll still from behind them and I am directing ఈజీగా ఉంది మనకి పీటీకి డైరెక్ట్ సెప్టోప్లాస్టిస్ వాళ్ళు ఎట్లా చేస్తారు ఎక్కడికి వెళ్తారు పోస్ట్
Dear audience, thank you for being patient for these minutes. Already the patient has been taken to the OT and they're inducing the patients. So it may take around 2-3 more minutes so that patient is stabilized and draped. And we will start the live second case also for the the biopsy of this interesting case. As we have time with us, I will like to thank our other partners, AOI Hyderabad branch, Dr. Janaki sir's team significantly contributed in this program, and Royal Pearl.
Can you hear me?
Yes, sir, please.
Dr. Nageshwar Rao garu.
Yes, sir. Yes, sir. We are all with you, sir, waiting for you.
No, you are all not with me. I know
No,
all
sir,
is
no,
empty.
sir, we are all with you, sir.
All is empty, I know.
Yes.
Anyway,
Yes, sir.
we will start the next case.
Yes.
Where is Shilpi Bhatia Sharma? She's washing up. Okay. You are having a joke, or I can take part in the joke also.
So what is your plan, Janki?
Sir, there are two ways I can plan in this case, sir. Number one, I can go through a modified endoscopic Denkers and examine the infratemporal fossa and then go from there. Or I can go from the nasopharynx. I can directly go see how the tumor is and I can go from there. So I think I will go endoscopic modified Denkers here. And that way I can also show technique of endoscopic modified Denkers. And then I will open up the sphenoid sinus and we will see how we can deal with the carotid artery. This is what I'm planning in this case. You have any idea, sir?
Sir.
How many people are there in the hall, sir? Maybe 10 people?
No, 50 to 60 people. 60 people, sir.
Hall.
60
Oh,
people
that's-
outside, 10 people are taking coffee.
Okay. Sudarshan Reddy Garu is there, my brother.
This hall 60, the other hall
Is there? He very much there.
Other hall also there.
He is very much here, Dr. Sudarshan Reddy. He is here only, very much.
Dwarakanath Reddy Garu.
He left. Yes.
Now I will ask by name only now.
Dr. Mohan
Acharya Garu.
Dr. Mohan Reddy is
Acharya Garu.
here. Dr. Mohan Reddy is here.
Oh, Mohan Reddy, sir.
Shyam, Dr. Shyam, Dr. Subramanian,
Wonderful,
Dr.
wonderful.
Vishnuvardan Reddy, Dr. Anand. Many
Sir.
people are the big, big people of
Sir,
Hyderabad.
it is a blessing, sir. Big blessing, sir.
Yeah.
What more I can say?
Yeah.
Biggest blessing.
So the mic.
Hello,
Yes, yes, yes.
Dr. Shyam here.
Shyam Garu.
What is your plan to excise or only biopsy?
Sir, as I told you, it depends on the consistency, sir. If it is going to be liquid, no, I will go for the kill. If it is going to be firm, there is no point. I have to see what it is, no.
Okay.
If it is looking like malignancy, then I will take a biopsy, extended biopsy, a little more than a biopsy, and come out. Is there any other opinion from the audience? Do you want to ask the audience?
If you had a frozen section, would your opinion be still the same?
Sir, wonderful question. Wonderful question. That is the first thing I asked here. But unfortunately, that facility is not available here, sir, in our hospital.
Yes, yes.
But 100%, I agree with you. 100%. If I have the frozen, completely I will change the modality. Because if it's going to be fungus, I would have gone in for the kill anyways. But I don't have that facility here.
So
Wonderful, wonderful observation. Wonderful observation.
This is Dr. Subramaniam.
Oh, hello, sir.
Actually, the same thing I want to ask. If it is available,
Sir, you are not audible.
Switch on, James, please. Okay, I'll just give this mic. Please.
hello.
Change the battery.
Yeah, he is on. Same thing I want to suggest.
Yes, sir.
The frozen is available. You can plan for the treatment immediately also. Now we have to wait for the report to come.
100%, sir. I agree with you.
Yeah.
But unfortunately, I am operating in a new state. And really sorry about that. I agree with you.
No, there are so many issues are there. But everyone is mesmerized by your surgeries.
Sir, I need your blessing, sir. I'm really sorry.
Thank you.
Wonderful, wonderful observation. Frozen proceed is the best. But unfortunately, first thing I asked, do you have frozen? They said no. Then what can I do? I can't do anything.
Because in the COVID time, when we were doing a lot of surgeries, we used to confirm by the time we take the biopsy and proceed. If the report comes, we used to do decompression or other things. So it's really a good tool if you have. Otherwise, there's no problem. We can wait.
Wonderful, sir. Wonderful. I fully agree. 100% agree. But as I told you, there's a shortcoming.
Before you start, yes, I wanted to ask one question. In the
Yes, sir.
nasopharyngeal fibroma, in a recurrent case, what is your mode of treatment? What is your approach? Your experience in a recurrent nasopharyngeal angiofibromas?
Recurrent, there is not much difference, sir. Actually, I will do the same. Only thing is the planning, where it is recurrent, where is the recurrence, whether it is in the pterygoid wedge. Only thing I will plan is whether it is in the carotid. If it is in the carotid, external carotid ligated, these are some challenges. Previous external carotid ligation done means it can get it from the internal carotid or the other side. So these are the challenges I would like to see. Apart from that, if it's going to be just a recurrent JNA, I might not change my internal carotid artery, then it's a different ball game. Then I will be thinking about BOT, coiling and things like that.
Generally, in the workup phase, we go for CT angio in all angiofibromas or just go for only plain contrast CT scan only?
I go in for, sir, just for the sake of juniors who are watching around India, in a CT contrast, there are two phases. One is called the arterial phase, second is called the venous phase.
Yeah.
And we should always ask the radiologist to get the arterial phase in a case of a JNA and the venous phase in case of a glomus. So these are both venous and arterial phase in case of glomus, because we have to see whether the sigmoid sinus and lateral sinus are patent on the other side in glomus, whereas in JNA we are not bothered about that. So we have to go in for the arterial phase. If you have the arterial phase, then if you think it is only the external carotid artery territory, which we have clearly told anterior to the pterygoid wedge. So the pterygoid wedge is the watershed zone. Behind it, you can have a supply from the internal carotid. Then I will go in for a DSA. Then I will go in for whether it's supplied by the internal carotid, which branch of the internal carotid and all this stuff. But if it is anterior to the watershed zone, I will go ahead just with the arterial phase CECT.
Okay.
Dr. Janikram,
Yes, sir.
like we are planning for extended biopsy, right?
Not
Increase the
sure.
yield. I believe it is to increase the yield. Am I right?
Yes.
Okay. Other day I was talking to one Dr. Nageshwar Reddy from Asian Institute of Gastroenterology. They are using contact endoscopy, like use the printed histopathology. It seems they rely on that. So,
sir, I have been using contact endoscopy for 20 years. I was one of the first to use contact endoscopy in India.
Okay. So nice.
So I have extensive experience on contact endoscopy, but it is not very useful, sir. Honestly, it is actually a surface microscope given by Karl Storz. We have two magnifications. One is 6 and another is 10. And I mean, for maybe it's the pathologist, first of all, the pathologist should come inside the theater. So we did a study. The pathologist has to come to theater. Number two is the stain over that contact should be the proper stain, or else it doesn't work properly. I can show you the contact endoscope. Maybe in the next workshop, I'll show you a complete use of contact endoscope. We have written 3 or 4 papers on that, but still we didn't publish it. But as you say, contact endoscope is good, but nah, I'm not very impressed with that.
Okay.
I've been using it for 20 years.
In that case, what is your opinion about narrowband imaging?
Narrowband imaging is different. That is super. That is for the larynx. It's very good. I think the Rakesh Srivatsao sir keeps talking about that narrowband imaging. Yes. Now the Rubina camera, that also is good, but somehow I think nothing to replace frozen and pathology. What do you say? I don't know. What is your opinion?
Dr. Janki,
Yes, sir.
What is your investigative protocol for all this kind of situations, whether it be JNA or some other tumor, sinonasal tumors? Investigative protocol. I mean to say, when you go for the CT scan, when MRI, when DSA, how you are going to decide over these things?
Sir, one thing I will always tell is that I always tell this to my fellows. Hey, what man, you wash up, man. What are you? Whatever investigation you are taking, it has to give a complete information about planning your surgery. There is no point in having an investigation just for the sake of investigation.
Yeah.
This is very clear. For example, in a CT scan, if you take a sagittal cut, imagine you are taking a sagittal cut for a JNA. What is the use of I am asking you, what is the use of a sagittal cut? There is no use. To me, I think if you want to see a sagittal cut and plan, I think that guy can't plan. Please understand that very, very clearly. If you take an axial cut for a skull-based tumor, we can't plan 100%. If it is in the brain, the pituitary or the cranial, I can't plan. But if you give a coronal cut for the neurosurgeon, he cannot plan.
Yeah.
You just give the coronal cut to the neurosurgeon and say, you'll be totally lost.
Yes.
So I want, because I'm going through the endoscope, endoscope goes in a coronal plane.
Yes.
So we need coronal cuts. That is the most important cut for us, because our whole orientation is throughout with the endoscope through the coronal cut only. So point number 1.
Yes.
Point number 2. If you have a contrast enhancing tumor, then nothing like a CECT, thin section CECT, arterial phase. One investigation is more than enough for planning your surgery completely.
Yes.
This is and that too the window setting. See, in this case, they have given me soft bone window setting. What is the use of bone window setting? What is the use of me saying the Unsenet process and Ethmodal bulla in a case of JNA?
Yes.
Absolutely no use.
Yeah.
So when I'm asking, I went to the radiologist now. I went to her, I talked with her. I think some diagnostics, I don't know even the name. Boss, when you take for me, this is what I need.
Yeah.
You give me this. If I can talk with them on those terms, then I will know. We are, I'm not talking about you, as postgraduates, there is no point in simply doing, for example, that hemangioma. Let me tell you the hemangioma. I went to the diagnostic center. They gave me a CT. In the CT, I couldn't find the dura. I couldn't find whether the dura was breached or not. Just to see the dura, I took an MRI. So I should know in that investigation what I am to look for.
Yes.
Or else, what is the use of the investigation? So, for example, a DSA. Let us take a DSA. There will be 10,000 branches going here and there and here and there and here and there. And it look very nice. So much tumor, blush, this and that. Okay. What is the use of seeing 10,000 arteries? Are you going to go and ligate each artery? I am telling you honestly, how many of us can name every artery which goes into the tumor? Or how many of us can bipolarize and no, I am very honest. I can't do it.
Exactly. What you said.
I can't do it.
Yeah.
Okay.
100%.
So what is the use? I want to see whether the tumor is being supplied by the ICA or ECA. Very simple.
Yeah.
If I can get that information through any of the investigation, I'm ready to do it.
Yes.
There is no point saying I'll do this, I'll do that. What is the use, boss? Why you want
Tackling the things intraoperatively. Yeah.
So the surgeon should be very clear about what he is going to expect out of that investigation. Or else there is no use of the investigation.
Yes. Good.
It is as simple as that. This is the answer to the question you asked. I don't know. Maybe I am too junior to answer this, but you can ask the opinion of anybody else.
Yeah, because the youngsters very much confused what investigation to go for, when, and all. That's why actually I put this question. So that
Most important is if it is contrast enhancing, it is CECT.
Yeah.
If it is non-contrast enhancing, best is soft tissue window or brain window setting. If it is fungus, if it is going to be sinusitis, CRS, best is bone window setting. All this is very clear. It has been given in standard textbooks. There's no point doing an MRI for a sinusitis case. What is the use?
Yes, exactly. Yes. Absolutely.
So MRI, when you will do in JNA, I will do it only when I see whether there is that to MRI, I will do an arterial phase in MRI and I will see whether the ICA is supplying and which branch of the ICA is supplying it or whether the dura is breached or not. This is the two information I will get.
Yes.
Other than that, I will not get any information from the MRI.
Hmm.
So we are supposed to be very, very logical. Let us not subject the patient because we have the investigation. We should not do it.
So as a first line investigation, we do CECT, and if needed, if you are suspicious in that study, then you may ask for an MRI afterwards. And that's good.
Parotid, MRI.
Yeah.
Because we have to see the retromandibular vein, MRI.
Yeah.
So each one has got a particular investigation where you will catch it the best. For example, if I want a vascular loop over the seventh nerve, there's no point doing a CT scan. I will do a MRI to see T2 Fiesta. I will write for a T2 Fiesta, go to the MRI console, see whether there is an artery supplying. If it is going to be CSF leak, what is the investigation of choice? I will do CECT along with MRI. I should take an MRI. Why? Because I want to see BAH.
Yeah.
I will never do a CSF leak without an MRI.
Yes. Good.
So like this, if we can clearly make out why we are doing an investigation, we will not make unnecessary investigation. At the same time, radiation exposure, this, that.
Yeah. You should be
Am I
clear
right, sir?
what you are going to expect from that investigation. The clarity should be there. Yeah.
Yes.
Thank you.
So I'm going to start, sir, the next case, a very interesting case. We'll start. Thank you, sir.
Yeah. Thank
Sir, there are two things I want to tell. I thank Vasavi Hospital again for making all the theater facilities almost free of cost. Thank you very much to Vasavi. Second is I thank the head of Department of Neurosurgery Department, NIMAMS Bangalore, which is the mecca of neurosurgery, who phoned up just now and, he inquired about the case. He sent the case. Really, the biggest honor I can ever have is to get a case from NIMAMS. NIMAMS is not an ordinary institute. Dr. Kumarasamy sir and also the head of neurosurgery. Thank you very much, sir. Okay.
Yes, sir.
I want good interaction. Dr. Krishna Kishore sir
Yes,
is
sir.
there.
Yes, sir.
Dr. Krishna Kishore sir, I have fond memories of you in Kakinada.
Yes. We had a
Very fond memories.
wonderful workshops we had, and your
What fond memories.
yes.
With Jason Murthy garu.
Yeah, and
Can you, hey, put up the light, please. Can you see the Sinike, please?
yeah, yes.
Are you getting endoscopic picture?
Yes, we see the Seneca there in the
Oh, see that
bad
complete.
Seneca, very bad Seneca.
Coblation. So
Yes,
the
sir.
Sinike, I am again using the bonds. Hey, Tanni.
aggressive పని చేస్తుంది
Tanni.
బోనస్ చీప్ అండ్ అది కాదు చాలా బాగా పనిచేస్తుంది బోనస్
Sir, this wand is more effective than routine wands, sir.
In my opinion, yes.
Yes, because this cartridging.
Another important things are why, they are bringing the ear wands.
Sir, ear wands.
Ear wands, the Rosens, Plesters and all is coming with the.
Yes, sir.
You see, once it comes, it will revolutionize the market. I just had a trial of that. Ultimate it is.
Yes, sir.
It is bloodless. Endoscopic ear surgery will become totally bloodless.
Sir.
Now you see, I have released the Sinike. I am searching for the modified endoscopy. Sir, it comes for 6 patients for me, sir. 6 cases.
Yes, sir. 6.
This one comes for 6 cases. And it is, I think, 2,000 rupees or 3,000 cheaper.
Lesser than that.
I am not bothered. I don't want to promote, but I'm just.
Yes, sir.
See, when there is something good available, why not we share? That's all. You see, this. So, he gave me the instrument for very less price. I got it for all my fellows.
Yes.
Very less price there. I am ready to tell whoever, see, most of my instruments theater published. Less than half the price.
Yes, sir. Fire farm picture.
Operate
See, so You know that Pentro microscope, huh?
Yes.
You know?
Yes.
Pentro.
Centro.
Pentro microscope.
Sir, voice is not clear, sir. It's breaking.
Hello?
Yeah, now it is clear, sir.
You know this Pentro microscope?
No, sir.
You know the highest in size, boss.
Voice is breaking, Janki. Ask these audiovisual people to.
Hey, boss, audiovisual. See, boss. Very important information I'm giving to the audience. Yeah. And you are breaking my voice. This one.
Yes. Ante.
Hello?
Yes, sir.
See, that Pentero microscope is the highest in size, boss. And the original cost is around 1.4 crores or something like that.
Sir.
I got it for 35 lakhs, boss.
Sir.
And still, for the past 10 years, it's working super. So,
Yes, sir.
if I can use it, why not my colleagues? What is wrong in telling?
You are big boss, you can purchase.
Section. People feel shy when they say I'm using second hand, this, that. I don't mind. What is there? Okay. Now give me this one. No, cobbletter. Quick. More importantly, you see.
Sir.
See, ideal qualities, it should not block. If it goes on getting blocked, no, you get irritated.
Yes, sir.
Elevator. Quick.
Yes. Are you going for biopsy or radical surgery, sir?
No, I'm going for biopsy only, sir.
Yeah.
No, biopsy should be done from intratemporal fossa. I don't want to take some superficial biopsy.
Yes, sir.
The biopsy is right from the intratemporal fossa, pterygopalatine fossa.
Yes, sir.
And once I feel it is liquid, no, I'll go for the kill. If it is going to be solid, as Sir said, I don't have a frozen. So then I will do it tomorrow or day after tomorrow, depending upon the biopsy report.
Yes. We are ready for both extremes, sir.
In the sense, what extreme?
If you do surgery, we will wait for that also, sir.
Nageshwar Rao Garu is ready for anything. I know. Where is Sri Ramurthy Garu?
Sri Ramurthy Garu in Vishakhapatnam, sir.
Is he seeing or not?
He just called me now. And asked about the cases and everything. He is having some cold, I think, sir. Cold and his voice is not clear and he's has some upper respiratory tract infection like.
Oh. Convey my regards, sir.
Yes, sir. Already I conveyed, sir.
I love him.
Yeah, thank you. I just conveyed, sir, already.
If I see him, I'll kiss him, you know.
Yes, sir.
What an educated person. How much he has traveled.
Yes, sir.
Wherever I go, whether Europe, anywhere. Do you know Dr. Srinivas Garu? They will ask.
Sir?
That is the kind of traveling he has done.
Stream. Murthy.
Brand ambassador, I call him.
Broken.
See, I'm not doing a big osteotomy. Elevator. See, I'm just doing a minimal. That's a.
Yes, sir.
So these are all. I think one full day I can take a osteotomies in Denker. See, that's the next.
NLDs.
See here, if you want to preserve Asner, no, you can preserve this bone so that you will not injure the
NLD.
nasolacrimal duct.
Yes,
See
sir.
here.
Yes,
Now
sir.
I can actually, in this case, I will not cut, I will transpose. Come out, come out, come out.
But yes, my time.
Blexley. Blexley, Blexley.
E step.
Good irrigation, irrigation.
Sir, everybody is having some doubts, sir. All over India and other delegates.
Please, sir. You
What
please
is the secret of your energy, sir? Since morning to evening, you are so energetic.
Secret of my energy is Nageshwar Rao Garu. Nageshwar Rao Garu is the secret of my energy. When I have become this one, sir. And another thing, I am a very jolly person, sir. I am very happy, jolly person. I don't want to.
Yes, sir.
Yeah, I'm generally not sad. See, I'll tell you one thing. This Holman Muller, no,
Sir.
he proposed a sign for JNA. Okay, he has told it for JNA.
Bulge in the post wall.
See, this is posterior wall pushed anteriorly.
Yes, sir.
Not specific for JNA. Any tumor in the infratemporal fossa
Yes,
can
sir.
push.
Post wall of the maxilla.
So how can we tell for JNA? I'm asking you, schwannoma also I've seen.
Yes,
Big schwannomas can push. So we should not blindly follow. Blinding follow and all wrong. Hey, coblation.
One, sir. 6 కేసు వాడుతుంటే ఇంకా ఆశయం వచ్చింది మరి.
See the bulge.
Yes, sir.
Sir, another thing, when you are doing Denker, no?
Yes.
Some people use coblation here. Don't use coblation, huh?
Infraorbital
Because
nerve
if you
damage.
use, it will damage the Hasan and the Masan.
Yes, sir.
What is Hasan Masan? Hasan is anterior superior alveolar nerve.
And medial superior nerves.
Correct, correct, correct.
Asan and Masan ante anterior superior nerve, medial superior. Branch of the infraorbital nerve.
Correct.
Divides into 2 trunks.
Either coblation, please. Hey, this camera is not true color, man. That camera is better. Better we go for the original spice instead of going like this. See, when Prathamesh ji used that this one, no, the drill. Nerve monitor.
Yes, sir.
It's a nice tool. I also use nerve monitor. But the thing is, I always tell my residents, once you use the navigation for frontal, not do frontal without navigation.
Sir.
Several countries have navigation, they look frontal at
Sir,
all.
your voice is not clear, sir. Little adjustment needed. Your voice is not clear. Mouthpiece, little adjust mouthpiece, sir. Voice is breaking.
Audio visual. Audio visual.
Now it's clear, sir. No problem.
Give. Coblation.
So this one is alveolar recess approach, sir.
Yeah, you're right. Alveolar recess, but I am not interested in alveolar recess.
Yes, sir.
I just want to go down
Yes, sir.
so that I'm doing uninostril. No, you see, I didn't do the cross coat.
Yes.
So when I don't do the cross coat, even if there is a smaller component, I open it slightly bigger. So these are all small tips.
Yes, sir.
So because I don't want to struggle with Shilpi, Shilpi will say, boss, I cannot show, that's all. Then
Yes.
what will I do? So there are certain things we should always try to. So this is uninostril, completely uninostril technique.
Yes, sir.
And now I will change to four-handed now, debrider.
Sir, can you show with the pointer to the pterygomaxillary fissure area?
Scissors. I'll cut off the nasolacrimal duct. I don't want to. How is the picture quality?
Excellent, sir.
Take it off, man. Take it off. Take it off. Take it off. Okay. Take it off, my dear friend. Blexley. Okay. Now you are asking me where the pterygomaxillary fissure is it?
Sir, with the pointer, sir. Can you
Sure.
show the point? Yes, sir.
Give me the coblation. Suction first, then coblation. Madam, another 15 minutes if it's going to be a biopsy. Then 1 hour if it's going to be a complete surgery. Depends.
Yes, sir. Then I think you will not stop with biopsy, sir.
You are telling your inner mind,
Sir.
Through that you are conveying my mind,
Sir.
You are very clever, boss. You are the cleverest.
Sir.
He is telling his mind through my mind. How is it? That means you do. He is telling you do.
Yes, sir.
Very clever. Thus, see, after doing a Denker, I said doing ethmoidectomy. This is one. You are asking me, is it more? Why it is more difficult? Now you see.
Yes, sir.
Give me elevator. I'll show you. So if I had taken off this completely, then I will lose that uncinate process. It will go off till here. So I'll lose a little bit of this anatomy. That is why I said it is better to do this, then come here and as usual we'll do it. Of course, now I have not yet removed all that. Blexley. Okay. Give me a pack. Okay, done. Now I'm going in for the kill. That is going for the posterior wall of the maxilla. I'm going to find. I'm also very inquisitive to know what the tumor is going to be like. As inquisitive as you. And I think the professor of neurosurgery is watching from Bangalore.
Yes.
Thank you, sir. Really, really big thanks to you. Many people use a punch here. I generally don't use a punch. Come, drill. See, this is uninostril technique. So I might have a little hitch. See how many instruments are going inside.
Wait.
अरे यार क्या बात कर रहे हो लक्ष्मी कहाँ है लक्ष्मी आओ जी लक्ष्मी इज लक्ष्मी give me Blexley please take off this right What happened? Drill. Hey, don't do anything. Go away. Don't disturb. Stay there. See how she's irrigating. This is how we are to irrigate. Irrigation also is an art. Or else you will irritate only, not irrigate. Professor Kasam used to say, my ENT surgeon irrigates at times, irritates more. Okay, you asked about the pterygomaxillary fissure, right?
Yes, sir.
Okay, see here. Come up, my dear friend. See, that's the intraorbital nerve. This is the intraorbital nerve. See
Yes.
here. See the bulge?
Yes, sir.
When you draw a line from the intraorbital nerve vertically downwards.
Yes, sir.
This is the pterygomaxillary
Yes.
fissure.
Yes.
This is the pterygomaxillary fissure. From here is the infratemporal fossa. From here is the pterygopalatine fossa. Okay.
Yes, sir.
Cat's paw do yaar.
Cat's paw is better there, I think. Canal knife usually for the ear purpose also you can use, sir.
Which one, sir?
Canal knife for the ear surgery.
Yeah. Population ready hai kya? Sir, any opinions? Any opinions?
Open and see. That's the only thing we are waiting for.
I am also very excited.
Yeah.
Give. No. Who is going to bet? Give some bet, boss. Blue. Will it be liquid or solid? Okay, I'll go for liquid. Who is going for solid?
We didn't get it. What is that?
No. How many people going for liquid tumor? How many going for solid tumor? Will I remove completely or not? You just get audience opinion. We will see who wins.
You will remove completely, sir.
No. You get audience opinion.
Audience.
Yes, sir. It's from the audience only.
Any takers from the audience? Your valuable inputs.
No, if it is solid, I will not. How will I remove? I cannot remove.
But as you said, one of the possibilities, as you said, if it is fungal, turns out to be fungal, we are lucky. We'll be lucky. Or else, if there is anything else, means definitely we'll take a biopsy and come out. That's all.
No, but what is the audience stall?
Almost all the audience are raised their hands for the total removal of the tumor, sir.
Oh,
yeah, this is not this one. This is from the audience only.
Okay, let us see.
Yes.
No, but if it is going to be friable, I will not remove.
Yes, sir.
Because we need a biopsy report. Before doing anything, we should need a biopsy report.
Yes, sir.
We can't just go and play with the patient. Suction. Okay, ready. We start. Population. What, man? Shilpi, what is your opinion, man? Shilpi. Come on, Shilpi. Come on. You can. Come on. Okay, ready. 1, 2, 3. It's like a James Bond suspense thriller.
Lateral open చేస్తున్నారు.
Will it be a suckable tumor? Suspense.
Suspense is breaking my head.
Thriller, suspense thriller it is, really. This wand is very good, aggressive. You are doing wonderful job with this. Dr. Jankiram is aggressive, so is the wand in his hand.
No, no. See, I don't simply recommend. You know me. Why should I recommend?
Yeah, I know.
I am not bothered.
Yeah, I know.
Okay, now I think, yeah, I think it's solid only. Let's see. Give me a scissors. More bonds could have bonds. Looks like solid tumor, man.
Solid tumor only?
Yeah.
Janki, why you had a doubt about liquid? MRI was not showing, which liquid tumors.
Sir, actually, sir, pituitary already will be a little this one, sir. I was hoping that it will be an invasive pituitary. Honestly, me and Shilpi both. Sir!
Oh, wow. Yeah. Open the Pandora box.
What a beauty.
It appears like pituitary.
Yes.
Yeah.
Pituitary.
Suckable, fragmented.
What man, Shilpi? Bloody shit.
The first time doing pituitary other than the pituitary process, sir. In the world, I think so far there was in many cases, first time pituitary away from the cella.
Yeah. No, sir, we have seen.
Yes,
we have seen.
Mostly there may be supracellular extension will be there, but it's almost away from the cella, sir. Far away from the cella.
Sir, what a case, huh?
Sir.
$1 billion case. Nobody expected, no?
Yes, sir. Thank you.
Except for the earlier surgery, history of earlier pituitary. That's the only thing. And another thing, why you told that he is blind also?
No, sixth nerve palsy. Tomorrow's case is blind.
Oh, yeah. Okay.
Yes, sir. Sir, this belong to this patient only, sir.
Why, sir? Suddenly you're asking like this.
Sir.
What is this? Very scary question. Shilpi, ultimate, man. Ultimate case.
Oh, extension thing. Dumbbell lage.
Is the dura here?
नहीं मैं पहले बायोप्सी लेकर आऊंगा उसके बाद I'll do it. I don't want to mess around. Suction. Take another biopsy. Give biopsy. Take it for biopsy, man. Hey, get it. You have microwave here. Irka. See, this is looking little fibrous. Hey. Biopsy, please. Biopsy. This is more of
both fibrous and liquid components, sir.
Yeah.
As for these cases, diffuse weighted images are the better scans for, sir.
What?
Diffuse weighted images, DWI.
No, but what DWI will show, sir, whether there is diffusion or no diffusion. If it is cellular, there will not be diffusion. If it is liquid, it will not be more diffusion. That's all. What is the big deal?
Yes.
That is not the point. The DWI more for trauma, all that. DWI cholesteatoma.
Sir.
What I'm going to do, sir? is I will come out with a biopsy. I'll plan suction. No, you said, hey, give me a counter sign a section too. See, I don't want to
Go ahead.
cause any this one. I have to plan for a pericranial and all. If there is this pituitary, then I have to plan for pericranial because I will show you why there's a big CSF space in the sphenoid, and I need to plan for a pericranial. Good. So I will not play around. So I should know. See, I always say a good surgeon knows how to operate, but an expert surgeon knows when to stop. So there is no point in me causing any. I know Nageshwar Rao Garu wants me to somehow demonstrate everything, but sorry,
Yes, sir.
you have to come another date for that.
Sir, you have asked different people opinion, but you have strong opinion that is a pituitary, sir. What
I was very sure, sir. I told Shilpi. Shilpi also told the same thing.
Yes, sir.
Shilpi told it is invasive pituitary. I am telling you. She told me.
Yes.
That is because we have seen cases like this.
Yes, sir.
But anyway, let the biopsy report come, then we will discuss about it. I am not going to. No blood, no blood. I am stopping. Pack it and come out. Sir, I am going to stop here
Yes, sir.
because I'll go to the scan now. I'm going to show you something very interesting. Hey, show me the scan, boss. Can you show me the scan? Hey, show me the scan, boss. See here. I'll show you something very interesting. Come here. Come. You come nearby. Oh, no, you can't come from there. You have to come here. You have to come here, boss. You have to come this side. Very important. See, this is where the real skull-based planning comes.
Yes.
Shuma, you cannot just go and operate. Hey, come here, boss. Come this side. Come behind me. See here. This is, boss, can you see?
Yes, sir.
Can you see the scan? No, not like that, boss. Come here, boss. See, this is,
Yes, sir.
this T1 with contrast.
Yes.
Okay, this one you have, see, variable intensity. It's not uniformly
sir.
homogeneous.
Yes, sir.
Okay, if it is variable, you have to think about pituitary or meningioma or things like that. But more importantly, why did I stop? You can ask me why I stopped. I
Yes.
removed this component. I stopped. I didn't take here.
Why is-
Reason is this. See, reason is this. See here.
Yes, sir.
This is the cella. You see what has happened here. Can you see the CSF?
Yes, sir.
Can you see this CSF? This CSF.
Yes. Meningocele or
Not meningocele. This is the dura, boss.
You're-
If I
yes, sir,
penetrate it,
but,
no. Patient will have high flow CSF leak. Then I have to plan for a cover. Or else
Yes.
patient will develop meningitis. That is why I stopped. I didn't go to the right side at all. Because now what I will do, if it comes as pituitary, I'll plan for a pericranial and then I'll remove all this and then I'll plan for a cover here.
Yes, sir.
Or else the patient will die of meningitis. See, this is all completely removed tumor by the previous neurosurgeon. Very nicely done.
Yes,
Only
sir.
in the
Sorry,
cavernous sinus.
sorry for the disturbance, sir. Dr. Kirtane, sir, came to the auditorium, sir. I'm just
Uyyo.
bringing to your notice.
Sir,
Professor
My
Kirtane,
guru-
sir, came to the auditorium just now.
my guru is here.
Yes, sir.
I'm so happy. Sir, namaskar. Welcome, sir.
Thank you very much. I'm happy to be here.
Sir,
Just waiting to see the magic happen now. Please go ahead.
no, magic over. That's all finished. No magic, no, nothing. Over, sir. Actually, it's a very interesting case. Come nearer. So, this is a level where there is a dura and they're full of CSF. So,
One
if
more
I go-
senior guest, Dr. Haldipur, sir, also came to the auditorium, sir.
Oh, fantastic, Dr. Haldipur, sir. Welcome, sir. Welcome. So sweet, sir.
வணக்கம் அண்ணா
வணக்கம் அண்ணா கேபி of ENT அண்ணா வணக்கம்ண்ணா
இப்போ இந்த சர்ஜிக்கல் லுங்கி டான்ஸ் பாக்குறேன் இப்போ
super. So I am going to stop here because I just removed it. I didn't want to go to the right side at all. And I will plan for the proper surgery only after I get the report. If it's going to be a pituitary, as I suspect strongly, this is going to be a pituitary, with involving the infratemporal fossa, pterygoparietal fossa, and the nasopharynx going into the cavernous sinus, then I'll plan for a pericranial flap and then do it. So I hope the neurosurgeon who is watching from NIMAMS will agree with me. So I call it a day. I will come back with a biopsy report and let you know about it. Thank you very much, sir.
Thank you very much, sir, for your wonderful experience of this very bad case. It's
Very, very
special
rare.
case, very special case to us, and surprising case. I thought you will go ahead, but
Sir, you want me to get into trouble? Ah?
no, sir.
You are a dangerous person.
We know your capacity, but there is no time. That's
What you
No,
said
not
is
for time. Not for time. We have to plan for reconstruction before we remove. Very, very important. And we have to plan for a pericranial now in this case. There is no hadad. You saw the whole nose is completely stenosed and the synechiae. You saw the pre-op how it was. So I have to plan for a proper reconstruction before I touch this patient.
Yes, sir. Dr. Janki, what you said is 100% right, that our expert knows when to stop.
Exactly.
Yes, we should know when to stop. This the right decision you have taken, and let's wait for the biopsy report, then we can complete the job. Yeah, that's very good aspect of it. Should
Thank
not
you,
get
Kishore,
tempted.
sir.
Thank you. Thank you.
Thank you, sir. I'll be there to
Yeah,
join the professors. Yeah, I'll be there, sir. Thank you.
Thanks for all the feast, great feast. We had surgical feast, the day one. Look forward for the more exciting day two tomorrow.
Sure, sir. Sure, sir.
Thank
Sure,
you.
sir.
Thanks a lot.
I hope you'll be there for the gala dinner.
Yeah, sure. Definitely. We will be there.
Yeah.
Yeah.
Thank you, sir.
Yeah.
Thank you so much, sir. Thank you so much, audience. And with this, yeah. So we will be taking a break for half an hour.
How did you
At 7 o'clock, there will be two post-graduation case presentations. And at 7:30, we will have oration, felicitation, and further programs. So thank you so much, audience, for being patient throughout the day. And we'll meet at 7 o'clock again. Thank you.
Good evening. Sir, good evening. You got three, sir? Sure, sir. Then I'm in the call only. As soon as you reach me, get come out. Sure, sir. Sure. Thank you so much. Okay.
वो लैपटॉप है विक्रम वो बाहर का है ना
वो बाहर का लैपटॉप है
वो बाहर का
वो लैपटॉप है
वो कार का लैपटॉप है ये
for her. The treatment will go next. Next is there, huh? She's a postgraduate. So sir, the management is also there next. Management is there next.
Open for discussion.
If we can.
So why you are thinking of inflammatory polyp as a first differential diagnosis?
So there was a history of chronic ear discharge previously, and then patient had an intracranial complication for which she had a craniectomy done, and she was having a chronic ear discharge since 12 years. So could be a inflammatory recurrent cholesteatoma with an inflammatory polyp.
And how will you exclude cholesteatoma?
Like on CT scan, there will be bony erosions.
The
seen.
history and examination.
So there
The
is
history
a,
and examination only you came to this differential
yes, sir. This is a
diagnosis.
persistent otorrhea which was not responding to antibiotics, sir.
What was
And-
the diagnosis in the first surgery?
So
Was it,
actually past records were not available, sir. So according to the past history, it was indicating a complicated CSOM with an intracranial complications.
why osteoma?
Osteoma also it similarly presents as an EAC polyp, but the patient will be having a pain, giddiness or tinnitus, which was absent in these cases.
No, osteoma won't present
And,
with pain, giddiness.
And hard, it would be hard on palpation.
Malignant otitis externa.
Malignant otitis externa, actually, the patient presented with an oral polyp, but in this patient, there was no immunocompromised state. The patient didn't have any nocturnal otalgia. So,
Very nicely explained everything. So above two things are the commonest of things which can happen, and the rest are all they are quite rare. So I think this is sufficient. You can proceed further. Next.
yes, further.
How did you proceed with the management?
Yes, next. Specific investigations were done. Oral swab was taken for pus and culture sensitivity, which revealed no growth. General oral dry mopping was done, and a course of broad spectrum antibiotics was started with local application of antibiotic steroid drops, and a pure tone audiometry was done. Pure tone audiometry revealed moderate conductive hearing loss with a 48.75 decibel loss on left side and 22.5 decibel on right side. HRCT temporal cones was done. The CT scan revealed a soft tissue density involving the left external auditory canal, middle mastoid cavity, additus and the eustachian tube, and the left tympanic membrane and ossicles were not visualized. A post-op status of left craniectomy was noted. MRI brain with contrast revealed an ill-defined T1 or flared hypo and T2 hyperintensities with no restriction on diffusion-weighted images in the left cerebellar hemisphere, which was suggestive of encephalomalacia with gliosis.
Excuse me. Before investigating, before getting the CT scan and MRI done, how could you come to a diagnosis of cholesteatoma or osteoma? You say the tympanic membrane not visualized.
Yes, sir.
The whole thing was filled with a polyp.
Yes, sir.
Now, how did you come to a diagnosis of cholesteatoma, osteoma?
Sir, there's a previous history of complicated CSOM with an intracranial complication. We thought that it might be an recurrent cholesteatoma with a polyp presentation.
What made you to think as an osteoma? Osteoma will never present like this.
It is one of the differential diagnoses she thought of with the history and examinations.
See, she's final year residentship. She's presenting this case, and we also remember our days during our MS time, and we had to face only 2 externals. There are 200 externals here, so we have 200 externals here. So we have to think accordingly, sympathetically. So I'll request the audience to please let her proceed with all these things. We know we cannot question her like that because yeah, she's getting to it, and I think I think everybody's got the message. So we also remember our days during when we were residents and we were poked by these questions by our seniors. So please proceed further. I think I think the audience also agrees with me. Thank you so much.
Differential diagnosis. You can proceed. You can proceed.
Thank you, sir. And T2 hyperintensity fluid signals were noted in the left mastoid cavity. This is the image on left side with a mastoid cavity filled with a cholesteatoma. And on the right side is a post-contrast MRI with a non-enhancing cholesteatoma in the mastoid cavity with an enhancing polyp in the EAC. This is the coronal section of MRI showing polyp enhancement. And on the right side is an apparent diffusion image with a cholesteatoma showing diffusion restriction. After blood investigations, according to the hospital protocol, a revision mastoidectomy was planned under GA. Under aseptic precautions, local infiltration was given in the post-auricular region with 1% lignocaine with 1 lakh adrenaline, and a post-oral Weil's incision was given. Temporalis fascia graft was harvested, and the incision was deepened and a posterior based periosteal flap was elevated. Intraoperatively, we found a mastoid cavity filled with a cholesteatoma with a foreign body stick in situ. It was a wooden stick measuring about 0.5 to 1 centimeter. And there was a pink polyp of around 1.2 into 0.7 noted in the mastoid cavity, which extended into the external aortic canal with a pedicle attached to the tympanic mucosa and the eustachian tube. Post-op status of canal wall down mastoidectomy was noted. New bone ossification was noted, and hypertrophic mucosa was seen in the mastoid cavity, middle ear, and on the promontory and eustachian tube, and which was removed. Ossicles were absent.
Well, sir, first of all, welcome to the premises. And because people have been waiting for so long to hear Mr. Azharuddin, so can you take some moment out and talk to our people for once? Yes, over to you.
Respected doctors, Dr. Saab, Min Saab. I mean, nice to be in the company of another Padma Shri awardee. I was also awarded a long time back. So I'm actually, first of all, I must apologize for being in tracksuit and pant because I was at the ground because we had a practice game for the senior team. So I was watching that, but I could not go home. If I had gone home, then I would be very, very late for this function because of the traffic snarl. So I just came right straight away. I mean, right from the ground, I came here. So I'm very happy to be here. And I think it's a very unique thing, you know, when they came and met me, I think day before yesterday or something like that. Yeah. And they said, okay, this function was there. But actually, I was supposed to travel in the night to Delhi. But because of Balaji here, you know, my uh, very, like, he's like a brother, you know, whenever, so he requested me that this is the first thing he asked from me. He has never asked me anything. So he said, okay, Darba, you have to come. So, I mean, I'm here. I think he needs more applause than me because he's the one who's got me here. And I think I'm sure you all would have had a very, very productive day and very, very busy day. I hope there are a lot of things which have happened. You know, there's some open surgeries were happening. So I was very happy because I'm a novice in medicine, but one of my grandfather was a cardiologist. It's a long back. He was a personal physician to the king of Saudi Arabia, King Khalid, during those times. So that's the only thing I think we have in our family as a doctor. But my nephew also become a doctor now. So I mean, I was always I was fascinated by the way the medicine, I mean, the medical thing has gone up. You know, there's so many new techniques have come, so many new surgeries have come. Because I was just thinking, somebody was telling me that, I mean, you play the flick very well. So I was just thinking that, you know, even the doctors, I mean, they have flick is a very difficult shot. So I think with the doctors also, I think when they do those operations, it's not easy. It must be very, very difficult. So I was just wondering how difficult it would be for them to do the operation. But I think in any profession, you know, if you really work hard, if you are willing to put in your hours and willing to learn, because everybody is learning all the time. Nobody is perfect, you know, because the world, when you come in the world, you always learn. Nobody is perfect. So we can learn from different profession as well. It's basically more. One thing is very clear is that, you know, if you work hard, you will get all the results. So I think, I mean, all people are here are very professional. I'm sure you would have put in a lot of hard work, you know, studying. I mean, I was fortunate that I was I was given skill in cricket, so I really worked very hard in that skill. And I think it's mostly the important. The first and foremost thing, if you really want to succeed in any profession, is if you have the skill and you have to. Once you have the skill, then you can work very hard. You know, because with the medicine, you have to have interest, and then have. I mean, some are very naturally talented. Some have to really work hard. So it goes in every profession. But I'm very happy that today I was able to come here and be with the elite doctors who are present here and who have done a lot of operations, have done a lot of, they have saved a lot of lives actually, to be very, very honest, I'm sure. I mean, I don't need to say that, but that's how it is, you know, because my uncle also, my father's younger brother also is a general surgeon, lives in New Jersey. So I was visiting New Jersey one time. He was so busy. I mean, I never saw him. I was in the house for 3 days. I couldn't meet him for 3 days. Whenever he used to come, I was sleeping. Whenever he was out, I was sleeping. So this thing happened. So when I asked him, Chajan, I mean, I could not meet you for 3 days. What is it? He told me that my job is more important than anybody else because my job requires, it's a patient, you have to save the life of the patient. So that's how it is. You know, I really admire the way the doctors have really, work very hard. And I know sometimes it's tough, you know, people expect the doctors, every patient expects the doctor to make him all right, but sometimes things don't happen the way you want to happen. But you all try your best, everybody tries their best. But I'm very happy and very fortunate enough to be here tonight in this August company. And with the medicine, I will not be able to say much. But if you have any questions to ask, I mean, I'm here for another 5-7 minutes. I'll be very happy to answer them. But don't ask me tough questions. Thank you very much for calling me here. Thank you.
Thank you very much, sir. With this, I request you to kindly take your seat. Well, ladies and gentlemen, once again, a very, very good evening to everyone who all are present out here, taken the time out and been here with us since morning. Of course, at the same time, we are going to be doing the proceedings. I would like to call our cluster head, Sun Farmer, Mr. Nitish Srivastava. Can we please have you here on stage, sir? With a huge round of applause, ladies and gentlemen. Now, I would like to call Mr. Amit Shukla. He's a SBU Health of Sun Farmer. Welcome, sir. Welcome to the premises. Followed by, can you please request Dr. Deepak Haldipur to kindly come and join us on stage. With a huge round of applause, ladies and gentlemen, come on. Thank you. Followed by Dr. Madhuri Mehta. Can you please have you here on stage, ma'am? And now I would like to call Dr. Sudarshan Reddy to kindly come and join us on stage. Also, I would like to call Dr. Mohan Reddy. Can you please have you here on stage, sir? And now I would like to go with the flow of the felicitation to all the honorable dignitaries on stage. I would like to request Mr. Nitish Srivastava to kindly do the felicitation of Mr. Kirtane. Can you please do the needful and get the shawl on stage? Well, also we are in South and there's a beautiful tradition where we do the honor by something really picky and choosy. So I would like to request sir to kindly do the honor. Yes, please. Come on, everyone. Can we expect a huge round of applause? With this, I would like to request Mr. Deepak Haldipur, sir, to kindly be here. And I request Mr. Amit Shukla to kindly do the needful and honor Mr. Deepak. Yes, please. Mr. Deepak. With this, the only lady right here on stage, ma'am. Yes, please, Madhuri ma'am, I request Azhar sir to kindly do the needful and honor. Thank you so much, Azhar sir. Well, yes, with this, I would like to request Sudarshan Reddy sir to kindly be here, and may I request Dr. Nitish Srivastava to kindly do the honors with the token of gesture. Well, with this, I request Mohan Reddy sir to kindly be here. And I request Amit Shukla sir to kindly do the needful and honor Mr. Very much, gentlemen. Thank you. And now I request all the panelists to kindly come and join us on stage. I would like to start with Mr. Pradeep Chaure. Can you please have you here on stage? And I request Mr. Milan Ketunet sir to kindly honor Mr. Pradeep Chaure. Yes, please. Thank you very much. Well, with this, ladies and gentlemen, I would like to call Mr. PJ Mandal. Can we please have you here on stage? With your thunderous round of applause, ladies and gentlemen, please welcome Mr. PJ Mandal. I request Azharuddin sir PJ Mandal. Ladies and gentlemen, let's pump it up. Thank you. And now I request Mr. Venkateshwar Rao to kindly come and join us on stage. Dr. Sankat Kumar to kindly come and join us on stage. Dr. Kendra Devi to kindly come and join us. With this, I would like to request Dr. P.R. Savin, can you please have you get on stage? Followed by Dr. Sridhar Reddy. request to kindly do the needful by honoring Dr. Betty. With this, ladies and gentlemen, let's pump it up. Let's give a huge I request Dr. Vanilla to kindly come. Doctor. This young to come and join us on stage. Yes. So when we sing to kindly come and join us on stage, do the honors of all of Dr. Mohan Bedi. Dr. P. Nageshwar Rao. Dr. G. Xiang. Right, so I can see not many people around have been here since morning. But of course, let's gather some huge claps and let's give it up for all the doctors who have been doing wonderful, wonderful work. With this, I request Dr. Bhupendra Rathore to kindly come and join us on stage. By Dr. Shri Prakash, can we please have you here on stage? Dr. Bhargav Jadhav, can you please have you on stage? Come on, ladies and gentlemen, let's come with Dr. Venkat Ravi Reddy to kindly come and join us on stage. Have you put on stage? Dr. G.V.S. Rao, can you please have you here on stage? By Dr. Ravi Agarwal, can you please have you here on stage? By Dr. Prashant Kumar Basu, can you please have you here on stage? Dr. Sri Dayala, can you please have you here on stage? Followed by Dr. Vishnu. Dr. Vishnu Gagan Begri, I request Dr. come and join us on stage. Dr. Y. Maunika Reddy, can you please have us here on stage, ma'am? Thank you very much to all the guests and the doctors. I request all of you to kindly take your seats. We are also waiting for one more person, a very, very important dignitary to be here with us and enhance the beauty of the evening. So without further ado, I would like to request Dr. Keertane sir to kindly say a few words. So sir, can I request you to kindly take it over and आपकी तरफ से कुछ बातें. जी हाँ.
Yeah, I mean, you have caught me by surprise, and I'm at a loss of words. Big fan. And I'll just take off from a little comparison that he made between how cricketers have to work hard, how sportsmen have to work hard, and have doctors also have to work hard to reach where they are. And he talked about new operations that we have to learn to offer to our patients. Watching today's cricket matches, there are new strokes which you have to learn, which were not there when you were playing cricket over there. I mean, some of the most amazing and audacious shots that you see of fast bowlers, it's amazing. I mean, he was always the master of the flick to the leg. I mean, we used to love to watch it. When is he going to play that shot? Huh? And there's another thing which he said, which makes a lot of sense. He said that every patient who comes to you expects you to make him completely all right. But you know and I know that no two patients behave the same. Every time Azharuddin came to the crease, we expected him to score 100.
Yes, yes.
But it didn't always happen.
Yes.
Yes. But and that he set the trend. So we said first 3 matches, so every time he comes, it's got to be 100. But it doesn't always happen. The same thing people have to realize happens with patients. You do the same operation on 2 people. One responds very well, one doesn't. So I think one common thread over here, he told us about his family members who were doctors. I don't have any family members who are cricketers, but I did have the privilege of being in the same school and playing along with Sunil Gavaskar.
Very nice.
Yeah, so he was 3 years behind me in school. So for Harris Shield and Guy Shield, we used to play together in Xavier's College. But that is the only claim to fame as far as cricket I can have. But one thing that becomes very clear, we as doctors know how hard we have to work to train ourselves to reach where you do. When we see these cricketers enjoying all the adulation that they get, and we say, what lucky fellows. But you have to realize that the amount of training, hard work, and I can use the word over here, sacrifices that they have to make to reach that top level and to remain at that top level is amazing. The amount of fitness that they require to keep up to is absolutely amazing. So, sir, hats off to you. And thank you for taking your time off.
Always, man.
God bless.
Thank you very much, sir. So yes, sir, now I would like to request Deepak sir to kindly do the needful, and the mic is over to you.
I was the one who told about the flick, but not the flick. If you remember Azhar, when he would stand in the leg slip or in the slips, if the ball went a little past him, he would turn with his back to the wickets and he would catch it and flick it onto the stumps. I think a lot of you have seen it, you remember it. It was his trademark thing. Second, Azharuddin, probably for me, you see cricket before that, the fitness of Indian cricketers and the fielding was pathetic. He was at watershed point where one thing was fitness, and second, I remember him for his running between the wickets. And if he was there for 1 hour, it was 30 runs assured. He would keep on flicking, running here, there, everywhere.